Shalini, you may start.
Mahima, shall we start?
Yeah.
Okay. So a very good morning, afternoon, evening to everyone who's logged in from all parts of the world today for this 9th annual but virtual International Symposium in Diabetes, which we are organizing jointly with AASD and DIPSI. So for people who've tuned in for our symposium for the first time, a small brief CMRE or Consortium for Medical Research and Education is basically a platform jointly hosted by me, Dr. Shalini Jaggi, and Dr. Rajiv Chawla, both of us from New Delhi, India, basically to enhance medical education, update on what is the latest, because I think as practitioners, as clinicians, it is very important for all of us to update ourselves on the latest in the field of medicine, diabetology, so as to cater to our patients, offer them the best, the latest of services, of knowledge that is available to improve the quality of life of our patients. So we've been doing this for the last 9 years. This happens to be the 9th annual symposium. And next year, I promise you, the 10th symposium is going to be a physical event where all of us will be meeting face to face for the grand event. This was supposed to be a hybrid event as well, but due to some unforeseen circumstances, we had to make it virtual. But I promise you, the science remains excellent as always. We bring you the very best happening all over the world in the field of diabetes with a star of star faculties, a whole lineup of great faculties from all corners of the world who will share their expertise and their knowledge with us. And I welcome all the delegates on behalf of everybody from CMRE, from AAST, and from DIPSI. You are welcome to participate in the symposium. I'm sure there is a questions column where you can actively post your questions, and we will be taking up all the questions in the discussions where our faculties can interact, listen to your queries, and answer them well. So without much ado, let's start this inaugural, and I welcome my partner, my colleague, my senior, Dr. Rajiv Chawla, to say a few words of welcome.
Thank you, Dr. Shalini. Good afternoon, everyone. Dignitaries on virtual dais, Professor Inas, Professor Mohammed, Professor Vinod Kumar, Dr. Shalini, Dr. Vipul, and entire team. It's my pleasant duty to welcome you all, not only to the organizing committee, to all the faculties, those who have already logged in, to all the delegates, those who have logged in for CMRE ASD 9th International Symposium in Diabetes, which is a virtual one this year. This is 9th in sequence, and I'm really extremely excited and happy to share that with ASD, this is 3rd in sequence. Professor Inas and Professor Mohammed have been kind enough to partner with us. And for last 3 years, we not only organized 3 international symposium. In between this year, we also had East meets West, where we could exchange a lot of knowledge and expertise from different zones. As Dr. Shalini very rightly said, the vision and mission of CMRE has been to promote continued medical education, to impart training for upgradation of knowledge and skills for all medical professionals and healthcare providers, more so in the field of diabetes and endocrinology. We provide a platform for exchange of new ideas, knowledge amongst medical and other healthcare professionals on the latest developments which have been happening by organizing these workshops and symposia, and give them a chance to interact with our expert national and international faculty. Again, it gives me proud to share that this year we have engaged 11 international faculties whom we will be able to learn from over next 1.5 days. And we have more than 50 national KOLs, those who are in the field of diabetes and endocrinology, those who are going to give you not only their presentation, they are going to share their expertise and their views and final carry-on message for the benefits of all the delegates, those who have logged in. And since we have partnered with ASD and Professor Mohammed, who is also DAR President, Diabetes and Ramadan President, we have come a long way over the last 3 to 4 years. We have been able to break those barriers and boundaries through our joint partnership by reaching out to all different ethnicities. And again, I'm happy this year also we have almost registered more than 5,000 delegates, and we have been also able to reach to an international delegate and membership of ASD, Emirates Diabetes Society, and we have also been able to reach to Southeast Asia, Egypt, also to part of UK and US. So I'm sure all those delegates, those who are going to hear to all these international experts in the field of diabetes and endocrinology will be much wiser over this 1.5 day. Of course, it's a very, very tight program, but I can promise you that Monday onwards, when you go back to your own chambers, you will be much more enlightened and you'll be able to rationalize your practice in a much better, much scientific, rational way for the, of course, for the benefits of all your patients and larger society. With those few words, I'll now request Professor Inas Sheltout. She is ASD President, to say a few words of encouragement and give her blessings to this program. Professor Inas.
Thank you very much, Professor, and welcome to the International Symposium in Diabetes. And on behalf of the board and members of the Arabic Association for the Study of Diabetes and Metabolism, we appreciate the cooperation with the CMRE for medical research and education for the very, very successful cooperation and well-prepared scientific virtual events. Each of them was having thousands of delegates, and feedback from attendees was excellent indeed. Today we are having a very important agenda talking about the recent EASD ADA guidelines, which was published very recently, and we are having eminent speakers and thousands of delegates. And let me thank Professor Rajiv Shaula, Director of CMRE, and Professor Shalini, Director of CMRE, for their fruitful cooperation, and Dr. Colin Diane, Head of Endocrinology in Cardiff University. And also we are having Professor Muhammad Hassanin, Chair of DAR Alliance, and speakers from ASD Egypt, Professor Muhammad Naguib, Professor of Internal Medicine and GIT from Cairo University, my colleague, and Professor Hisham Magdeddin. He's a professor of endocrinology in Cairo University, among very eminent other speakers from the whole world. Thank you very much for this important cooperation, and looking forward for more cooperation in the future. Thank you.
Thank you so much, ma'am, for your kind words. I now welcome Professor Mohammad Hasnan, who has been our friend, our mentor, our guide all through this journey of CMRE for the last 9 years of our existence, to say a few words on the partnership, the alliance, and the future.
Thank you very much. It's a great pleasure to be with you guys. Unfortunately, it's virtual. Our collaboration started many years back when I was leading the international activities of Cardiff University, and being partnered with India is such a fruitful partnership because of the wealth of experience and hunger for education that one experienced there. Now we have a different angle for it for the last number of years, where we managed to join two important cultures and heritage of medical as well as other aspects between Egypt and India in the form of the AASD, as well as the beautiful collaborations with yourself, the CMRE group. Not only with this, but obviously with our large group of friends from India, Egypt, UK, and across the globe. I look forward to this to flourish even more and to be even more and more structured, and to even develop research activities so that in the future, in these meetings, we can present our joint data. I'm sure that the rich program that we have today will help so many people across the two countries and beyond in their everyday practice and I certainly will enjoy the agenda. Thank you for preparing it, and thank you for all the hard work for yourself, Professor Rajiv Chawla, and Shalini Jaggi, and all the colleagues from India.
Thank you, Professor Mohammed. Unfortunately, we couldn't get Professor Colin, who is a part of organizing committee. He couldn't just now join, but I must put it on record. The entire contribution done from the Cardiff University early days when we were growing along with Mohammed, Dr. Richard, Dr. Neera, and Professor Colin, who made this program very, very popular in this part of the world. So, of course, his good wishes and blessings are always with us. Shortly, he'll be joining. I'll request Professor Vinod Kumar just to say a few words to give his blessings.
Thank you. Thank you very much, Dr. Chawla. And I'm delighted to be amongst the luminaries, international luminaries on this program. Personally, I have been attending your course, CMRE, for a few years. You have always been very kind to invite me and engage me and give the opportunity. And I have all my best wishes for a very successful program, as it has been in the previous year, and even more. Thank you very much.
Thank you, sir. Thanks a lot for your blessings. Professor Vinod Kumar, just to introduce, is the senior most endocrinologist in this country, maybe practicing today. And he has been like a mentor and father to all of us. And he is also, fortunately, now RSSDA patron also. And years along, we have been together and we have been seeking his blessings. Over to you, Dr. Shalini, to start the program.
So thank you so much. I think we are all God-fearing human beings, and I'm sure any event has to have blessings of God Almighty for a successful and seamless conduct. So I'll request RX teams to just invoke the God with a small 2 minutes recording of God's blessings and prayers. We'll have the Saraswati Valan.
Vakratunda Mahakaya Suryakoti Samaprabha Nirvignam Kuru Me Deva Sarvakaryeshu Sarvada.
So I think with that, let's set the ball rolling. It's going to be a 2 days scientific feast for everyone who's interested in updating themselves on different aspects of diabetes. The scientific program has been well planned by the scientific committee, comprising Dr. Colin Dayan, Dr. Mohammed Hasnan, Dr. Inas, Dr. Rajiv Chawla, and myself. And we've tried to address each and every aspect of diabetes or its associated comorbidities, complications, which pertain to our day-to-day care when it involves looking at patients with diabetes, because it's not only the disease that we treat, but the whole idea is to improve the quality of life and offer the best to our patients. So with that, let us start the program. The first symposium is a very, very important symposium, symbolic of the partnership that we share, the camaraderie that we share with AASD. And to host this AASD CMRE joint symposium, to chair this symposium, we have Professor Vinod Kumar sir with us. Like Dr. Chawla introduced, a very, very respected, very senior consultant physician and former professor of medicine, AIIMS, New Delhi, professor and HOD endocrinology, PGI, Chandigarh. Sir is respected RSSDI patron as well. And it's an honor to have Dr. Vinod Kumar as a chair in this very, very important symposium here. So I'll request Dr. Vinod Kumar to introduce our faculties, Dr. Hasnan and Dr. Inas Chaltaut.
Well, thank you, Dr. Shalini. I'm very proud and privileged to chair this session in which we have the speakers both from India as well as from other countries. And we have very senior diabetologists, and I'm very happy. I think Dr. Professor Hossain and Professor Chaltaut are already well known to all of us. At least to me, they are very well known. I have been listening to their lectures in the past also. Dr. Hussain comes from UAE, and Dr. Hertz comes from Cairo. With this, I would request Professor Mohammad Hussain to kindly give his lecture, followed by Professor Sheltout on the same topic, which is an exciting topic. And particularly, I would be looking forward how these guidelines are applicable to different regions. And that is the, I think, focus of their presentations. Thank you very much. Professor Hussain, please.
Thank you very much for the kind introduction. Just as a point of clarification, I work in Dubai, a very lovely city and a lovely country, UAE, but I come from Egypt, Alexandria. So just for a slight clarification. So let me just get this correct scene. Yeah, I hope you all see my screen now. So for this important first session, it's related to the joint American Diabetes Association and the European Association for Study of Diabetes consensus on management of diabetes. And specifically, I would cover the first part on the hyperglycemia section. So when we look into this important document, first we have to understand it's a consensus report. It's a very comprehensive consensus report with nearly 350 references, where the authors have gone thoroughly through the processes and came to this consensus report. But at the end of the day, it's not a protocol, it's not a guideline, and we can certainly look into areas that maybe for our own clinical experience or environment, we might vary. We will not vary in the focus, surely anywhere in the globe, that we have to think of these crucial 4 points: glycemic management, cardiorenal protection with glucose-lowering agents, weight management, and cardiovascular risk factors management. These nowadays are very important points. And of course, the glycemic management is a very important one. I'm delighted that in the narrative of their presentation, they started with glycemic control. The reason I see this is crucial, slight diversion, because in our Eastern cultures, we have many people with diabetes in early age. And consequently, cardiovascular and renal problems perhaps happen a bit later in their life. But glycemic control is a crucial factor, as we know from DCCT and from UKPDS, a crucial factor for all diabetes-related complications, specifically for the vital muscular complications. And of course, with strong hints for macrovascular complications as well. And with this, they stress upon the importance of thinking of behavioral approaches, metabolic surgery, as well as medication in the glycemic management, and not just to focus on one of these aspects. They stressed upon the weight issue, which I'm sure in our communities is really quite important. And they're not talking here about any weight reduction, talking about a minimum of 5% with a stress upon 10 to 15% could lead to even remission of diabetes, as well as extra benefit beyond the glycemic management, specifically for the cardiometabolic disease and for quality of life. So with having the person with diabetes at the center of care, we need to think in any person with us with diabetes on these key aspects to assess the characteristics of the individual, consider specific factors, utilize the shared care decision and agree a management plan and implement the plan to eventually have a monitoring process and review this plan on a regular basis as well. So when you think of diabetes, the top priority is self-management, education, and support. This is crucial, and we have to embrace diabetes self-management education and support as being a crucial part of the diabetes care as much as pharmacotherapy. And obviously, we have to identify and know how to access these resources. Unfortunately, in many of our communities, this is one of the key areas that is lacking. And of course, we have to make the person with diabetes understand the importance of this and getting a holistic approach for all the aspects together. And initiate the self-management and update it and renew it on a regular basis according to the person's social as well as medical aspects and life support. They also stress upon an important point that is unfortunate reality in many cases, which is clinicians' inertia. We end up with giving soft excuses, overestimation of the care provided, and we do not provide enough education, training, or practice organization to overcome these issues. So weight management, when it comes in the guidelines, is because we now have available therapy in the format of GLP-1 receptor agonists, as well as the combination of GLP-GIP that can reduce the weight of a person with diabetes in the studies that were done by a figure that is equivalent to what we see sometimes in metabolic surgery. We are talking here about 13% of the body weight of the individual reaching over 12 kilograms of the person weight. Of course, this is important to think of because bariatric surgery or metabolic surgery has been shown for up to 10 years to reduce the weight loss of the individual up to 30%, while medical therapy was not able in the past to sustain weight loss. And we see in many cases, people achieve a target and then they bound back to where they started. But with metabolic surgery, the situation is different. Having said that, the available therapy now, as I mentioned, has been very important. But before we think of therapy for weight management, they have stressed upon, we need first to set realistic targets and goals, and then provide the person, not just with, you need to lose weight, or you need to change your diet, or you need to do physical activity. We need to provide them with evidence-based, structured weight management program. And this is really quite important. Now, failing this or not achieving the goals, then we need to think of the added option of the pharmacotherapy or the metabolic surgery. And when we choose a drug for diet glycemic control, we need to choose a drug that also have a dual effect of not just the glycemic control, but weight efficacy that is crucial for this. And with this, they step out to spell what is the difference between what physical activity I can do while I'm sitting or stepping, or the quality of the exercise to make me sweat, or even strengthening the muscles exercise, so the type of exercise. I don't have the time to go through all of these aspects, but they are very important, and I advise all the colleagues to read them in depth. They also talk about sleep time, sleep quality, and the timing of the sleep. Nowadays, we see in many cultures, people are going to bed very late at night and sleep and waking up late. And they've looked into the sleep pattern, which is better, and certainly the classic early sleep and early rise is far much better for your health. So when it comes to the glycemic management of people with type 2 diabetes, we now have this beautiful renewed algorithm. The right-hand side of it is related to the weight management, which I've already discussed with you. But the left-hand side is talking about glycemic improvement. I'll go back to this because it has classified the type of agent that we use and talked even about combination therapy to start with, and not necessarily metformin for all. Metformin traditionally is the recommended first-line glucose-lowering therapy because of its high efficacy in lowering HbA1c, because of its rare hypoglycemia, and of course, because of its potential for some modest weight loss and perfect safety and very, very cost effectiveness. And they look obviously for every drug on their impact on the kidney and on the heart. And with all of this, we do not have anything negative about metformin. So certainly it's one of the important drugs. For sulfonylurea, there's been an important shift in recognition that not all sulfonylureas are the same, that they are highly efficacious when it comes to glucose lowering. They are inexpensive and accessible to many, and they are not all the same. They are not a heterogeneous group. And hence, we need to think of the more modern sulfonylurea with lower risk of hypoglycemia or impact on weight, especially knowing that they are neutral when it comes to impact on heart or kidney. So TZDs have been, in my opinion, massively ignored as an important tool, specifically for our cultures where the phenotype of so many of our people with diabetes includes significant insulin resistance. And that's why they have stressed upon here the importance of the high efficacy of TZDs, the fact that they have no hypoglycemia, and the potential benefit on the cardiac, as well as, of course, their effect on NASH. There is weight gain as a side effect and fluid retention, and hence optimizing their therapy by maybe utilizing a smaller dose or the combination with other drugs such as SGLT2 would minimize these issues. DP4 inhibitors have been with us for some time, and they stress upon their benefits of being intermediate in efficacy with no hypoglycemia, neutral on weight, and neutral on other cardiovascular or renal risks. And the early combination that's been shown with some of the earlier studies, specifically with the study of vildagliptin, has changed people's mind in the stepwise approach to change from monotherapy to perhaps dual therapy when required. SGLT2 inhibitors will be covered thoroughly, as well as GLP-1 in the cardiovascular aspects, but we all know about this newcomer, about their efficacy that ranges from intermediate to high, about the lack of hypoglycemia, the weight loss, and the extensive studies on benefit for cardiovascular or renal outcome. GLP-1s are...
Alert from low battery.
I'm sorry, let me just fix my battery for my presentation. I think that's fixed now. So GLP-1s, of course, they have a high level of efficacy with low hypos and weight loss, and with evidence of benefit for the cardiovascular aspect, as well as for renal aspects as well. Now we have oral, we have injectable, and cost, of course, is an issue in many of our communities, but we should not ignore such an important class of drugs, as we have a sizable proportion of people who could benefit from this. There's a new options, as I mentioned, that there is oral semaglutide, and there is the higher doses of GLP-1s in some studies with benefits such as dulaglutide higher dose and higher doses of semaglutide, showing benefits on both glycemic efficacy and weight management to a level that we have not seen with the traditional doses. But we also have the newcomer that is available for us in UAE here, as well as for the USA, of the combination of the GLP-1 with the GIP tirzepatide, with very high levels of reduction of glycemic hyperglycemia, as well as weight reduction. So we now have a much bigger options for treatment, and this single peptide has been remarkable from the point of efficacy for glycemia as well as for weight, with no risk of hypoglycemia or rare risk of hypoglycemia. The ongoing studies for cardiovascular trials hopefully are going to show us results in the near future so that we can judge their safety on cardiac and renal aspects. Of course, insulin is a crucial tool for us. because insulin is the only drug in our arsenal of choices that has no limit to glycemic lowering. We know, of course, that insulin has moved thoroughly from the days that it was simple insulin to now the more sophisticated molecule that has lower levels of hypoglycemia compared to the past and lower levels of weight gain compared to the past. However, these 2 points are still important points to be careful with when we initiate or intensify insulin therapy. Insulin is neutral when it comes to cardiorenal profile, and that's important as well to remember. The guidelines, the recent consensus rather than guidelines, stress upon the importance of considering combination therapy. Why? To increase durability of glycemic effect, potential to address the therapeutic inertia, the simultaneous targeting of multiple pathophysiological processes characterized by the type of type 2 diabetes, the potential impact on medication burden, adherence, and treatment resistance, and of course, the complementary clinical benefits of the different classes of drugs that could be combined in a single tablet or when you combine with your patient. So again, they stress upon here the importance of thinking of efficacy, and they have stressed upon we have drugs with very high efficacy, such as dulaglutide, high dose, semaglutide, tirzepatide, or insulin. Indeed, among this is the oral combination or the combination of a GLP-1 with insulin. Following that, there are drugs with the high efficacy, which are the GLP-1s not listed above, metformin, SGL2, sulfonylurea, and TZDs, and the intermediate efficacy of the DP4 inhibitors. When it comes to insulin initiation, they of course say consider a GLP-1 first. But if you already started your patient on a GLP-1 or it's not feasible to do so, then consider basal insulin and then add a mealtime in other types of insulin if required. I do not necessarily agree with this approach. I feel we need to personalize the insulin based on the profile of the individual. Sometimes you will start at basal, sometimes you will start a different type of insulin according to the individual profile, lifestyle, and other aspects. Again, the integrated management is crucial with the multidisciplinary approach. This is a team approach and cannot be done just with a clinician, and the importance of the language that we use. By language, I don't mean English or Hindi or Arabic, I mean the wording and the communication with our people with diabetes so that it's simple and understandable by all. I have finished here. I would like to finish with this interesting photo which I took when I was working in UK, because I was surprised to find that in some of the parts of South England, there is a sign towards Egypt. So it looks like you can reach Egypt so many ways, even driving through England. Thank you all, and I look forward to the questions and answers at the end.
Thank you, Professor Husnan, for enriching information in a limited time. And I think we would follow it before discussion. We'll follow it with the talk by Professor Sheldout. So may I request Professor Sheldout, please go ahead with your kind lecture. Thank you.
I'm going to complete what my colleague, Professor Muhammad Hassanin, has said about the ESD ADA Guidelines 2022 and management of high-risk group. Before 2016, guidelines and societies were only concentrating and focusing on glycemic control in type 2 for prevention of diabetes complications. But since 2016, guidelines and societies have been recommending the use of SGLT2 inhibitors and GLP-1 receptor agonists for their metabolic, cardiovascular benefits and kidney benefits. In 2016, the European Society of Cardiology and Canadian Diabetes focused on cardiovascular and mortality benefits in patients with type 2 diabetes and cardiovascular disease. In 2018, the American Diabetes Association started to focus on benefits in atherosclerotic cardiovascular disease and chronic heart failure in patients with type 2 diabetes. 2019, the EASD and the European Society of Cardiology had focused on kidney benefits in patients with type 2 diabetes, chronic kidney disease, and diabetic kidney disease. 2020 American Diabetes Association was talking about independence of hemoglobin A1C, atherosclerotic cardiovascular disease, heart failure, or chronic kidney disease predominate in patients with type 2 diabetes and how to prevent these complications and comorbidities. 2021, again, the European Society of Cardiology focused on cardiovascular and mortality benefits in type 2 diabetes with high risk of cardiovascular events or in patients with HFrEF. In 2022, we're going to see what's the new for 2022 by the American Association of Diabetes and the European Association for the Study of Diabetes. And this is the ADA-EASD consensus recently published about the decision cycle for patient-centered glycemic management in type 2 diabetes. And the goals of care was to prevent complication and to optimize the quality of life and to assess key person characteristics in each patient, like the presence of comorbidities like CVD, CKD, or heart failure, and to consider specific factors impacting the choice of treatment, like the presence of these complications or comorbidities, and to take care of the patient well-being and to support the patient, and to review and agree on management plan by the patient. This is very important, and this was repeatedly highlighted in the recently published guidelines. This is the ADA 2022 Standards of Medical Care. There was this roadmap to reduce diabetes complications by lifestyle modification together with glycemic management, blood pressure management, lipid management, and to use agents with cardiovascular and kidney benefits. This is ADA 2022. And for patients with type 2 diabetes, lifestyle modification, and to check if these patients are having atherosclerotic cardiovascular disease or high risk of atherosclerotic cardiovascular disease or the presence of heart failure or CKD or none. Then this was very much highlighted, and which medications are used for each type of patient. And this is a change in AGA between 2021 and 2022. And the first line therapy in 2021 was to use metformin and comprehensive lifestyle change, including weight management and physical activity. But in 2022, this statement was mentioned. Other medications like GLP-1 receptor agonist or SGLT2 inhibitors with or without metformin use can be used on glycemic needs, taking care of high risk of atherosclerotic cardiovascular disease in certain patients or the presence of heart failure or CKD. This is the consensus of AGA together with ESD published in August 2022. And patients were either having atherosclerotic cardiovascular disease like recent myocardial infarction, stroke, any revascularization procedure, or conditions like transient ischemic attack, unstable angina, amputation, or symptomatic or asymptomatic coronary artery disease, or patients having indicators of high risk for atherosclerotic cardiovascular disease, like those above the age of 55 with one or two other risk factors, including obesity, hypertension, smoking, dyslipidemia, or albuminuria, and patients with heart failure or patients with CKD. And for patients with atherosclerotic cardiovascular disease or indicators of high risk for atherosclerotic cardiovascular disease, the first line therapy should include GLP-1 receptor agonist or SGLT2 inhibitor with proven effect on cardiovascular benefit. And for those with heart failure, the most important medication to be given is SGLT2 inhibitors. And for those with CKD patients, we're going to check later which to use very shortly. And for other types of patients, I'm sure Professor Muhammad has covered very nicely. And these are the medications for lowering glucose. These are the summary of characteristics. And let me highlight on two groups of medications, SGLT2 inhibitors and GLP-1 receptor agonists. And these are the SGLT2 inhibitors. They are having intermediate to high efficacy with no hypoglycemia, and they cause intermediate weight loss. And the main action of SGLT2 inhibitors is reduction of renal tubular glucose reabsorption. And they are having importance and benefits in lowering the glucose, the blood glucose, and to lower GFR. They can be used to prevent deterioration of renal function, and of course they are having benefit on MACEs, especially canagliflozin and empagliflozin, benefit on heart failure. All the group is having benefit on heart failure. The progression of diabetic kidney disease, the benefits are evident in canagliflozin, dapagliflozin, and empagliflozin. And this is the GLP-1 receptor agonist, and they are having high to very high efficacy with no hypoglycemia. Weight loss is evident in this group. Some of them are used only in treatment of obesity without the presence of diabetes. For heart failure, they are neutral. And can we use these medications in our countries? We know that GLP-1 receptor agonists are very expensive for our patients, but we are lucky to have SGLT2 inhibitors with reasonable price and can be used with most of our patients. This is the use of SGLT2 inhibitors and GLP-1 receptor agonists in patients with atherosclerotic cardiovascular disease. Like we said, we are going to use GLP-1 receptor agonist or SGLT2 inhibitor with proven cardiovascular benefit. And if the hemoglobin A1C is still above target, we can use vice versa. If we are using GLP-1 receptor agonist, we can use SGLT2 inhibitor and vice versa. For heart failure, SGLT2 inhibitors remain to be the most effective and good evidence in treatment of heart failure and prevention of heart failure. In patients with chronic kidney disease, according to the recently published guidelines, we can use maximally tolerated dose of ACE or ARBs in the beginning, and to add SGLT2 inhibitor with primary evidence to reduce chronic kidney disease. And we can use them if the estimated GFR is 20 milli or above, and it should be continued when initiated until the initiation of dialysis or transplantation. If we can't use the SGLT2 inhibitor for any reason, we can use GLP-1 receptor agonist with proven cardiovascular benefit. Again, this is the goals of care and to prevent complication and to optimize the quality of life and to assess the key person characteristics. If the patient is having CVD or CKD or heart failure, then how to use these medications to prevent and modify the disease course. And this is the cycle of how to take care of our patients. And which medication to use in each of these disease entities and complications and comorbidities. And this is very important to ensure the strategy in place to detect and optimize management of cardiovascular risk factors, to target cardiovascular risk factor screening and surveillance starting from the onset of diabetes or diagnosis of diabetes, and to reduce the blood pressure or to use blood pressure lowering medication if there's hypertension, and to use lipid lowering medication, whether for primary or secondary prevention, the use of antithrombotic agent, and smoking cessation. So this is the consensus recommendations in patients with heart failure, CKD, established cardiovascular disease, or multiple risk factors for cardiovascular disease. The decision is to use GLP-1 receptor agonist if the patient can afford, because we all know that they are very expensive, or an SGLT2 inhibitor with proven benefit, independent of the background use of metformin. This is a change from the previous recommendations published until 2021. Then we can use these medications independent of the use of metformin. And in people with heart failure, CKD, established cardiovascular disease, or multiple risk factors of cardiovascular disease, the decision to use GLP-1 receptor agonists or SGLT2 inhibitors with proven evidence in this benefit on cardiovascular disease or CKD, and it should be used independent of the baseline hemoglobin A1C. Again, these are conclusions and recommendations. In patients with CKD, SGLT2 inhibitor and GLP-1 receptor agonist reduce the risk of MACE inhibitors, and in people with CKD, SGLT2 inhibitors also reduce risk of heart failure and kidney outcomes, including end-stage kidney disease, and this is a new newly introduced information. And in people with CKD and estimated GFR 20 milli, we can use SGLT2 inhibitor with proven benefit, and it should be initiated to reduce the risk of MACE, heart failure, and kidney outcome. And if such treatment is not tolerated or contraindicated, we can use a GLP-1 receptor agonist with proven cardiovascular outcome. This is the European Society of Cardiology, and for the first time, we have evidence from several cardiovascular outcomes that indicate cardiovascular benefit from the use of SGLT2 inhibitors and GLP-1 receptor agonists in patients with cardiovascular disease or at very high risk of cardiovascular disease. And let me finish with this important 2022 KDIGO guidelines recommending comprehensive treatment of patients with diabetes and CKD, chronic kidney disease, to reduce the risk of kidney disease and progression of cardiovascular disease. For some patients, we use the antiplatelet therapies, and for most patients, we use RAS blockage or SGLT2 inhibitors or both. For all patients, we use lipid management, glycemic control. These are needed: lipid management, glycemic control, blood pressure control, smoking cessation, exercise, and nutrition. And SGLT2 inhibitors in combination with metformin should be used as a first-line therapy. For patients with type 2 diabetes and CKD, we start with physical activity, nutrition guidance, and weight loss, and we can use metformin until the estimated GFR is less than 45, then we reduce the dose, and if estimated GFR is less than 30, we discontinue the metformin, and if dialysis starts, we discontinue metformin. And for SGLT2 inhibitors, if GFR is less than 20, we don't initiate SGLT2 inhibitors, then we can use them if the GFR is above 20, and if dialysis starts, we should discontinue. And to use GLP-1 receptor agonists, they are preferred, and DPP-4 inhibitor with safe profile on kidney disease or insulin sulfonylurea TZDs or alpha glucosidase inhibitor when needed. Let me thank you very much.
Thank you, Professor Checkout. I think with this, we come to the end of first half of the session. And before I hand over to Dr. Shalini Jaggi for the second half of the session,
Sir, we have Dr. Shashank's session also. After this, we can have the discussions.
Is he here? I couldn't see him.
Yes, sir, we have, he's traveling right now. He'll be joining live, but we'll have his recording.
Okay. So we can go ahead with Dr. Shashank Joshi.
Yes, sir. So can I have Dr. Shashank's CV? I think all of us know him very well. A leading endocrinologist from India, IDF Southeast Asia chair, lot of president of Indian Academy of Diabetes, former president of API, RSSDI, ESI, IRO, everything. He's been honored by the government of India with a Padma Shri in recognition of his efforts, and we've all seen him in the COVID battle taking the leading from the forefront. So now we have Dr. Shashank, who's going to shed light on a very novel topic, very correlated to what we've heard, the ABCD adiposity based chronic disease clinical evaluation for disease staging. Dr. Shashank Joshi, please.
I'm going to put the video.
Hello, everybody. Today we are going to discuss a new landscape in the management of adiposity medicine and a concept called ABCD, which is adiposity-based chronic disease. We know that chronic care and chronic diseases are on the rise, and mother of all diseases lies in the adipocyte. And the ABCD model of adiposity-based chronic disease has a direct implication on CMBCD, which is cardiometabolic-based chronic diseases. So we all know that the NCD explosion or non-communicable disease explosion has the underlying root as obesity. And we all recognize that all the chronic disease clusters which we see today in modern medicine are all related to obesity. What is obesity? It is a chronic relapsing progressive disease process characterized by abnormal and/or excessive adiposity, which impairs or adversely impacts health. So the first recognizable thing which we need to recognize is obesity is a well-recognized disease. It's chronic, it's relapsing, it's progressive. It has abnormal or excessive adipose tissue, which is impairing or adversely affecting health. It has several factors like sleep, food, biology, mental health, food marketing, genomic risks, life events, stigma, so on and so forth. It is associated with 200 plus complications, It cuts short the lifespan and increases mortality, and it impacts quality of life. We have probably a very large proportion of people who live in India with obesity. And the approximate estimate is around 135 million because we are thin fat Indians. And clearly, if you see, multiple complications are associated with obesity. You can see here the dark blue is grade 4, the lighter blue is 3, 2, and 1, which is the strength of evidence, very strong, moderate, or weak. So currently, you can see that more than 229 complications are affecting every organ system and medical specialty, starting from de novo type 2 diabetes, hypertension, coronary artery disease, cardiac failure, fatty liver, venous thromboembolism, gout, stroke, depression, endometrial cancers, breast cancers, colorectal cancers, atrial fibrillation, incident heart failure, even C-sections or osteoarthritis. Then, of course, we have GRD. We have even congenital anomalies of the abnormal newborn, which are associated, and renal cancer, and so on and so forth. So what is driving this ABCD or CMBCD? It is the phenotype. Now, uniquely, geographies like China, India have a phenotype which predisposes them to ABCD or CMBCD. We have rapidly urbanized our environment. We have become a global village, particularly with the internet explosion. We have a lot of socio-cultural factors, and as the affluence has gone up, as people have become more and more affluent, likelihood of adipose tissue depositing at abnormal sites has gone up. And of course, there is a genomic predilection, and our food habits have become worse by the day. So in the Asian population, which is what I represent from the country of India, there is a natural selection, and there is a clear genetic variant which influences obesity-related traits. This leads to higher thermogenic activity of the brown adipose tissue, which leads to an increased non-50 alleles in the ancestors of East Asians and South Asians, which leads to a predilection to central obesity. So clearly we are thin fat Indians, and the Asian phenotype carries more fat with the same BMI compared to the non-Asian phenotype. So we have, as Asian Indians, more fat, both total and abnormal region, with less lean mass, less skeletal muscle mass, and bone mineral density compared to other ethnic groups, and which is why there is an explosion of type 2 diabetes and non-communicable diseases in this geography of South Asia. So for the same BMI of 32, let me illustrate patient A, patient B, and patient C. Patient C clearly represents the Caucasian phenotype, while patient A is a typical Asian Indian living within or outside of India, which is the thin fat Indian phenotype, where in the body composition, there is more fat. And clearly, therefore, for different BMI also, the lean mass can remain the same. So we are seeing a new phase of malnutrition today. And this new phase of malnutrition we are seeing is called as low lean mass, which is present across all body weights and all BMIs. And this is the new modern phase of Asian malnutrition. And this is called as sarcopenia. Sarcos is muscle, sarcopenia is less muscle. And across the whole Asian geography, right from East Asia of Japan, Korea, Taiwan, from Singapore, Malaysia, to India, Pakistan, Nepal, Sri Lanka, Bangladesh, and various other countries, we can clearly recognize a less muscle mass and a low lean mass in our population. Current type 2 diabetes comes in clusters. Here you can see these clusters are based on the BMI, the waist, the hip, the fat, the insulin resistance, the triglycerides, the beta cell function, the insulin resistance, the area under the curve, and the HDL. And we are now recognizing different clusters because there's a lot of heterogeneity in type 2 diabetes. So for example, in these various clusters, we have some people which are overweight with normal insulin sensitivity and normal insulin resistance. And mostly they are normal, which is low risk. The cluster 2 is very low risk, where there is good insulin sensitivity, adequate beta cell mass. Again, they are normal. Then we have the third cluster where there is a beta cell failure. They are overweight. Their insulin sensitivity is moderately low, but the beta cell output is poor. And they get mostly prediabetes, and they have an increased susceptibility to various abnormalities which we see and recognize. So clearly we can see that this cluster 4 is low risk obese. Adiposity, with obesity, with low insulin sensitivity, normal or borderline, insulin secretion, and predominantly a renal sinus fat and renal failure. So when we look at the chronic conditions, the first stage is genomic predisposition and family history. The second stage is pre-disease, where there is increased overweight, abnormal distribution of fat, abnormal function of fat, and all the biochemical abnormalities, insulin resistance. So in the first stage, there is only insulin resistance. As the disease moves, you get pre-diabetes. But in the third stage, the BMI, if it is used as a threshold, you get obesity. If you use anthropometry as a threshold, then you get thin fat Indians. And if you use biochemistry as a threshold, you get type 2 diabetes. And the fourth stage is complication, which are cardiometabolic or biochemical, and ultimately macro and microvascular. But BMI is a very, very poor measure. The reason I am asked to give this talk from a clinical standpoint is BMI is a very poor measure of individuals' adipose-related disease burden. It is the fat quantity, the fat quality, and the location that matters. So therefore, it is best to avoid the term obesity and instead use the term adipopathy or ABCD, adiposity-based chronic disease. The ABCD or adiposopathy is a key pathogenic driver of many conditions and represents a disease continuum. And therefore, based on the goals, the treatments and the outcomes will differ on the disease stage. So here you can see in the ABCD, clearly the primary drivers are unhealthy lifestyle and epigenetics. In the stage 1. In the stage 2, there is overweight and abnormal adiposity. Stage 3, there is abnormal adiposity. And finally, you have the outcomes. We have also a term called DBCD, which is diabetes or dysglycemia based chronic disease, where you get pre-diabetes, type 2 diabetes, and microvascular disease. Then we have HBCD, which is hypertension or high blood pressure based chronic disease, where there is pre-hypertension, hypertension, and hypertensive complications. Then we have LBCD, which is lipid-based chronic disease, where there's abnormal lipids, dyslipidemia, and lipid-related complications. And finally, we have the actionable model, which has been derived, and this was all devised, these terms have been devised by Professor Jeffrey Mechanic, who is a medical director and past president of the American College of Clinical Technology, a good friend of ours. And the CMBCD is chronic cardiometabolic based chronic disease, which is a metabolic syndrome in the older terminology, where you have subclinical atherosclerotic cardiovascular dysfunction, asymptomatic CVD, and symptomatic CVD. Well, in the DBCD model, glucose is the primary target. In the ABCD model, and overall, it encompasses obesity as a primary target. And therefore, we need to recognize that. So fundamentally, when we are looking at cardiometabolic based chronic disease, we are looking at metabolic flexibility because it has an impact on lifespan. And clearly we recognize that the disease burden is huge because we know the global burden of deaths are all being driven by cardiovascular disease. Even today, the largest cause of death on planet Earth is cardiovascular disease. And these deaths are clearly driven by an ABCD, DBCD, and CMBCD model. You can see that cardiovascular rates in India have exponentially grown up. The mortality has grown up. And particularly in the post-COVID times, we are seeing a higher incidence of cardiovascular disease, stroke, and ischemic heart disease due to lack of recognition and follow-up which is being lost. Well, the clock of macrovascular clock of heart disease starts ticking very early in life. We know atherosclerotic plaques start at the age of 6 and 7. And by the time diabetes becomes overt, okay, macrovascular complications have already set in. And by the time the microvascular clock starts ticking, already there is de novo diabetes, which is overt and obvious. So fundamentally, the metabolic driver of cardiometabolic based chronic disease needs a strategy for early interventions. And we need to control the metabolic drivers, including adiposity, dysglycemia, and hypertension, A, B, and C. And therefore, it's A for the adiposity and the A1C, B for basically blood pressure, and C basically for the dysglycemia part and the dyslipidemia part. So what is CMBCD? It is ABCD plus DBCD. So ABCD stands for adiposity based chronic disease. It has two parts which reflects, as I earlier told you, adiposity-based reflection of mass, function, and distribution, and the chronic disease, which reflects the risk, the presence, and severity of complications. Then we have the DBCD term, which reflects the different spectrum of diabetes, from pre-diabetes to insulin resistance to overt diabetes to diabetic complications. And finally, a combination of ABCD and DBCD results in a medically actionable model, where we have a complex interrelationship between obesity, diabetes, and heart disease, which go hand in hand. And therefore, it's very, very important to have primordial prevention, primary prevention, secondary prevention, and tertiary prevention to prevent development of end-stage disease complications. So when we merge the ABCD, DBCD, and CMBCD models, I'm reiterating this graph again. You can see that in the ABCD model, it is the abnormal amount of weight, the fat distribution of ectopic fat, and the abnormal function of adipocyte, which drives cardiomechanical and biomechanical complications. Similarly, the glucose model of insulin resistance drives diabetes and microvascular complications. And similarly, when these two are merged, you get development of metabolic syndrome traits with glucose, dyslipidemia, and hypertension driving heart disease, heart failure, and atrial fibrillation. So clearly, adiposity and dysglycemia affects cardiovascular disease. We know that ABCD model increases the prevalence and the progression of coronary artery calcification. It also increases preserved and reduced ejection fraction and increases the prevalence of atrial fibrillation. Similarly, you can see that DBCD leads to more reactive platelets, higher risk of first myocardial infarction, decreased myocardial perfusion, apart from micro damage in the myocardium and cardiac lipotoxicity. And overall, the metabolic CMBCD model will lead to more coronary plaques, more incidence of prevalence of first acute coronary event, and higher prevalence of all coronary artery disease, heart failure, and atrial fibrillation and death. So obviously, it's a combination of beta cell defect, insulin resistance, lipotoxicity, glucotoxicity, and that contributes to DBCD, ABCD, or CMBCD. And therefore, it's very important to recognize whether it is metabolic or mechanical inflexibility. We need to have metabolic modulators for good health, and that is so crucial. So obviously, today's treatment of type 2 diabetes, the reason we are talking as clinicians in this ABCD model is we need to move beyond a glucocentric approach to a weight-centric, cardio-centric, cardio-obesity-centric approach. And if you see the latest ADA-ESD guidance, the latest RSSDI-ESI guidance, the proportion of type 2 diabetes which needs a weight-centric approach is much more than those who need a glucocentric approach. And that is why this ABCD model has become more actionable. So obviously things happen because we are driving chronic disease models of adiposity, dysglycemia, and cardiometabolic risk. Adiposity and dysglycemia are the key drivers for the #1 cause of mortality worldwide. And therefore, weight control is as important as a primary target as glucose control. And it's just not weight. It is the adipose tissue reduction and shrinkage which will mitigate and prevent complications and death and prolong life, particularly to cardiovascular. My last mantra is always lifestyle. We are in best of times, but we are in worst of times. And therefore, if we have to make a difference on ABCD, DBCD, or CMBCD, we need to eat slowly. We need to eat less. We need to eat on time. We need to eat right. We need to do a lot of physical activity, including 10,000 steps a day, do a lot of walk, build some muscle mass because we are sarcopenic, do some yoga and meditation, do ensure that you sleep on time, sleep well, and be stress-free and smile. That's really the core essence of the mantra to prevent ABCD models. It's equally important that when we are reducing glucose or DBCD, adipose tissue or ABCD, or the cardiometabolic risk, we need to be happy and healthy. And we are in digital times, and therefore we are into a digital meeting. We need to do 1 hour of digital detox every day because that has truncated the physical activity, and that's really been the challenge. So I hope from the exercise I have told you, you understood a little bit about the term ABCD. and recognize that obesity, though is a recognizable disease, ABCD is much more granular in its depth. It's closely married to DBCD and is closely having a medical actionable model called CMBCD. So what you have listened, I hope you have learned. What you have learned, I hope you will adapt and you will follow a healthy lifestyle and sleep well. Thank you for a patient.
Thank you, Dr.
Thank
Shashank.
you so much.
Yes, please go ahead.
Yeah.
Shalini.
So thank you so much, Dr. Shashank sir, for that enlightening talk. And I think we've had three very brand new concepts, very brand new presentations. So Dr. Vinod Kumar sir, I would like you to lead the discussion.
What is this echo coming from? So, okay, it's okay now. So, thank you, Dr. Shalini, and I would like to congratulate all the three speakers for very nice messages that they have given. Coming to the first two presentations on EASD and ADA guidelines, it is very heartening to note that factors like sleep and person-centric approach, importance of communications, and involvement of the patient himself in the decision making are very important additions to the 2022 guidelines. I might also like to make a brief comment that in our country, for a number of years, we have been talking of the mantra that Dr. Shashank also said. We often say, eat well, eat right, exercise well, sleep full, and de-stress. And also, because Professor Hussain talked about adherence, so adherence to the treatment is very important. And I would like to pose one clarification, or maybe it's a very brief question. Dr. Hussain, how do you go about the failure of compliance to the advice that is given, whether it is on the lifestyle management, whether it is in relation to the anti-diabetic agents? Because in our country, in my feeling is that a large number of people just do not comply with the advice that is given to them. In spite of all the communication that we try, in spite of all the methods, particularly in elderly people who have cognitive decline to some extent, many times, they just fail to understand what we are telling. That's my question. Thank you.
Thank you very much. It's such an important question that obviously affects so many of the chronic diseases that adherence to treatment is difficult. I think I would rather go to the roots of the problem and ask myself, how much support did we provide the individuals? In many of our clinics, we do not provide comprehensive patient education, and we don't provide continuous support for them to comprehend. We know that the consultations could be busy with so many aspects that we want to address, and the retention of information of the individual is such more. As a patient, maybe they got focused on one point and they switch off from all of the other discussion. And that's why working as a multidisciplinary team with reinforcement of some of these important messages is important. Having said that, of course, it's not an easy task for chronic diseases in general. And that's why they are talking in the guidelines of implementing the multidisciplinary approach, the self-management, and reinforcement on a regular basis in a language that the person understands. Certainly, looking into the tablet burden, the combination of therapy and the type of tablets that we can give to our people that would suit their condition best, it's of course a very important aspect.
Thank you. And before I pass on to the further discussion, a very brief comment on Dr. Shashank's paper. When I see around people in this country, and for that matter, it may be true of other countries, I find people who grew up as child and then adolescent and then developed into adults who had been thin looking, who had been normal or even underweight, who were not obese at that time, probably many of them did not have enough food to eat at that time. They have blossomed into the non-obese adults, middle-aged, and even in old age, they are not obese. So I think if that is a correct statement, then if not primordial, at least the primary prevention must start in early childhood. because it is that stage when the parents start feeding their children unwantedly. Thank you.
So I completely agree with Dr. Vinod Kumar. We need to start focusing from maternal nutrition in the second throughout the childhood, particularly after 7-8 years, when the adolescent till adolescence, that's the time they gain some weight. Some people as child remain malnourished, but then they become affluent later, eat more. They are physically active as young adults. Still later on they slump up, and then they gain weight. So you're absolutely right that we have to, throughout the life course and journey, be healthy throughout and not falter at any decade. Unfortunately, as Indians born in India, we are getting diseases almost 2 decades earlier than the Western population. And therefore, it's very crucial what you're advising, sir, that we need to look at primordial and risk factor modification, starting not just childhood, but I think maternal health impacts child's weight and outcomes later, communicable diseases, as well as focusing on early childhood, late childhood. The good old adage that chubby children are healthy children has gone. And we need to physically focus on physical activity in schools, encourage more sports, give extra incentives and points. And we need to focus on work canteens and school canteens, because they are the culprits where excess food and less physical activity has contributed to this whole pandemic of non-communicable diseases. So I agree with you completely, sir.
Thank you. We still have about 3 minutes. If there is any other comment or question from anyone else, most welcomed.
Dr. Shashank, sir, we're in the era of precision medicine. So do you think all these models, the way we stage, the way we try to differentiate people based on their phenotypes, will be the way forward when it comes to deciding the right drug for the right patient?
Shalini ji, absolutely right. We are looking at clusters, and we are now in a process of identifying these clusters. And I think there is a lot of heterogeneity in type 2 diabetes. We see a full spectrum from lean, which Professor Vinod Kumar was alluding to normal weight, to abdominally obese, to overtly obese. So we see the whole spectrum, and we are seeing clear-cut clusters, some with beta cell defects, some with insulin resistance, some with both. So obviously, the future is in precision medicine and clusters. Absolutely. And identifying the clusters and then mixing and matching the appropriate drug as per the pathophysiology and the cluster would be the way forward. So that's a very, very valid point which you're saying, ma'am. And that is where the personalized and precision medicine is looking forward, that identifying clinically clusters and then treating clusters and trying to have a complication-free world with good glucose control, and also moving the girdle beyond glucose-centric to cardiometabolic risk, to weight. And that's where the new guidance and recommendations are coming in.
Absolutely. Professor Inas, one very quick question.
Sure, may I ask a question to Professor Inas? Inas, many people in Egypt as well as in India wouldn't be able to afford GLP-1 receptor agonists. How do you think we can best serve the cardiorenal protection with the modest cost?
For sure, we have a percentage of patients who can afford, because we use GLP-1 receptor agonist extensively, because we are having patients sponsored by their companies, or they are certain entities in Egypt is covering really any kind of medication. So we are using GLP-1 receptor agonist, and worldwide GLP-1 receptor agonists are used in about 5% of the patients, and I think this is the same percentage in Egypt. But we have SGLT2 inhibitors with reasonable price for international companies, pharma companies, and we are having many generics now. More than 22 national pharma companies are producing SGLT2 inhibitors, and they are used now extensively, and they have the same protection for cardiovascular disease, and also they have more benefit on chronic kidney disease. So we are using SGLT2 inhibitors extensively.
Thank you.
Thank
you so much,
the speakers. And I would like to once again thank the speakers. And over to you, Dr. Shalini now.
Thank you so much, Dr. Shashank sir, Dr. Mohammed, and Dr. Inas for your inputs. And we'll request you to stay back for the next session also, so that we can have a grand discussion round. So with this, we move on to our next speakers, none other than Professor Mohammed Nagoeb. Can I have his CV here, please? So Dr. Mohammed is Professor of Medicine and Hepatogastroenterology from Cairo University, founding member and General Secretary of the GIFTS, member of Egyptian Society for Study of Liver and GI Diseases, many hats to his illustrious head. Welcome, sir. He is going to shed light on diabetes and exocrine pancreatic insufficiency. Welcome, Dr. Mohammed.
Yeah, welcome everybody. I am very pleased to be participating in such a prestigious symposium, and I am very pleased to be participating here with our Indian partners. I thank you, Dr. Shalini, Professor Kumar, Professor Rajiv, and all the faculty. Of course, I thank my professors, Professor Ines and Professor Hassanin, for giving me the chance. If you allow me to share the presentation with you, and we will discuss after. Moment, just can you see it now?
Not yet.
It's loading, I think. Yeah, yes.
Okay.
You can please put it in full screen mode.
Yeah, I will. Okay. Yeah. So let's ask the question why hepatogastroenterologist would be presented in a symposium for diabetes. Because in many lectures given by the professors, we are now aware about the multidisciplinary approach of our patients. And there is very big amount of patients in our GI clinics who are originally coming to visit us from the diabetes or the endocrinology clinic with long-standing GI complaints. And maybe also your patients in your own clinics, they are complaining all the time from GI disorders. And you, of course, as internists, before becoming endocrinologists and diabetologists, you would try to explain to them why those GI complaints are coming from. So I come here to shed some light on a very underdiagnosed and undernoticed problem, which is the exocrine pancreatic insufficiency. And its relationship with diabetes mellitus. This is going to be my agenda, and let us not waste time in it. You will know it all. This is the pancreas. Of course, the pancreas is spread between two specialties and does not know who is the father. Is it the endocrinologist? Because pancreas is an endocrinal organ, and when an endocrinal society wants to make a logo for itself, it will definitely pick the pancreas as their logo. On the other hand, there is the gastroenterologist, of course, who thinks of the pancreas as, because of its exocrine function, that is, when he performs another society, the gastroenterology, he will also use that pancreas as a logo. So there is some debate about whether the pancreas is an endocrinologist problem or a gastroenterologist problem. So I said to myself, why not make this happy marriage between the endocrinal and the exocrinal part, between the endocrinologist and between the gastroenterologist. So my introduction, of course, all of you know that the pancreas is an exocrine and endocrine gland. The exocrine part is the most important part in our digestion. Actually, our digestion depends primarily on the pancreas. And if you don't have a well-functioning pancreas, unfortunately, sir, you will not digest, because the pancreas is responsible for the digestive enzymes that can digest carbohydrates, fats, and the proteins, and neutralizes the acidic chyme that is coming from the stomach. Moreover, the exocrine pancreas, the part I'm speaking about, comprises 85% of the pancreas. So it is the majority of the pancreas is an exocrine gland. So how they interplay together? Do they have something to do with each other, or they are just neighbors in the same neighborhood? No, sir, they have very much interplay to do with each other. Endocrine islet cells hormones regulate the ductal and acinar cells of the exocrine activity. How is that? The insulin is trophic to the ductal and acinar exocrinal activity. How is that? Rise of insulin and other pancreatic islet peptides like amylin, C-peptide, and urocortin-3 following the postprandial glucose rise will actually stimulate the exocrine pancreatic function to start performing its job. Also, the increase of glucagon will do the other way around. It will depress the pancreatic enzymes and juice secretions. While the ductal and acinar cells, they affect the physiology of the endocrinal islet cells through the cytokines and growth factors that they can secrete. So what is the definition of exocrine pancreatic insufficiency? It is the inability of the pancreas to secrete enzymes and bicarbonates for the action of on the intestinal lumen to accomplish the normal digestion of food, like I formerly mentioned. How is that be done? Mechanisms of exocrinal pancreatic insufficiency can be by abolishing any point of the digestive chain of the exocrine pancreas, by insufficient activation of pancreatic secretion, by damage of the pancreatic cells, which reduces the production and secretion of pancreatic juice, by asynchrony. Asynchrony means that the food is present in the intestinal lumen at a time where the pancreatic enzymes are not present, and the other way around. The pancreatic enzymes will reach the intestinal lumen when the food is not there at that time. And this happens, for example, with bariatric surgeries or the bypass surgeries. And lastly is obstruction of the pancreatic juice by any problem that obstructs the pancreatic duct. So what's the relationship between exocrine pancreatic insufficiency and diabetes? Here is the first fact. 50% of patients with type 1 diabetes, they have exocrine pancreatic insufficiency. So among every 2 patients with type 1 diabetes, there's one of them already complaining of exocrine pancreatic insufficiency. And why is that? Because lack of the trophic action of insulin and possibly glucagon and somatostatin on acinar cells, like we said, involvement of the exocrine tissue in the same autoimmune destruction of the islet cells. The autoimmune cells who are going to destroy the islet cells will not leave the exocrine part alone. It will destroy the exocrine pancreas as well as the autonomic diabetic neuropathy leading to enteropancreatic reflex impairment. It means that when they have this kind of autonomic neuropathy, those reflexes that allows the exocrine pancreas to start to secrete its juice is going to be impaired. And lastly, the hypoxic sufferance, like any diabetic having a micro and macrovascular disease, all his tissues are hypoxic, as well as his pancreatic tissue, because of the microvascular damage. What about type 2 diabetes? Type 2 diabetes, they have 35% of patients, they are having exocrine pancreatic insufficiency. I mean, every 3 patients with type 2 diabetes, 1 of them is suffering from exocrine pancreatic insufficiency, and this is because of the autonomic diabetic neuropathy and the hypoxic sufferance theories only. So what are other causes? Of course, you know it better than me. Chronic pancreatitis, pancreatic malignancy, congenital diseases like cystic fibrosis, any disease that can obstruct the pancreas. Non-pancreatic causes like celiac disease, it's a very common, and celiac disease is common in type 1 diabetes as well. We know it very well. Crohn's disease, autoimmune pancreatitis, Zollinger, Ellison, and surgical procedures that will make the asynchrony between the pancreatic juice and the presence of food. So, according to that, there are proposed subgroups of pancreatic exocrine insufficiency. They are divided according to the etiologic factor. We say that there are some factors that are definitely to cause pancreatic exocrine insufficiency, like pancreatectomy and chronic pancreatitis and cystic fibrosis and so on. Others that are possible to cause pancreatic insufficiency, like gastric surgeries or mild chronic pancreatitis or post-pancreatitis or Whipple disease, and things that are likely like the functional disorders like the irritable bowel syndromes, but they have less amount of causing exocrine pancreatic insufficiency. So what is the prevalence of exocrine pancreatic insufficiency? Unfortunately, it is unknown. Why it is unknown? Because doctors, they don't think about it, so they don't search for it. So you diagnose it very, very less than it should. So you cannot say the prevalence of a disease that you don't diagnose. But it has a very high percentage among the diseases, as we said for our lecture today, that in type 1 diabetes 50%, and in type 2 diabetes it is 35%, and like patients with chronic pancreatitis, it's almost this time that they must develop exocrine pancreatic insufficiency. What about the clinical presentation? How could we suspect exocrine pancreatic insufficiency? Unfortunately, the symptoms of exocrine pancreatic insufficiency are very common, and they do not almost occur unless there is less than 10% of the exocrine pancreatic function. The most common is steatorrhea. This is a very late presentation of exocrine pancreatic insufficiency, but what is commoner than that and occurs a little bit earlier than that are the symptoms of dyspepsia, occasional diarrhea, meteorism, distension, malabsorption, and maybe while examining the patient, you would find that he's having some sort of vitamin deficiency, of course, mainly the vitamin, which are fat-soluble vitamins like vitamin E, D, E, and K. Malnutrition can lead to sarcopenia, and of course now we are speaking about sarcopenia very much, and we are seeing that even obese patients, they can be sarcopenic. So they don't need to be losing weight to become sarcopenic. They can simply be malnourished to be sarcopenic. Also, there is increased incidence of all other comorbidities like osteopenia and osteoporosis and non-traumatic fractures, like the increased risk of cardiovascular events. Already diabetes is a cardiovascular event. The presence of exocrine pancreatic insufficiency may multiply this risk of cardiovascular event, and of course there is some sort of immunocompromisation, so they are very prone to concurrent and intercurrent infections, those patients with combined diabetes and exocrine pancreatic insufficiency. So how can we diagnose it? There is combination of 2 out of 3 symptoms of maldigestion or malabsorption, indicator of a malnutrition, and a positive result of a non-invasive pancreatic test. How is that? This is the way it goes. If we have an exocrine pancreatic insufficiency definite etiology, like we said, severe chronic pancreatitis or total pancreatectomy or cystic fibrosis, I don't need any diagnostic test. I don't need any kind of investigations. This is a definite exocrine pancreatic insufficiency. And of course, those patients will definitely develop also diabetes, what we all known before by the pancreatogenic diabetes mellitus or type 3C diabetes. This is a term that we use less nowadays. What about the possible and unlikely? Those are the patients that they need some investigations. As we said, clinical presentation, nutritional markers, and indirect pancreatic tests. If we have the clinical presentations and the nutritional markers, or the clinical presentation and the indirect test, or the nutrition and indirect, we say that it is exocrine pancreatic insufficiency possible to say it. Unlikely if we have only the indirect test positive without any nutritional marker of deficiency. What are the diagnostic tests of exocrine pancreatic insufficiency? We know that we have some considerations. Direct methods should be highly sensitive and specific, but they are invasive, expensive, and very time-consuming, and not readily available, and unfortunately variable among centers that prevented their standardization, and that's why they are not very useful. What about the indirect methods? They are less sensitive, but they are less costly, and they are, of course, easier, and unfortunately are not very widely available, besides readily reproducible diagnostic technique. That's why exocrine pancreatic insufficiency is underdiagnosed. What are the direct methods? And we can see that they are, all of them are very difficult, like the 72 hours fecal fat estimation, or what's called the coefficient of fecal absorption. This is the gold standard, but it needs 3 days collection of stool, 100 gram standard fat diet for 5 days, and you have to stop therapy. And after all that, it is not specific. We have the endoscopic pancreatic function test, which was useful only in early cases, but it is very time consuming because you have to collect the duodenal juice for a whole 45 minutes during an endoscopy. This means anesthesia for 45 minutes, endoscopy for 45 minutes, collecting duodenal juice for 45 minutes. And unfortunately, after that, you cannot quantify the volume output, because this only 45 minutes and the patient is not eating, and you cannot quantify. What about the cholecystokinin secretin stimulation? It is the gold standard in scientific evaluation. I mean, in research and in research centers, because it's invasive and complicated. And lastly, of course, the secretin MRCP test. It's by giving secretin and having serials of MRCP images, 3 minutes, 7 minutes, and 10 minutes afterwards. And it needs more validation, and it is subjective, and it needs precise timing of the serial imaging. And that's why it is not very common. And it's almost uses were in acute and chronic pancreatitis, and they were not validated in other etiologies of exocrine pancreatic insufficiency. What about the indirect pancreatic function test? The most common and the most widely used, and the one that I usually use in my clinic, is the fecal elastase 1. It is the gold standard. It's the advantage that it is most widely used. It's non-invasive, single sample. You don't need fecal collection. Does not require stoppage of therapy. In fact, you can you use it once, and you can give the therapy. Then you can monitor it again by ordering another sample, and it is not very expensive. It's highly sensitive. Only disadvantage that is not very nice results when you have liquid consistency of your stool, because it cannot be readily measured, and there are other potential causes of false positive, like the bacterial overgrowth, and Of course, like calprotectin test in diagnosing GI disorders, it has this gray zone between 100 and 200 micrograms. These are a gray zone. It is not a positive test. The positive test is above 200, less than 100 is a definite deficiency. What about 13C mixed triglyceride breath test? Of course, we know there are plenty of breath tests to diagnose malabsorption syndromes. One of them is the 13C mixed triglyceride. It is by giving a diet with triglycerides, rich in triglycerides, and with 13C carbon particles in it, and then you measure it in the breast. It is simple, it is non-invasive, it can be useful to monitor the treatment response. The disadvantage is the false positive, because any patient with chronic liver disease or chronic lung disease will have a false positive result, and it is also non-specific and low sensitivity in the mild forms of exocrine pancreatic insufficiency. What is the treatment? What is the therapy? After you have this clinical suspicion and you perform the indirect test and you can find it that there is deficiency in the fecal elastase, what are the indications of pancreatic enzyme replacement or supplementation? Indications, of course, are weight loss or steatorrhea and the persistence of symptoms of dyspepsia, diarrhea, meteorism, and malabsorption of proteins and carbohydrates, and of course, after exclusion of functional disorders. Of course, it has no benefit in pain management in cases of chronic pancreatitis. We are only speaking about the supplementation for improving the digestion and the nutritional status of the patient and maybe control of his steatorrhea. The goals of therapy, the main goal is to supply the patient with optimal amounts of lipase to reach the duodenum with the delivered food. The currently available forms will maybe eliminate the azoturia, which is the protein malabsorption, whereas it will only decrease the steatorrhea, which cannot be totally corrected. The general measures, of course, is a lifestyle modification like any disease. Let's like say avoiding fatty food, limitation of alcohol intake, cessation of smoking, and a consumption of well-balanced diet, and maybe refer the patient to a dedicated nutritionist to plan the diets with your patient. Vitamin supplementations, of course, primarily the fat-soluble vitamins A, D, E, and K. And of course, the gold standard or the mainstay is the what's called the PERT or the pancreatic enzyme replacement therapy. Long-term monitoring will focus on correction of nutritional deficiency and treatment of positive diseases if possible. And we can see here, it is like 4 pieces of a puzzle: lifestyle, PERT, follow-up, and diet. Endpoints of treatment are normalization of fat absorption and correction of nutritional deficiencies. The typical indications for initiating the PERT is the progressive weight loss and steatorrhea, and the efficacy by increasing or increased by higher enzyme doses, by enteric-coated supplement, and of course by suppression of acidity, so not to destroy those enzymes before reaching the duodenum, and administration of therapy during food. We always instruct our patients to take the pills during eating, while they are eating, in the mid of their already of their meal, so that when the meal reaches the duodenum, the pancreatic enzymes will reach the duodenum by the same time, and by that we can guarantee the synchrony between food and the activated enzymes. How we can measure the improvement? Of course, by the fecal elastase or by the coefficient of fat absorption and the serum nutritional parameters and the abolishment of GI symptoms and improvement of the quality of life. There are 6 approved agents by the FDA. Lipase plays the paramount role in the therapy. There are combinations of amylase, protease, and the lipase. These are the approved agents. Of course, many of you may be aware of some of them. I don't know about India, which of them are present. And in fact, in Egypt, we had the crayon, and afterwards it was stopped from being being here. Problems, of course, with with bringing it from outside. And now we have two companies in Egypt. They are making the pancreatic enzyme formulas, and they are present in the market nowadays. These are the different concentrations, of course, and we, as I said, we start by titration of the dose until we reach the optimal result with our patient. And this is a form of the syrup in patients with pediatric population, like those with type 1 diabetes. And of course, the consideration is, as we said, administration, which means increase the dose depending on the lipase, improvement of the body weight and clinical symptoms, and less stool fat content. Of course, you have to allow several days, maybe a couple of weeks, before moving on to the new dose. Of course, should be enteric coded. And there is the technology of many microspheres that makes the birth effect much better. Of course, at least we start with 20,000 units of lipase, then we can increase the dose later on. The adverse effects of pancreatic enzyme replacement are very trivial. Some of them are just some abdominal pains and cramping, and they can go away after a while, to less extent that they can cause some cough, some dyspepsia. Unfortunately, they can also cause some diarrhea, but all of those are transient and not much of a complication. But you have to cautiously use it in patients with renal dysfunction and hepatic dysfunction. Of course, not very well tested among pregnant females. In a capsule, there is so much interplay between exocrine and endocrine pancreas. So exocrine pancreatic insufficiency is very, very, very common among diabetes. We said half of type 1 and 1/3 of type 2 diabetes. It is largely a clinical diagnosis. So all of us diabetologists or endocrinologists seeing so many diabetic patients every day, we have to suspect exocrine pancreatic insufficiency as a cause of the GI complaints of our patients. It's not necessarily that it is a bacterial overgrowth or the effect of metformin, or that is having functional GI disorders like irritable bowel syndrome or so. Please think of exocrine pancreatic insufficiency and search for deficiencies before the era of steatorrhea. Correct the vitamins like A, D, E, and K. And of course, the mainstay is the pancreatic enzyme replacement therapy that depends mainly on lipase. At least 20,000 units, and you can increase it every couple of weeks according to the response. And thank you very much.
Thank you so much, Professor Mohammed, for that very enlightening talk. And I'm sure people practicing diabetes, endocrinology are definitely enriched. We've all been encountering such patients, and I think it's always a multidisciplinary effort when it comes to managing such patients. I would request you to kindly stay back for the discussion that will happen after the next two lectures. So next lecture, of course, is by our own host, Dr. Rajiv Chawla, who's going to talk on the deadly trio of diabetes, heart failure, and renal dysfunction. So I think we've done with the introductions earlier. So Dr. Chawla, welcome for your talk.
May I share my screen?
So please share again.
Can you see my slides?
Yes, please make it full screen. Yeah.
Good evening, everyone. I think after three very enlightening sessions, it's now my pleasure to do little different what we have discussed since afternoon. What I'll be doing is to discuss how diabetes, heart failure, and renal dysfunction are deadly trio in natural course of the disease. The flow of my session will be first to discuss cardiovascular disease, heart failure, and kidney complication in patient with type 2 diabetes, how we can reduce the risk of CV disease, heart failure, and kidney complication in patient with type 2 diabetes, and what do guidelines suggest when it comes to management of type 2 diabetes with these comorbidities. We all know there is a very significant and very dynamic relationship which exists between systemic metabolism, heart, and kidneys. So once we know that heart is the most metabolically demanding organ, which is susceptible to changes in volume as well as to metabolism. So metabolism by liver, pancreas, and fat is essential for healthy functioning of organs like heart and kidneys. We all know that. And it is the kidney which plays a very, very important role once it comes to glucose homeostasis, or volume homeostasis, or even blood pressure regulation. So there has been a lot of evidence trying to link systemic metabolism, heart and kidneys, and a lot of studies have proven that fact that acute or chronic dysfunction in heart, kidneys, or systemic metabolism may induce dysfunction in another. So each dysfunctional organ perpetuates dysfunctionality in other organ through a variety of mechanisms. And it is type 2 diabetes which itself carries huge risk of cardiovascular disease, kidneys, and now we know even heart failure. Let's talk about metabolic dysfunction first. And we know if there is a metabolic abnormality, it is going to affect both cardiac and kidney disease progression as well as outcomes. Moment there is a metabolic dysfunction in the form of hyperglycemia, dyslipidemia, insulin resistance, or altered hormonal milieu, it will induce inflammatory adipokines, and that will lead on to fibrosis, endothelial dysfunction into the kidneys, with ultimately declining kidney function, onset of microalbuminuria, increase in glomerular filtration in the beginning, and subsequently fall in EGFR and fluid retention. In the heart, it leads on to fibrosis. With acute endothelial dysfunction, there is going to be an onset of early heart failure and rampant atherosclerosis on long-term basis. So even cardiac dysfunction will add to kidney and metabolic burden. So if there are cardiac abnormalities, that is going to affect both kidney and metabolic disease progression and ultimately the outcomes. So in cardiac dysfunction, if you have early neurohormonal activation or hypoperfusion or volume overload, that will lead on to arterial resistance and autonomic dysfunction, which not only will increase free fatty acid level, worsen dyslipidemia and insulin resistance, but in kidneys also it will increase hypertension, onset of microalbuminuria, and subsequently progression to macroalbuminuria, and there will be a declining kidney function. And kidney dysfunction will add to cardiac and metabolic burden. The moment you have kidney dysfunction, there is an overactivation of RAS and NSS system. There's going to be sodium and fluid retention, hypertension, arterial calcification, which will induce oxidative stress and will worsen glomerular hyperfiltration, which will further worsen insulin resistance, and that will also lead on to ventricular hypertrophy, ventricle failure, vascular dysfunction, endothelial dysfunction, and rampant atherosclerosis subsequently. So once it comes to overall type 2 diabetes course in a patient, we know these patients are at an increased risk of complication due to metabolic disturbances and interconnected risk factors, which we just discussed. So all those patients, those who have clustering or risk factor like obesity, hypertension, dyslipidemia, and smoking, with further worsening of insulin resistance, there is going to be a gradual beta cell dysfunction, which will predispose to all micro as well as macroangiopathy. It could be simply onset of microalbuminuria, subsequently leading on to nephropathy, or maybe rampant atherosclerosis, peripheral neuropathy, or even macrovascular diseases like heart failure, MI, or stroke, or even dementia. And we know large proportion of patients with type 2 diabetes, they have CV disease. Almost 1/3 of patients with type 2 diabetes, they have CV disease. So it's not very surprising once we say that patient with type 2 diabetes with CV disease will also have increased complication in the form of MI, stroke, heart failure, or CKD also, as compared to someone who is not having CV disease in the setting of type 2 diabetes. And we know that it is CV disease which accounts for higher morbidity or mortality in all patients, whether those patients have underlying CKD or myocardial infarction. Even CKD and heart failure are most frequent cardiorenal disease manifestation in patients with type 2 diabetes. And this is what has been shown in this wonderful data of almost 7 lakh patients, that CKD and heart failure together accounted for almost 60% new onset. And these were one of the earliest manifestations, coming much earlier than stroke, MI, or peripheral vascular disease. And we know heart failure itself, these days we talk about heart failure, that this is unfortunately not getting diagnosed correctly, and it is one of the most important complication which might happen in the setting of type 2 diabetes. Almost 25 to 40% of patients with diabetes might have heart failure. Eric study very clearly established that in 386 patients, a follow-up of 5 years, almost 68% patient had symptomatic or asymptomatic LV dysfunction, either HFrEF or HFrEF. And we know another cardiac screening of 580 patients has shown that 28% patient, they had subsequently, if they were more than 60 years, they had again HFrEF or preserved heart failure in almost 28% of patients. So having said that, heart failure is very, very important. So is kidney also, which is again one of the earliest and very highly prevalent complication in setting of type 2 diabetes. So if you follow type 2 diabetes patient during the course of disease, almost 15 years down the line, about 50% patient will have either albuminuria, impaired EGFR, or both, setting to higher cardiovascular mortality. Because moment you have coexistence of type 2 diabetes with kidney disease, overall mortality may go up by almost 5 times as compared to someone who only has type 2 diabetes or albuminuria. So moment you have type 2 diabetes with albuminuria and reduction in EGFR, there is going to be almost 4 to 5 times increase in overall mortality in these patients. Even heart failure and kidney function also decline, and these seem to be very, very interconnected. Because if you see that all those patients, those who have heart failure in the setting of CKD, again the mortality in these patients is very, very high as compared to someone who does not have heart failure with CKD, because even CKD patient might ultimately have higher CV mortality. They may not die of CKD. Actually, they may die of CV mortality. So let's see whether we can reduce the risk of cardiovascular disease, heart failure, or kidney complication in patient with type 2 diabetes. So if we go through the meta-analysis of all major trials like ACCORD, Advanced UKPDS, and VEDET trial, they have shown only modest benefits in terms of overall CV events. In terms of MI or reduction of all-cause mortality, it has not been very, very impressive. Of course, UKPDS has shown us that 20 years, there was a reduction in microvascular risk by almost 25% by 1% HuNC reduction, but that was not p-value wise significant in first 20 years when it comes to MI. But once these patients were followed for another 10 years, even that MI protection or reduction by 15% was p-value wise significant, although microvascular benefits were still identical even 10 years after those patients are out of that major UKPDS trial. And we know today, these days, with SGLT2 inhibitor or with GLP-1 receptor agonist, all MACE outcomes are much better. You talk about EMPEREC, there has been a reduction by 14%, and same was seen in Canvas trial in 3-point MACE by getting reduced by 14%, although declared TIMI initially has shown only 0.7% reduction, which was not p-value wise significant. But overall, if you see CVD with heart failure, that was significantly down by almost 22%, even in declared TIMI trial. But GLP-1 receptor agonist leader has clearly shown that with liraglutide, there was a reduction in 3-point MACE by 13%. And surprisingly, with injectable semaglutide in SUSTAIN 6, there was actually a reduction in overall 3-point MACE by 26%, which was very, very impressive. Once it comes to CV death outcomes in SGLT2 or in GLP-1 receptor agonist CV outcome trials or all cardiorenal trials in patient with type 2 diabetes, we know EMPEREC has only shown a CV death reduction by 38%. In fact, all 3-point MACE endpoints were driven through a reduction in CV death by 38%. And it was only in leader trial with liraglutide that there was a reduction in overall CV death by 22%, which was p-value wise significant. Although Pioneer in oral semaglutide has shown significant reduction by 51%, but p-value wise, it was not very, very significant. Once it comes to hospitalization with heart failure, consistently all SGLT2 inhibitor, whether it was EMPA, CANA, DAPA, or other etroglyphosylin, they have shown reduction in risk for hospitalization with heart failure by almost 35%, although GLP-1 receptor agonists in terms of heart failure have not shown much benefits except the leader trial with liraglutide. But once it comes to composite kidney outcomes in SGLT2 inhibitor or in GLP-1 receptor agonist, all trials are again unanimous, and they are aligned in terms of composite renal endpoints, which are down by almost 30 to 40%, maybe with EMPA, CANA, or DAPA. And similarly, a trend in reduction in albuminuria has been seen in leader trials, SUSTAIN, and even in REWIND with dulaglutide. So metabolic and CV kidney benefits of SGLT2 inhibitor in type 2, these are mediated through multiple mechanisms. So once we talk about drugs like SGLT2 inhibitor versus GLP-1 receptor agonist, these drugs are not identical, although actions seem to be synergistic, because with SGLT2 inhibitor, there is primarily diuresis, glucose excretion gets increased and natriuresis is there. So that leads on to change bioenergetics to the myocardium. There is going to be reduction in intraglomerular pressure, which reduces left ventricular wall stress and mass. And subsequently, there is a reduction in inflammation and oxidative stress. So preload and afterload gets corrected. That is how there is an immediate reduction in hospitalization with heart failure as early as 28 days. Renal composite endpoints also significantly go down. So is reduction in blood pressure, HbA1c, and body weight also. But once it comes to GLP-1 receptor agonist, again, mechanism proposed are different, because there is increase in insulin secretion, glucagon suppression happens with GLP-1 receptor agonist. Of course, it also leads on to natriuresis, diuresis, and appetite suppression. So there is true reduction in inflammation. Lipids also gets corrected, and coagulopathy also gets improved, and there is an improvement in LV function. That is how CV events are much altered in the long run, especially those patients who have established atherosclerotic cardiovascular disease with GLP-1 receptor agonist. There is a reduction in albuminuria, blood pressure, body weight, as well as HbA1c. Let's see what guidelines say once it comes to management of type 2 diabetes in relation to established atherosclerotic cardiovascular disease, presence of heart failure, or maybe diabetic nephropathy. So ADA 22 clearly said that after lifestyle modification and of course diabetes education, if we have to reduce overall burden of complication, it has not only to be the glycemic management, blood pressure management is equally important. So is the management of lipids, and all agents with proven benefits for CV risk reduction and kidney benefit or renal composite endpoints should be used early so as to get all these benefits. So guidelines are absolutely unanimous, whether you talk about ADA, ACE, or our own RSSDI, ESI guideline, that after HbA1c control, it is blood pressure control, which is very, very important. So is the control of cholesterol, which stands for C, and drugs to protect both heart as well as kidneys, like GLP-1 receptor agonist or maybe SGLT2 inhibitor. Of course, there is an importance of diet, exercise, which needs to be re-emphasized to every patient, and very early screening for complication. An effort to reduce smoking or stop smoking and stress management goes a long way as so as to reduce overall increasing burden of micro as well as macro angiopathy. So an early use of these drugs, which can protect both heart and kidneys, probably will go a long way in cutting micro as well as macroacute complication in these patients. So to conclude, understanding cardiovascular disease, heart failure, and kidney disease in patients with type 2 diabetes, it's a very, very strong and dynamic relationship which exists between systemic metabolism, heart failure, or heart involvement, and kidneys. Type 2 diabetes, CV disease, heart failure, and CKD are interrelated, because worsening of any one disease, maybe CV or heart failure or CKD, will obviously worsen another system also. So guidelines and societies recommend the use of agents with proven CV and kidney benefits, that too early in management of type 2 diabetes, especially if you have clustering of risk factors, presence of atherosclerotic cardiovascular disease, or presence of diabetic nephropathy or heart failure right in the beginning. Thank you very much. I'll stop sharing here and stand by for any interaction or questions.
Thank you so much, sir, for that excellent talk. And I request you to stay back for the discussion after the next speaker. So after changing tracks, we again come back to something which is very, very pertinent when it comes to managing type 2 diabetes. And we all know insulin resistance lies at the bottom of it. The soil, the fertile soil that insulin resistance offers to the NCDs of both diabetes and hypertension. To do the honors, I request our speaker, Professor Hesham Magdeldin, a master's degree in internal medicine, MD degree in internal medicine, a very experienced faculty, lecturer of internal medicine, assistant professor of Cairo University, and consultant internal medicine and endocrinology at Cairo University till now. So he is going to shed light on insulin resistance, the hidden danger. Welcome, sir.
Thank you very much for the introduction. I'd like to thank all members of this very highly
We can't hear
international
you.
meeting. Sorry?
We can hear. We can hear.
Yes.
I can hear. Yeah, please go ahead.
Okay. So we'll talk about
Maybe you
insulin
need to
resistance.
put on the computer audio. You're not audible. We can see you, but we can't hear you.
But I can hear him. What is it? But I can hear him. Rajiv, can you hear him?
Yeah. Dr. Hesham, please.
Okay, shall I continue?
Yes,
Yeah,
please.
can I continue?
Yes, please.
Okay. Just I want to start why I choose this to talk about insulin resistance, because in spite that insulin resistance has been around for many decades, but still we can all agree that its definitive mechanism is elusive. And maybe the interpretation of different assessment which we are encountering in our clinics sometimes confusing, and we are not clear about these measurements. And more, many times this insulin resistance is
Hesham,
used.
please share your slides. You have not shared your slides, sir.
Shared already.
No, they're not visible. Can you just unshare and share them again?
Okay. Just a minute.
Mahima, just help him out.
Yes, sir.
In the meantime, Dr. Vinod Kumar, any comments on deadly try of type 2 diabetes? So I think he's,
Yeah, he's back. Yeah.
He's back. Let us see.
yeah. Yes.
Yes.
Is it apparent now?
Slide.
Yes. Can you please make it full screen mode, sir? Yeah, perfect. Perfect.
Thank you.
Okay. Just I want to start why I choose this insulin resistance, because the concept is for many years, but it's still confusing. So I want to go through the historical background, giving a hint on the epidemiology, clinical presentation, and then how to assess and manage. Here we can see that it was since 1921 when firstly the animal insulin was produced from animal pancreas, and up till 36 when the concept of insulin resistance was first introduced. Then in 1979, glucose clamp technique was introduced by DeFronzo and others to measure the insulin resistance. And in 1895, the concept of homeostasis model was introduced. And then until now, we are craving for understanding more and more diabetes pathology, pathophysiology, and treatment. But in 2012, they recognized the insulin resistance as a hidden danger, because if untreated, it can lead to serious health consequences, as discussed before, the cardiovascular disease and others. And they said that interventions to improve insulin sensitivity can go a long way toward improving overall health. So if we can improve insulin resistance, we can get a good step in improving overall health of the subject. In 2020, it's still difficult to define what's insulin resistance. If we think, what's insulin resistance? Simply, it's an impairment of the biologic response to insulin in the target tissues, primarily the liver, muscle, and adipose. There is no clear-cut definition, actually, of insulin resistance. But for those who are using the exogenous insulin, it's defined as people need more than 1 unit per kg per day to maintain glycemic control. They have insulin resistance. For those who have more than 200 units of exogenous insulin, they have severe insulin resistance. The metabolic consequence of insulin resistance results in many problems like hyperglycemia, hypertension, dysglycemia, and visceral adiposity. This problem is not rare. Actually, it was estimated in the States that it affects up to 24% of adults above 20 years old. It increases to 40% for those over 50 years, and it can affect up to a third of patients with Alzheimer's disease. The presentation actually varies between people. Some people will have only obesity. Sometimes, as we will discuss more details, non-obese people have insulin resistance. But it can also reach to the cardiovascular problem, hypertension, the type 2 diabetes, the metabolic associated liver disease, others like cancer in different organs, hyperfiltration in the kidney, polycystic ovary, and more recently, the central nervous system. There is now what's called central insulin resistance, which is implicated in impaired energy homeostasis, blurred brain development and memory function, and Alzheimer's disease, sometimes called diabetes type 3. If we think about the mechanism of insulin resistance, we can say that the cellular effect of insulin occurs through two main post-receptors pathways. This is one of the phosphatidyl inositol kinase, PI3K, and the mitogen activated protein kinase, MAPK. Insulin resistance affects PI3K, which will result in the metabolic defects. But still, the MAPK is still intact, and the hyperinsulinemia can affect this pathway, causing cancer in many organs. And here we can say that the insulin resistance is in the core, in the crossroad of obesity, metabolic dysfunction, cognitive dysfunction, and obesity-related malignancy. Obesity through the mitochondrial dysfunction and endoplasmic reticulum dysfunction, with adiposity dysfunction, as discussed before in other lectures, gut microbiota dysbiosis, chronic inflammation will affect the insulin resistance. This through the PI3PK pathway impairment will cause hypertension, dyslipidemia, dysglycemia. On the brain, it affects the cognitive dysfunction, impaired learning and the memory. And then the hyperinsulinemia will act on the intact MAPK pathway, will cause obesity-related malignancy. At the same time, this pathway will cause more and more body weight, more and more obesity, and will go into vicious circle. And the only way to stop this one is the lifestyle factors. Here simply, the insulin, after attachment to the receptor, will pass through the insulin receptor substrate, affect the PI3K, which will cause the release of the GLUT4 secreting vesicle to the surface, causing glucose to enter the cell for glycolysis, glycogenesis, lipid lipogenesis, protein synthesis, and it will stop lipolysis. On the other hand, if the patient develops insulin resistance, we can see here that there is deposition of macrophages with the release of inflammatory cytokines, and at the same time, less movement of the glucose transport. This will cause increased free fatty acid production. These cytokines, inflammatory cytokines with the free fatty acid affect the muscle, will decrease entry of the glucose. At the same time, it will affect the liver. It will cause increased gluconeogenesis and decreased glycogenesis. So obesity can cause insulin resistance through chronic inflammation, mitochondrial dysfunction, gut microbiota dysbiosis, and more importantly, the adipose extracellular matrix remodeling. And on the other hand, insulin resistance can affect the metabolic dysfunction, hypertension through enhanced renal sodium reabsorption and hypertrophy of resistance blood vessels, dyslipidemia through the enhancement of the hepatic flux of free fatty acids. But recently, more important notes on the central effect of insulin, hyperinsulinemia, can result in degeneration and irreversible impairment of memory. Then it will affect the blood-brain barrier itself, causing less insulin to the brain. This will increase the levels of cerebral beta amyloid and tau protein, which is associated with Alzheimer's disease. This to show that the insulin resistance is at the crossroad of obesity and associated diseases. Here, the factors that mediate effects of obesity are chronic inflammation and others, the metabolics, hypertension, dyslipidemia, dysglycemia, non-alcoholic fatty disease, cognitive affection, cognitive dysfunction, learning deficiency, memory impairment, and there is possibility to reverse or to ameliorate this effect through the lifestyle, physical activity, optimized dietary fat, limited dietary carbohydrates, and optimized sleep. Here, it's not obesity, as mentioned before. It's not obesity per se, it is the adipose tissue dysregulation. And this very nice study published in 2012 showed that it's not obesity, but rather the adipose tissue dysfunction. They studied the size of the cell, hypertrophy of the adipose tissue, and the ectopic deposition of adipose tissue in the viscera, in the muscles, and the liver, which are important. A nice study published in 2022, they studied the insulin resistant in population with heart failure, but without diabetes or overweight or hypertension. And so they found that in non-diabetic, non-overweight, normotensive patients with heart failure, insulin resistance was higher. So there is direct link between insulin resistance and heart failure. So insulin resistance is very important actually clinically. What are the different causes or risk factors? Actually, they can divide it into acquired, hereditary, or mixed. But most patients are the acquired group, due to excess dysfunction adipose tissue, aging, physical inactivity, nutritional imbalance, some medications, glucotoxicity, and lipotoxicity. There are some genetic syndromes like myotonic syndromes, ataxia telangiectasia, lipodystrophy, polycystic ovary disease, but the acquired form is the more common. How to assess insulin resistance? Maybe we have to know that we have different methods, not only homeostasis insulin resistance, which we are using in our clinic. There are many methods. Some are using the steady state analysis of glucose and insulin, but others, they study the dynamic testing after glucose introduction. This table to show that the direct measure is the hyperinsulinemic euglycemic clamp. In this test, we are infusing insulin to hyperphysiological level, and to prevent causing hypoglycemia, we are also infusing glucose. And from the steady state of insulin and glucose, using different equations, we can measure insulin sensitivity or insulin resistance. There are some tests like insulin suppression test, but there are simple surrogate indices like those derived from fasting steady state, the homeostasis model. In this test, just we'll draw a simple fasting sample and measure fasting insulin and fasting glucose and multiply and divide then by 22.5. It's called the homoinsulin resistance. The reverse of the log of this equation is called the QICI, the quantitative insulin sensitivity. This studies the steady state condition. But we can also use the oral glucose tolerance test after giving the patient 75 gram of glucose. We can measure also insulin and glucose, and we can, from using some indices like Matsuda index or gut index, we can get the insulin resistance. Here to show that we are in homoinsulin resistance, which is widely used throughout the world. We are multiplying fasting insulin by fasting glucose, dividing by 22.5. Why 22.5? Because it is the product of the normal plasma insulin and the normal fasting plasma glucose so that this can compare with the ideal normal individual. Still, there are other surrogate markers. We can use triglyceride. It was shown that in pre-diabetes, the triglyceride more than 150 gram, more likely to have insulin resistance. The percentage, the ratio of triglyceride to HDL ratio, if it's above than 3.5 in males or 2.5 in females, indicate insulin resistance, but this was not applicable in African-American individuals. So now, how can we evaluate insulin resistance? Actually, it should be clear that measures of insulin resistance have not been integrated into clinical guidelines. There is no guidelines integrating the insulin resistance. So as a result, the presence of insulin resistance is generally inferred, suspected, or you can detect it from the clinical presentation from the different components of the metabolic syndrome and insulin resistant syndrome. Here, now we are entering the era of the precision medicine diabetes. We can use the genetic background, the different clustering of patients to know which patients with insulin resistance can develop complications while others will not develop. Why some obese people develop insulin resistance while others not, while some non-obese people can develop insulin resistance. In the management, still the cornerstone is the lifestyle with less sodium, less fat, calorie restriction, attention to the glycemic index of food. Physical activity is very important. Regarding the pharmacological intervention, again, we should address that there is no medications are FDA approved to treat insulin resistance, but we have metformin, which tackle insulin resistance, is approved for pre-diabetes and diabetes and maybe polycystic ovary disease. GLP-1 agonist, as discussed in diabetes, sometimes in obese people, even without diabetes. Sodium glucose cotransporter 2 inhibitors, which can decrease weight and can help in ameliorating insulin resistance, and TZDs, which tackle PPAR gamma receptors, but they have some side effects. Even surgery, by bariatric surgery, we can decrease the fat content and we can decrease insulin resistance. Still, we have some investigational drugs acting on fat oxidation in muscle and liver and muscle mass, like myostatin, which are still in phase 1, 2, or 3. They are not yet released. What's bothering the patients actually when they are coming to our clinic is the prognosis. They are afraid and referred from some dietitian or so. They said, go to an endocrinologist to treat you from insulin resistance. So it should be clear that the prognosis of insulin resistance actually is dependent on many factors, like the severity of the disease, the pancreatic beta cell function, the hereditary, the susceptibility, and the spectrum of outcome ranges from nothing, mildly insulin resistant, to asymptomatic individual, to individuals with catastrophic cardiovascular or cerebrovascular events. So we depend on the follow-up of the patients until we have more precise data to recognize this patient. I want to finish with a message delivered by ADA in understanding insulin resistance. They said, what can we do about it? Actually, getting active is the best way to combat insulin resistance. And proper diet and weight loss, the importance of maintaining good eating habits to prevent or diminish insulin resistance is very important. No single or specific diet has been proved. Low carb, high fiber is the most important. No medications, again, are specifically approved to treat insulin resistance. The most important sentence which we have to say is, don't give up. It needs continuous support, continuous education, continuous follow-up, and thank you very much. Again, there is problem with sound.
We can hear you, but you are finished with your presentation, sir?
Yes.
Yes.
Okay, sir, you may take over, Dr. Vinod Kumar, sir, for discussion.
Okay. Well, thank you very much for very nice presentations. I have just very few comments. First, regarding Professor Mohammad Naguib about exocrine pancreatic insufficiency. I just wanted to clarify myself. The greater prevalence of EPI in type 1 diabetes compared to type 2 diabetes, what is the reason for that? Is it because of a longer duration of diabetes? Is it because of poorer control of diabetes in type 1 diabetes? Or is it predominantly played up by the autoimmune atrophy? What are the factors responsible for differential prevalence between type 1 and type 2?
First of all, thank you, sir, for this question. The reason why the incidence is higher in type 1 diabetes, that they have more factors added to cause the exocrine pancreatic insufficiency more than type 2 diabetes. Let us specify that in type 1 diabetes, they are absolutely void of insulin. They don't have insulin at all. So they lose this trophic action of insulin on the exocrine pancreas. Moreover, that most of cases, like we say, that type 1 diabetes is of autoimmune etiology. So the autoimmune etiology of type 1 diabetes also adds to the causation of exocrine pancreatic insufficiency. While in type 2 diabetes, we know that they are they have insulin, they have less insulin that they need. So the presence of insulin so the presence of insulin, even if in less than needed amounts, that might cause diabetes, but it is sufficient for the exocrine function to be done. So in type 2 diabetes, it needs to depend more on the neuropathy and the microvascular disorder that they develop, of course, in later courses of the disease.
Thank you. A very brief question to Dr. Rajiv Chawla. Would you like to point out the cohort of patients who are non-responders to SGLT2 and GLP-1 agents as far as their cardiorenal protection is concerned?
Yeah, I think it's a very multi-dollar question, and this has been addressed to in a session. We have a complete session on that, who are non-responder to GLP-1 and SGLT2 inhibitor, because of late we have noticed that many patients, in spite of having clustering or risk factor where you think that there is a multiple CV risk factors are there, or they have diabetic nephropathy, or they have incipient heart failure, reduced ejection fraction. Even if you start them on SGLT2 inhibitors, you may not have the desired effects. And similarly, that is true for GLP-1 receptor agonists also. Actually, non-responders are much more common with GLP-1 receptor agonists. Anyone who has multiple CV risk factor with established disease, they are ideally the candidate for long-term prevention of CV death by putting them on GLP-1 receptor agonists. But of late, many studies have shown that there are certain patients who don't respond at all, neither in terms of HbA1c reduction nor in terms of overall cardiovascular risk in the long run. But I think we'll have a complete session on that, and I'll not say much more on that.
Okay. Thank you. Now it's open to discussion.
Professor Inas, I would request you also to join us for these discussions, please.
She's there, she's logged in, but maybe. Mohammed, will you like to comment on cardiorenal continuum? Is one of the good topics for you, because you have been talking of late. I've heard you a couple of times that we need to address cardiorenal continuum, what I also tried to allude in my presentation. Any comments from your side once it comes to management of type 2 diabetes as a whole or as an holistic approach?
Sorry, Rajiv, you're asking me, correct?
Yeah.
Yeah. Yes, you're absolutely right. This is really a crucial point. that we need to be proactive with this. So we need to screen for this primarily, specifically for for renal, the diagnosis is based on lab. So we have numerical aspects for it, which is easier to detect. But for the undiagnosed cardiovascular disease, whether it's peripheral arterial disease or heart failure or ischemic heart disease, this needs a proactive process. And we are in the middle of writing cardiometabolic recommendations as a collaboration between the diabetes and the cardiac societies of United Arab Emirates, so that we can make it simple for the generalists, the primary care physicians, of what should they do. And in many cases, especially in our communities with sedentary lifestyle, there is a lot of undiagnosed cardiovascular disease that with a bit of probing, you will establish that these people do indeed have these conditions.
So that means even if there is a silent disease or patient is asymptomatic with clustering or risk factor, we must screen this patient early, and based on the presence of all these risk factor, therapy is guided to reduce cardiovascular as well as maybe a renal composite risk reduction should be ideally targeted.
Absolutely, because they might be not silent, but it's just that we didn't ask enough, or that the person's lifestyle is very sedentary, that they are not exerting themselves enough to realize that they've got ischemic aspect or a heart failure aspect to their health. And once this is probed, it becomes evident that they are with these problems. Of course, there are other tools nowadays that are potentials for investigation, such as the ProBNP. And whether it's cost effective in every single community or not, it's an important point. But at the end of the day, it's a lab test that potentially could put the person at a different level of risk.
What is your take on metformin as per ESD guideline you discussed in greater detail? Once it comes to our own Indian guidelines, RSSG, Endocrine Society of India, even in 2022 RSSG guideline, we still insisted that metformin has to be first line option after lifestyle modification, because evidence is still great in favor of metformin. But ESD and ADA guidelines, these are talking about options like SGLT2 or GLP-1 receptor agonist even ahead of metformin. What is your take on?
Well, I suppose for the odd occasion when you diagnose a person with diabetes in the cardiac unit, or after some investigation that shows a renal abnormality, then you will ask yourself the question, do I have to give an SGL2 and metformin, or just SGL2? Let's assume that this person have reasonable glycemic level. So here comes the question of, should I start with metformin as well? And I don't think we should be fussed too much about this, because this is the rarity. The vast majority of people with diabetes develop these complications a bit later. But for the sake of the argument, if you're now visiting a patient in primary care unit and they tell you, we found that this person has diabetes as well. Now, should you give them dual therapy or monotherapy if their HbA1c, let's say, is 7%? The SGL2 would come here regardless of the glycemic level. But then the question would be, should you also add metformin or not? So I'm a bit on the fence on this point. Having said that, this is the minority of our patients. The majority of our patients are diagnosed with hyperglycemia, and during the assessment, we need to find out whether they have other conditions or not.
I think very well. Professor Hisham, you talked about insulin resistance as a hidden danger. In your own ethnicity, like as we discussed with Mohammed just now, we still insist that insulin resistance being a core defect, if you cannot give pioglitazone to everyone, at least metformin should be given to address the issue of core resistance. What is your take on that in your ethnicity?
I totally agree, Doctor. Very nice comment. Thank you very much. Of course, as we discussed, that insulin resistance is a hidden danger, even before the development of frank diabetes in the stage of pre-diabetes. Sometimes we call it the honeymoon period for us, that we can prevent many complications of diabetes. So I think we can get metformin, and I think some authorities, they can give glitazones, but because of the side effects, it's better to start with metformin. And of course, the most important, as we discussed, is the lifestyle. Being active, good dieting, good habiting diet, good sleep is the cornerstone.
Over to you,
Can I ask a
Professor
question?
Vinod Kumar, sir.
Professor
Can I ask a
Hasham,
question?
Professor Hasham, if we wish to find out the prevalence of insulin resistance in a population, what kind of test you would recommend for population screening of insulin resistance, which largely otherwise remains hidden?
Yeah, this is of course, urgent question, actually. As mentioned in the literature, the hyperglycemic clamp is a gold standard, but only in research work. In a population-wise, the homoinsulin resistance is the one still used. Maybe we can use in our clinics the triglyceride or the triglyceride, the ratio of triglyceride to HDL. As I mentioned, it's increasingly recognized as a method to detect insulin resistance. In addition to the clinical presentation, obese people, some with hypertension, prediabetes, high triglyceride level, we can detect. So clinical plus homoinsulin resistance, I think, will be the population-wise method in the epidemiology studies.
Okay, thank you.
You're welcome.
Can I ask a question? And perhaps this can go to anyone of the faculty. What are your opinion about a polypill that includes a low dose TZD, pioglitazone, a generic SGL2, and a metformin?
Fortunately, it's already available in India. We are using generic SGLT2, and pioglitazone is very, very reasonably priced here. So is metformin, and these drugs are triple drugs are already available in India.
So
now
as a single
even
tablet,
SGLT2, gliptin, and metformin also. This has been approved by DCGI.
as a single
one
tablet,
pill.
maybe.
In
Pardon?
one
In
pill,
one
you
pill.
mean? In one pill.
One pill, yeah. It's available as FDC, single drug. FDCs are
available in
very
India?
popular in India. One is because of cost and because it reduces burden. So all proven drugs, for that matter, even if you go to DCGI, you don't have to do phase 3 again. If these are proven drugs with evidence already, only thing is couple of patients for maybe 3 months or 6 months, you prove that this FDC is good and you get a approval. We have these days almost SGLT2, gliptins, metformin already available. Pioglitazone, Glimpride, metformin was available for good 10 years in India. We have
No,
already.
but do we have a pill with pioglitazone, an SGL2, and a metformin?
No,
Not yet.
we now have a pill with SGLT, DPP4, and metformin. We have that
Yeah.
pill available now in India.
Yeah,
It
I
just
understand that.
Pioglitazone is
but-
still not yet here in the
Yeah.
form of a polypill.
Pio with
I
metformin
wonder-
and Glimpride is available.
Yes.
There is one company which is coming up with pioglitazone, remogliflozin, and metformin,
Yeah.
which is not in the market. And I think in another 1 month it should come.
Yes.
I hope some industry person is hearing you and this might click again.
Well, I hope that the research will be initiated for such a pill for maybe 2 to 3 years, because all of them have cardiovascular benefits, and the cost could be very, very
Competitive.
interesting or affordable for many of our communities.
Maybe Professor Hassanin already started the company who's going to manufacture this pill, and he wants just some partners to share in the company. So he's asking about our opinion if we want to share in this company.
Listen, if I have that company, I will not ask you for shares.
No? Okay.
Good. I think, Dr. Shalini, you may close the session if there are not much of.
You're muted, Shalini.
Since we do have some time and we finished well in time, so I thought if we have any time for any closing comments with anybody. I think we've done ample discussion, so we move on to the next session. To chair the next session, may I now invite our chairs, Dr. Girish Khurana and Dr. Rajiv Chawla, Dr. Girish Khurana is a consultant physician and diabetologist practicing in the state of Delhi and a member of the Executive Council of RSSDI. So welcome, Dr. Girish, and may I ask you to invite our next speakers, please?
Thank you, Dr. Shalini, for your kind words. Now, I would like to invite our next speaker, Dr. Arvinda Jagdisha, who is a well-known figure. He is from Bangalore, and he is MD Internal Medicine and FRCP from all the three distinguished colleges, Edinburgh, London, and Glasgow. And he is Chairman and Chief Diabetologist at Arvinda Diabetes Care Center at Bangalore. And he has a vast experience of working in various hospitals abroad also. And he is also the achiever of so many awards from Economic Times, Times of India, Civilian Award. He is always there in most of our conferences with presentations. And recently he has been elected as president of RSSDI EC body also. So may I invite Dr. Arvind Jagdisha to present his deliberation on CKD in diabetes.
I'll share my slides. Are you able to see my slide?
Yes, it's visible, Dr. Arvind.
Yeah. So good evening, everybody. At the outset, I thanks Dr. Rajiv Chawla and Dr. Shalini Jaggi for making me a part of this wonderfully organized scientific extravaganza conference. Thanks, Dr. Girish, for the nice words. Today, my topic is on management of hyperglycemia in chronic kidney disease. So first of all, greetings to all of you from Bangalore. So this will be my outline of my talk: overview, burden, prevalence, CKD classification, pathogenesis, management of hyperglycemia, age recommendation. Overview of chronic kidney disease. It is defined based on the presence of either kidney damage or decreased kidney function by the presence of reduced glomerular filtration rate and or increased urine albumin excretion for 3 or 4 months, irrespective of the cause. So diabetic kidney disease is one of the leading cause of CKD in diabetes mellitus. Chronic kidney disease is common in people with both type 1 and type 2 diabetes. On the right side of the slide, you can see the various risk factors, that is RAS, obesity, dietary protein intake, smoking, oligonephropathy, genetic factors, hyperlipidemia, glycemic control, proteinuria, glomerular hypertension, and systemic blood pressure. So if you go by the burden, the presence of CKD and diabetes individually or especially in combination have a huge economic impact. So diabetes is estimated to cost $245 billion, both like in indirect medical cost is around $176 billion and lost productivity is around $69 billion. In 2013, the CKD estimated to cost $50 billion in Medicare patients over the age of 65, amounting to 20% of the health expenditures of the group. Prevalence, starting on the left-hand side of the slide, according to the CDC in 2017, about 10% of the adults in the US are estimated to have CKD. Diabetes is the most common or leading cause of CKD. According to this, second one is according to the CDC in 2017, approximately 21.3 million people in the US have diabetes. At this rate, it is estimated that by the year 2050, perhaps as many as 1 in 3 adults may have diabetes. The prevalence of persistently, moderately to severely increased albuminuria in diabetes patients decreased from approximately 20% during the period of 1988-1994 to approximately 15% during the period from 2009 to 2014. By contrast, the prevalence of decreased eGFR, defined as an eGFR less than 60, increased from approximately 10 to 15%. We all know about this particular classification, that is chronic kidney disease classification based upon the GFR and the albuminuria. So it has been, depending upon the GFR, it has been staged into G1, G2, G3A, G3B, G4, 4 and G5, starting from normal to the severe kidney failure. Based upon the albumin excretions, it has been classified into A1, A2, A3, that is less than 30, 30 to 300, and more than 300 milligram of albuminuria. So pathogenesis, if you say, this is the proposed pathogenesis, how the diabetes can cause the diabetic kidney disease, like metabolic factors like polyol pathway, exosomin pathway, protein kinase C pathway, age-related pathways, and the hemodynamic factors, that is the systemic and the glomerular hypertension. These two things leads to activation of intracellular signaling pathways, oxidative stress, dysregulated autophagy, and epigenetic changes, leading on to inflammation, fibrosis, finally to the diabetic kidney disease. On the right hand side of this slide, you can see how the healthy kidney looks and how the kidney disease kidney looks. Coming to the topic of my discussion today, that is the management of hyperglycemia. So the good glycemic control is important in patients with diabetes and CKD. So glycemic control has been shown to prevent the onset and progression of nephropathy. It is potentially beneficial to keep the HbA1c within an optimal range. While AAC advocated on HbA1c of less than 6.5, target of EASD and ADA advocated less than 7. So both guidelines emphasize that in the presence of renal failure and HbA1c goal still need to be personalized. No specific numerical HbA1c target was put forth by either group specifically for patients with renal dysfunction. So this is an interesting slide showing the kidney heart risk factor management in patients with diabetes and CKD. You can see in this pyramid from the bottom, if you go, the first one is the main thing is diet, exercise, weight management, and the smoking cessation. The second one is the first-line drug therapy like metformin, SGLT2 inhibitors, RAS blockade, and statin. And at the top, you can see the goal-directed therapy, that is the treatment, that is GLP-1 RAs, TZDs, NSMRAs, anti-platelets therapy, lipid management, glycemic control, and blood pressure control. So this is the holistic approach for improving outcomes in patients with diabetes and CKD. The topmost is the lifestyle, that is healthy diet, that is the most important thing, followed by physical activity, smoking cessation, and weight management. The second one is second line, you can see the first line drug therapy, the SGLT2 inhibitors. Very important to note, initiate SGLT2 inhibitors if eGFR is more than or equal to 20, and it can be continued until dialysis or transplant. Metformin if eGFR is more than 30. Next comes the targeted therapy, that is GLP-1 RA, if needed to achieve the individualized glycemic target or if persistent albuminuria. Next, other glucose-lowering drugs if needed to achieve the individualized glycemic target. On the right-hand side, you can see The other drugs like RAS inhibitors at maximum tolerated dose if a patient is hypertensive. Then non-steroidal MRAs if persistent albuminuria and normal potassium, that is spironolactone. If for blood pressure, you can other concentration can calcium channel blockers plus or minus diuretic to achieve the individual targets. Next, if it is still is an issue, then you can go for steroidal MRA if needed for resistant hypertension like spironolactone. On the extreme right hand side of the slide, you can see the moderate or high intensity statin. Next is the antiplatelet agents for clinical ASCVD. Next is the ezetimibe or PCSK9 inhibitor or icosapentaethyl if indicated based upon the ASCVD risk and lipids. So physical activity, nutrition, weight loss is the main cornerstone of the treatment of diabetes with CKD. Always the temptation is to look for the dosages of metformin, SGLT2 inhibitors, then the other, and then comes the other drugs. So if you take the SGLT2 inhibitor dosage, if you dapagliflozin 10 milligrams daily, so what are the study backup for this? So the DAPA CKD study has shown dapagliflozin 10 milligrams can be started if the eGFR is more than 25, and DAPA heart failure and declared study has showed if eGFR is more than 30, DAPA 10 milligrams can be started. Dosing approved by the US FDA if the eGFR is more than 25 ml per minute. Next comes the EMPA 10 milligrams daily. EMPA reg study has showed it can be initiated if eGFR is more than 30. Emperor reduced and Emperor preserved has shown that EMPA 10 milligrams can be started if the eGFR is more than 20. So approved by US FDA is if EMPA 10 milligrams OD can be started if the eGFR is more than 30 ml per minute. Next, the canagliflozin 100 milligrams daily. If eGFR is more than 30 as shown in the CREDENCE study, and it has been approved by US FDA as well. So this is a beautiful slide from KDIGO 2020 clinical practice guidelines for diabetes management in chronic kidney disease. What does it say? It looks very busy, but if you go through the individual things, you can, if somebody is interested, can take a snapshot of it. What does this shows is patient's factor influencing the selection of glucose lowering drugs other than SGLT2 inhibitors and metformin in type 2 diabetes and CKD. So just I'll give you an example in this circle. Just you see that avoid hypoglycemia, that column you follow up. So the more suitable medications are GLP-1RA, DPP-4 inhibitors, glitazones, and alpha-glucosidase inhibitors. On the pinker side, you can see the less suitable medications, that is sulfonylureas and insulin. Like that, if you go individually, you will be able to decide according to the patient's need, whichever the drug is beneficial. So the metformin, slightly I'll go into detail about metformin because it has been universally used in the management of diabetes. On the left-hand side, if you concentrate in this slide, metformin is recommended treating patients with type 2 diabetes and CKD and an eGFR more than 30 ml per minute. Treat kidney transplant recipient with type 2 diabetes and eGFR more than 30 with metformin according to recommendations for patients with type 2 diabetes and CKD. Monitor eGFR in patients treated with metformin. Increase the frequency of monitoring as and when needed. On the right hand side of the slide, you can see adjust the dosage of metformin when the eGFR is less than 45, which is an important thing to be noted. And most important thing is recommendation is from KDIGO is monitor patients for vitamin B12 deficiency when they are treated with metformin for more than 4 years. In the center, this is the pictorial demonstration of how we can use the metformin. Next, the GLP-1RA. In patients with type 2 diabetes and CKD, on the left-hand side, kindly see this. In patients with type 2 diabetes and CKD who have not achieved individualized glycemic targets despite use of metformin and SGLT2 inhibitors treatment, or who are unable to use those medications, we recommend a long-acting GLP-1RA. The choice of GLP-1RA should prioritize agents with documented cardiovascular benefits. To minimize gastrointestinal side effects, start with the low dose of GLP-1RA and titrate up slowly. On the right-hand side, you can see the GLP-1RA should not be used in combination with the DPP-4 inhibitors. This is an important line because sometimes in a busy practice, there might be a confusion of adding both. So you should be very, very cautious about this particular thing. Then the risk of hypoglycemia is generally low with GLP-1RA when used alone, but its risk is increased when it is used with sulfonylureas or insulin. So the dosage of sulfonylureas or insulin may need to be reduced. So GLP-1RA may be preferentially used in patients with obesity, type 2 diabetes, and CKD to promote intentional weight loss. So in the center of the slide, you can see the dosage for various available GLP-1RA and dose modification for CKD. If you see the available in the market, that is most frequent, easily available in the market is dulaglutide and semaglutide injection. For important thing to note is there is no dosage adjustment needed, and it is recommended to use if EGFR is more than 15 for dulaglutide, and sema and oral as well as injection. There is limited data for severe CKD. So this is once again showing the dosage of dulaglutide. You can see no dosage adjustment used with the EGFR more than 15 ml. Semaglutide, no dosage adjustment required. There is a limited data for severe CKD. So non-insulin and insulin preparations in CKD patients, you can see the various drugs and the recommendation starting from the biguanides, metformin, sulfonylureas. Yeah, this is the commonly asked question, like which ones to use, whether it is glipizide, gliclazide, glimepiride, and you can see that the comfortable to use when the EGFR is more than 45. Then pioglitazone when EGFR is more than 60. Alpha glucosidase inhibitors like acarbose if the EGFR is more than 60. GLP-1 analogs, as we discussed, DPP-4 inhibitors. Linagliptin is one of the drugs where no dose adjustment is needed, whereas other drugs like sitagliptin, vildagliptin, and saxagliptin, the dosage has to be reduced to half. Next comes at the bottom, you can see the rapid-acting insulin, long-acting insulin, and the pre-mixed insulin. All of them need to reduce the dosage by 25% when the EGFR is between 10 to 50. Adjustment of inpatient insulin regime in CKD. This is about the insulin now. The stable CKD stage 1 and 2 with no hypoglycemia, no dose adjustment is needed. According to the sugar values, you can titrate the dosage. In CKD stage 3, that is EGFR between 30 to 39, decrease the dosage by 30%. In CKD stage 4 by 50%. In CKD stage 5 by 60%. So the dosing of insulin therapy in chronic kidney disease, on the left-hand side, you can see if the EGFR is more than 60, in type 1 diabetes is 1 international units per kg, and in type 2 diabetes is 0.5 international units per kg. If it is between 15 to 60 EGFR, then it is 0.75 for type 1 and 0.3 to 0.4 international units per kg for type 2. If the EGFR is less than 50, then it is 0.5 international units per kg, and 0.25 international unit per kg for type 2 diabetes. Then on the right hand side, you can see the dosing and titration of insulins in CKD, more than 60, no reduction, between 15 to 60, 25% reduction, less than 15, 50% reduction. So that always we should note an important point is the two things which may happen dramatically and drastically in diabetes with CKD is hypoglycemia and hyperglycemia because of the reduced renal clearance. These are the two conditions which may profusely create a problem in our patients. So always keep educating the patient regarding hypoglycemia as well as hyperglycemia. So these are the recommendations according to the ASE in diabetic patients with the CKD. This looks a busy slide, but only thing the recommendation is when do you monitor the creatine level or EGFR level or UACR. Almost the creatine level is out of question now. The recommendation is to monitor EGFR and UACR to prevent the progression of diabetes with CKD. So ladies and gentlemen, take home message from my talk today is diabetic kidney disease is one of the leading cause of CKD in diabetes mellitus. Approximately 1 in 3 adults with diabetes may have chronic kidney disease. Chronic kidney disease is classified based upon glomerular filtration rate and albuminuria. Glycemic control is important in diabetes and CKD, which has been shown to prevent the onset and progression of nephropathy. Management of hyperglycemia includes lifestyle modification and glucose lowering agents like insulin and non-insulin preparation. Thank you for your patient hearing, and I thank once again Dr. Rajiv Chawla for giving me this opportunity. Thank you so much.
Thank you, Dr. Arvind, for an excellent deliberation covering almost all aspects of the CKD and its management. Very well spoken and beautifully illustrated. And I think we'll take the questions in the end. And I'll ask my senior Dr. Rajiv Chawla to, if I have to introduce, or are you going to introduce?
Girish, you may do, yeah, please carry on.
So the next speaker is Dr. Mithun Bhartiya, who will speak on diabetes and ED. He is a diabetologist from, I think, I don't know from which city he is.
He's from Guwahati.
Okay, he is from Guwahati and he has number of credentials on his name. He is MRCGP, MRCP from UK. And he has also experience from CCT from UK and Mayo Clinic USA. And he has won a Newman Prize for his work on diabetes, testosterone, and erectile dysfunction. And he is a task force member of RSSDI Technology Group. And he represents India at Worldwide AGP Clinical Academy. And he is a founder secretary of Association of Clinical Endocrinologists. I think we will learn
very sought after endocrinologist in West Bengal and Guwahati, because he manages all those patients with diabetes ED. So very, very popular.
And this is a subject which demands a lot of discussion, and people, they are not well versed with the subject also. Now, may I request Dr. Mithun to please start.
A very warm good evening to everybody. And first of all, thank you so much, Dr. Salini Jaggi, a very close friend of mine, and Dr. Rajiv Chawla, sir, a mentor of mine, for this kind of opportunity. And I wish the conference a grand success, as always it has been. So today my job is cut out. I've been asked to speak on diabetes and erectile dysfunction. And I think this is a very important topic, and I'm very honored to speak on this topic. And I'm very grateful that the organizers have kept this topic for the meeting. So I think before I say that, I'm gonna say I've been guilty. I've been guilty of not being able to provide all patients that have come under my remit the right treatment in my training years. And that is the purpose of the talk, so that people who listen to me do not do the same mistake that I have done. Because the ultimate ignorance is not rejection of something you know nothing about. Yes, refuse to investigate. So something that you don't know, you need to, and you're refusing to investigate, is ultimate ignorance. You see, we are representative of what our childhood is, what our beliefs have been, what we have seen in life, what we believe, or what our parents have taught us. And that actually creates the basis of bias in our clinical life. You know, I'm born in an era where Tom and Jerry could never be friends. And when I saw this picture on the side, the life of dog, cat, and a mouse, I find it difficult to believe. Because it goes against the whole ecosystem of my upbringing. It goes against all my comical Cartoon Network has destroyed in my presence. And this is what is very important when we deal with sexual medicine. It's very important when we deal with diabetes and sex. We need to keep our bias in the cupboard and lock it and go to the clinic and see these patients with a fresh mind, with no bias as to what you would say. No bias that you will say, Are, you have become old to get sex. No bias that you say, Are, if you are having sex, want someone that is good enough. No bias in saying that, you know, it doesn't matter at this point of time if you have sex or not. You must treat these patients with an open mind, because it takes a lot of guts with a patient who's got sexual dysfunction to come and ask you for help. And you may be the only hope in his life, because if you dismiss this patient, he may not have the courage to go to some other person that may be there. Because there's a dichotomy in clinical practice, because we clinicians ask about in diabetic clinics, we would ask about blood pressure, cholesterol, feet, eyes, but we don't talk about sex. And we believe if he has a problem, he's going to bring it out. And similarly, the patient believes that the doctor has got such a long list of asking us. If he felt that sex would be affected by diabetes, he would ask me. And this dichotomy, who suffers is the patient. And I remember long ago, when it's not a few years ago now, when I was in England, I was there for 14 years, and I was doing an adolescent diabetes clinic. And I was faced with a 14-year-old man, boy, or men, whatever you can call them, young men. And I was trying to tell him, look, you need to get your diabetes under control, because this may improve your, reduce your risk of complications, micro and macrovascular and blah, blah, blah. And he was listening, but he was not listening. And then he asked me a question, Doctor, you tell me what is something that will have an impact on my life as a youth. And I said, this may affect your sex life. And trust me, he just converted into a new leaf. He got his sugar under control. Everything was under control. So you must hit the iron where it is hot. Not just for the purpose of getting his sugar control, but you are well aware that diabetes increases your risk and complications of sexual problems. And in men, erectile dysfunction is the most common side effect that are there. Now, we are all clinicians. And when we are clinicians, it's important to talk about in a case-based scenario, because that kind of makes the essence of a talk. And that's what we do in real life. So if I bring upon a talk of a 60-year-old diabetic comes to us with erectile dysfunction, he tries a cheap PD5 OTC. You see, in India, pharmacy sells everything, even without the license of a pharmacist. And it did not help him. And the total duration of sex is 2 minutes, and he comes to you, he's paid your consultation, he needs advice. And he asks you, what should I do, doctor? You see what answer you're going to give. Are you going to say, look, prescribe, you've taken a cheap PD5, take a branded PD5? You're going to say, forget sildenafil, try a longer acting, a weekender tablet like tadalafil? You're going to tell him you're too old, or none of the above? I'll give you a few seconds to recap and understand this scenario. It's a very common scenario that has come to us. Because what you need to understand in this patient, what is he trying to tell you? And so with that, let me go to the physiology of erection. I'm going to go back to the scenario. You see, we have 5 sense organs in our body. When these 5 sense organs are stimulated, the sex center in the brain is stimulated, and the sex center in the spine is stimulated. When the sex center in the spine is stimulated, there's nitric oxide secretion, and via the cyclic GMP pathway, there's secretion of guanyl cyclase. And there's cavernous and smooth muscle relaxation, and that is penile erection. Now, well, then the erection goes down because of the PD5 enzymes. The cyclic GMP is converted from cyclic, back into the pathway of GMP. And so this is where the PD5 inhibitors work upon in reduction this. So what PD5 does is that it keeps the blood in your penis a little bit more longer so that you get an erection. So I think the scenario what we're talking about, you need to understand, is that people get often confused between ejaculation and erection. And it's very important that you understand this and prescribe the right medication, whether the patient has an erection problem. If he doesn't have an erection problem, there's no point prescribing a PD5 inhibitors. So if he's going to ejaculate early, then the problem is the ejaculatory problem, not the erection problem. So that must be very clear for you to understand when you speak to this patient. Question number 2. A 45-year-old high-profile couple says that once he has ejaculated, it takes time for him to get an erection. So what do you do in this scenario? Do you tell the patient, you do better sugar control, you do tighter vascular control, do nothing, you give him Viagra again, and you say, I've often heard clinicians saying this, you try with somebody else, well, that should never be the advice of a medical profession and shouldn't be advised by anybody. And I think if you go back to the days of physiology long, long ago, mine is 25 years ago now, we just celebrated 25 years of medical life, is that I remember in class 11 and 12, we had to stimulate the nerve of a frog, and we saw the muscle twitching of the frog. And before the muscle twitching of the frog happened, second time, there was a gap before you could stimulate that again. And that, my friend, is the reality of this scenario, that it takes time for the person to reload the gun for him to get another erection. Because if you look at the model of Master and Johnson four-phase model, there's excitement, plateau, orgasm, and resolution. And in a woman, there are multiple cycles happening at the same time, whereas a man is monoorgasmic. Once this has happened, there's a refractory period before which the second stimulation goes to Dr. Jaggi's clinic and Chawla's clinic. A Google dive, they come with a lot of information in Google. I read that erectile dysfunction leads to heart attack. And he had erectile dysfunction 3 years ago, and he wants to know if this was true. So did his erectile dysfunction lead to his heart attack 3 years ago, which he's had? So is this the answer always yes? The answer is always no. Or use a get out of jail card, do something, say come back, we'll talk about it. Or partially yes. I think to understand this question, we need to go back to the vascular tree. We need to go to this excellent paper by Montossi. When he said that when there is 50% luminal obstruction, there is symptoms. You see the penile artery is between 1 to 2 millimeter. The heart artery is between 2 to 3 millimeter. And so forth. And if there's 50% occlusion, there is symptom. So if the penile artery, if there is 50% obstruction, there will be erectile dysfunction. And similarly, if the cardiac arteries got 50% occlusion, they're going to be symptoms. So if there's a small pipe and a big pipe, and obviously if it come to us with erectile dysfunction, at that time we had minimized these vascular risk factors. We could have prevented, not necessarily, but we could have prevented a full-blown myocardial vascular event that was happening. So ED is equal to endothelial damage, and we need to actually take care to bring things under control. The other factor which I'm going to bring about is when we're going to sit in a clinic and we're going to talk about sex, you need to make sure that you are comfortable talking about sex. Because if you are not comfortable talking about sex, the patient is never going to be comfortable. Especially if you're going to do a combined consultation with the men and the husband and wife, or the boyfriend, the girlfriend, whatever you can call it. Because it's very important to be comfortable. And Trust me, patients understand the body language. You need to understand why he's come. If he's had this problem for God many 10 years, why today has his wife threatened him? There could be a variety of reasons why this patient is presented today, and that should be understood. And what is more important to be understood is you must understand the lingo of the patient. As hard, as crude as the local language may be, it is better to talk to the patient in his own language. Because sometimes the linguistic barrier he may say he's got erectile dysfunction, but what he means to say is something completely different. So I think expansion of the question is very important, and you need to give concrete time to this patient to understand what he's trying to understand, because till he doesn't understand, you don't understand, you will not be able to prescribe. Every solution is not a PD5. You need to understand his ideas, his concerns and his expectations that he's come to see you, so that you can together formulate a plan of action which will be in his interest. You may want to take a more extensive medical history of the patient, understanding his medications, recreational drugs, and social history. And you must understand that what are you going to do in this diabetes clinic? Because when we are sitting in a diabetes clinic, I feel my job is to get him a quality of life that he or she deserves, and sex is an important part of the quality of life. It is important to understand that I cannot cure diabetes, and it's understand that sex is an important part of our life. And erectile dysfunction to a larger extent can be supported, can be improved for these patients. Now, there's a lot of hoo-ha about testosterone. So I'm just going to send the last few slides on testosterone. Because people check testosterone for erectile dysfunction. A lot of labs do testosterone in part of their packages that you get, and you are the interpreter of these reports. So let me get there are a lot of studies, there are a lot of FDA guidelines which, cause a lot of threat to testosterone. I think testosterone should be prescribed for people who are comfortable prescribing and who are dealing with it on a daily basis. If you're not dealing with it on a daily basis, if you're not abreast of the recent advances in testosterone treatment, please do not go, burn your hands or burn the patients with testosterone. So let's look at a T4DM studies. This was an excellent study done in Australia. It's a double-blind placebo-controlled 2-year phase 3 trial. It involved 6 Australian tertiary care centers, involved more than 1,000 men. They wanted to see if testosterone therapy prevented regression or reversed early type 2 diabetes beyond the effects of the community-based lifestyle program. And the results were outstanding. There was a 41% reduction in T2DM prevalence with testosterone replacement versus placebo. So I think important fact, which I'm going to conclude my slide on, is what appears is not just true. You might see a well-built person and handsome person, but that doesn't mean he doesn't have erectile dysfunction. It's very important to bring about the subject in a delicate manner and address it, because this patient will be yours for life, and you will get good wishes for from this couple throughout your life if you can sort this little bit of, just took a little bit of insistence in talking about the problem. With that, I would end my talk. I would say men can survive earthquakes, experience the horrors of illness and all the tortures of the soul, but most tormenting tragedy of all time will be the tragedy of the battlefield. This is Leo Tolstoy. And with that, I once again thank the organizers, Dr. Jaggi and Dr. Chawla, for giving me the opportunity to present in this outstanding meeting that they've conducted. Thank you so much.
Thank you, Dr. Mithun, for a talk which is very subject not much spoken about, and you have beautifully told us how to take the history and how to go for the problems, because PD also is a part of risk factors in diabetes like CAD. So it is another risk factor which one should be very much careful. And these PD inhibitors, if patients, they are of CAD, long-standing diabetes, they again are at risk for myocardial infarction and other cardiac problems. So we'll touch this subject more in our discussions later on, Before that, I would like to invite our last speaker of this session, Dr. Vinay Kumar Dhandania from Ranchi, and he is going to speak about diabetes management in CLD. Dr. Vinay is a graduate from Mumbai with diploma in diabetology, and he is secretary RSSDI Jharkhand State, life member of many associations, and he is a principal investigator for ICMR in diabetes study from Jharkhand, having various publications in national and international journals of repute. And he has his own center where he runs diabetic center at NMMSS and Orchid Medical Center at Ranchi. So over to Dr. Vinay for your deliberations.
Good evening, and at the onset, I would like to thank Dr. Rajiv Chawla and Dr. Shalini Jaggi for this very kind introduction. Am I audible?
Yes, you're audible.
Yeah, thank you. And I thank you very much, Dr. Khurana, for that very kind introduction. I'm going to talk on this very important topic, which we see in clinical practice. Management of diabetes in patients with chronic liver disease, cirrhosis of liver. I focus on cirrhosis of liver. Yeah, cirrhosis of liver is associated with diabetes, and we see it very, very frequently. If you see the prevalence, it's 15 to 50% patients have diabetes mellitus, and prevalence of diabetes in patients with CLD is reportedly 18 to 71%. Glucose intolerance being 80% with CLD and diabetes being 30 to 60%. So you can imagine the association is very, very high. And in patients with liver cirrhosis, glucose intolerance and diabetes together can present in almost 96% of the patients. And this is the global data. And from Southeast Asia, you can imagine it's almost 57.9%. It's very, very high from our own region. So diabetes and chronic liver disease, it negatively affects the development and progression of chronic liver disease of various etiologies. And concurrent diabetes and CLD are also associated with worse clinical outcomes with respect to mortality, the occurrence of hepatic decompensation, and the development of hepatocellular carcinoma. So you can imagine the consequences of complications of CLD in patients with diabetes. Unfortunately, early diagnosis and optimal treatment of diabetes can be challenging due to lack of established clinical guidelines, as well as the medical complexity of this patient population. And cirrhosis is largely associated with diabetes. And I said almost 80 to 90% of the patients have diabetes mellitus or some form of glucose intolerance. So there could be something called as hepatogenic diabetes, and hepatogenic diabetes is characterized by development of hyperinsulinemia, insulin resistance, and beta cell dysfunction, and all these three leading to glucose intolerance and diabetes in patients who are basically having chronic liver disease, but they are non-diabetic. So this is the basically pathophysiology behind hepatogenic diabetes. And the clinical difference between the hepatogenous diabetes and type 2 diabetes mellitus is that hepatogenous diabetes mellitus is after the cirrhosis onset, and type 2 diabetes is before cirrhosis onset. Clinical presentation could be normal HPG and HbA1c and abnormal OGTT, as I said, simple glucose intolerance. And diabetic patients have diabetic range of fasting and HbA1c. It is less frequent. Hepatogenic diabetes, type 2 diabetes is more frequent. Vascular complication is less frequent. Liver complications are more frequent, whereas liver complications are less frequent. So these are few important differences between hepatogenous diabetes and type 2 diabetes mellitus with CLD. And this is how we can we need to make a good diagnosis before proceeding for treatment. Implications of diabetes in liver cirrhosis is very, very important because of the different studies which we have, the randomized studies, the cross-sectional studies, the case control studies, which all categorically warn that hepatic encephalopathy and severe hepatic encephalopathy is much higher in diabetics compared to non-diabetics with the liver cirrhosis. Complications of diabetes in CLD would be hepatic encephalopathy, in decompensated liver disease. It could be variceal hemorrhages. That could be the early sign. hepatocellular carcinoma, especially with patients who have associated hepatitis C virus or hepatitis B virus associated with diabetes and chronic liver disease. Even the mortality is very, very high. Many studies have indicated that diabetes significantly reduces the survival rate in patients with CLD and liver cirrhosis. So this is again very, very important to understand that patients with CLD should be very, very intensively monitored and treated under closed observation in a team of gastroenterologists, hepatologists, and diabetologists. Liver transplantation is another important issue that again leads to increased fasting plasma glucose levels as a risk factors for new onset diabetes after liver transplant. So post-transplant, post-liver transplant diabetes is also a common associate. Pre-transplant diabetes is a major risk factors for diabetes after liver transplant. And post-liver transplant diabetes is associated with increased risk of graft rejection, severe complications, and mortality. So again, this is very, very important entity which we need to understand in clinical practice. The management of diabetes in patients with liver disease is theoretically complicated by liver-related alterations in drug metabolism, potential interaction between the drugs, and low albeit real incidence of hepatotoxicity. At the same time, there are drugs which are bound to the plasma proteins, especially drugs like sulfonylurea, and patients with chronic liver disease tend to have hypoproteinemia, and there the free drug levels can be high, and that free drug levels can be risk for getting causing hypoglycemia in those patients. So it is very, very important, and drug-to-drug interaction also becomes very, very crucial. So these are the important causes: NAFLD, NASH, alcohol, viral infection, especially hepatitis C and hepatitis B virus, hypothyroidism, Wilson's disease, hemochromatosis, autoimmune hepatitis. So these are few common causes for chronic liver disease in a diabetes. So whenever you have an abnormal liver enzymes, apart from before labeling them as NASH because of diabetes, we should rule out other causes which are very, very easily can be ruled out. History of alcohol can be ruled out. Viral infection by doing hepatitis B and hepatitis C markers can be ruled out. Hypothyroidism by doing a TSH, Wilson's disease, hemochromatosis, and autoimmune hepatitis all can be ruled out before labeling them NASH and diabetes. This is the pathophysiology is by activation of hepatic stellate cells, inflammation, apoptosis, angiogenesis, hepatic sinusoidal capillarization. These are basically the step which actually leads the twin cycle hypothesis of type 2 diabetes is basically a positive calorie balance versus which actually leads to pre-existing muscle insulin resistance at the level of muscles, which increases the liver fat. And this liver fat actually causes resistance to insulin suppression of glucose production, increases the basal insulin secretion, again hyperinsulinemia. So all these things becomes a vicious cycle, and the increased liver fat basically increases the VLDL triglyceride, increases islet triglyceride, and decreases the insulin response to ingested glucose in the pancreas. So that increases the postprandial glucose and plasma glucose. So this becomes a twin cycle, which is very, very interesting pathophysiology behind both diabetes and CLD. So management, we should target plasma glucose as fasting between 90 and 130, postprandial as less than 180, and HbA1c 6.5 to 7.5, depending upon the compensated versus decompensated liver disease. This is very, very important, and you should try to educate our patients that this is what we are looking forward, and we need to monitor very, very closely. Compensated cirrhosis basically needs lifestyle measures, physical activity, and that this stage can be managed with oral drugs and insulin as per the requirement. So compensated cirrhosis is one where you will not find complications like ascites or varicose bleed, or patients will not have like hepatic encephalopathy or anasarca, hypoalbuminemia. They can have minor signs and symptoms like spider nevi, palmar erythemas, and early clinical signs of liver cirrhosis and hepatosplenomegaly in ultrasonography. So the important things here is to abstain from the general measures which you suggest to all my patients is abstain from alcohol, immunization, like vaccination for hepatitis A virus and hepatitis B virus, pneumococcal vaccination, influenza vaccination, even DPT boosters should be given, modify risk factors for cardiovascular disease like hypertension and hyperlipidemia, and optimization of blood glucose control and weight loss. So these are the general measures which should be followed in almost all patients of diabetes with chronic liver disease at this level. This is, we are going to have a series of cases, the same case, how it follows in the clinics and how we pick them up. It's a 38-year-old male, non-diabetic for 2 years. Body mass index is 34 kg per meter square, has a recurrent history of recurrent anemia. Is non-alcoholic, no history of hypertension. Has a dyslipidemia with a total cholesterol of 225 with an HDL cholesterol of 32, triglycerides 325 and LDL cholesterol 104. His hemoglobin is 8.5 and KFT is normal. Fasting 180 with PP 286. His stool for occult blood was positive for when he was evaluated for anemia. And his USG abdomen was suggestive of hepatosplenomegaly with grade 2 fatty liver, and his portal vein was 12 millimeters. So, and then he was actually referred to a gastroenterologist, and an endoscopy was done, which was suggestive of varices. And that is how this gentleman was picked up to have chronic liver disease with diabetes, and is a non-alcoholic. And then he was evaluated for other causes. Finally, other causes were negative, and he was treated with diabetes and obesity with chronic liver disease at this particular age. And then he was, this gentleman was managed with diet and exercise very intensively. He was repeatedly having a diet recall sessions with special attention by trained dietitians. Even exercise was planned by structured exercise was suggested to him so that he plans to lose weight. And that is what he was actually suggested. And he was referred to a specialist, a trained specialist for exercise, planned for weight reduction. Anti-diabetic medications that will be beneficial for him are metformin, SGLT2 inhibitors, GLP-1 receptor agonists, and even DPP-4, pioglitazone, alpha-glucosidase inhibitors, even drugs like saloglitazole has some benefits. And finally, you can use drugs like sulfonylurea with caution and insulin in these patients. So the same patient comes to the casualty after 3 years with hematemesis and history of melena. And his blood sugar random was 450 milligrams per deciliter. At this particular time, he was admitted in intensive care unit. He's diagnosed to have cirrhosis of liver with portal hypertension, and he's not, but he was not in hepatic encephalopathy. His renal functions were also normal. So this gentleman was admitted in the ICU, was given insulin infusion to control his diabetes. And once the patient was stabilized and was taking meals orally, he can be shifted to oral anti-diabetic drugs from insulin as needed. And if he needs, he can be added as a basal insulin along with the oral hypoglycemic agents. At this stage of disease, the risk of hypoglycemia is high because glycogenolysis and gluconeogenesis both are impaired at this stage of disease. So we need to counsel regularly at this stage of disease. The same patient develops later on ascites, anasarca with hypoproteinemia. His renal function is also impaired, and his meal intake is also unpredictable. And this patient should be put on multiple. So at this stage of time, you need to stop all his oral anti-diabetic drugs. He should be under close monitoring by a gastroenterologist. For diabetes management, he should be put on multiple doses of insulin. Small doses, multiple doses are going to be helpful, and it can be easily monitored and titrated as well. Now, the same patient was well controlled on insulin and DPP-4, started developing frequent hypoglycemia, even on stopping insulin completely. So at this stage, always think about if the patient is started getting hypoglycemia with the dose which he was tolerating well, we should think of hepatoma, and we should screen for hepatoma in such patients, especially hepatocellular carcinoma, do test and evaluate it. Because If you see this association of diabetes and cancer is hepatic cancers are very, very high. The odds ratio is 2.54 and the risk ratio is 2.50, very, very high in diabetic patients. And if you see the cancer mortality also in different study group, the hepatic cancer has got a very, very high mortality. So it's very important that when a patient, you have some clinical signs which suggest frequent hypoglycemia, you should always rule out hepatoma in such patients. And the same patient, if it undergoes liver transplant later, post-transplant, there is an increase in insulin resistance, and most of the anti-diabetic drugs can be used with some caution on sulfonylurea to drug interactions with the chemotherapeutic agents which they have been prescribed later on. So this is how a patient should be followed up if different stages of management of chronic liver disease with diabetes. And this is the flowchart of management, treatment of NASH, and the control of other severe risk factors is very, very important, because if you treat at this stage very, very intensively, we can actually prevent the progression of disease from NASH to fibrosis to cirrhosis of liver and further hepatocellular carcinoma. So metformin is one drug which has been very, very useful, and it may be particularly useful in obese patients in whom it may cause mild weight loss as well. The maximum dose should not exceed 1,500 milligram. There are some concerns about lactic acidosis with metformin therapy in chronic liver disease patient. So we should hold on this drug in patients who have child-puke stage C, where the chances of lactic acidosis is very high. So patients with child-puke stage A and B can be put on metformin with a lower dose, not with the maximum dose. And whenever we feel that the patient has got an active liver or renal function is deteriorating, we should immediately stop it. In setting of acute illness and decompensation, it should be stopped. It is relatively contraindicated in patients with advanced liver disease or in binge drinkers because it may predispose to lactic acidosis. Sulfonylurea, insulin secretagogues should be avoided or used with caution at low dose due to risk of hypoglycemia. As I said, they are usually bound to the plasma proteins, and hypoproteinemia is very, very close, common phenomenon in patients with chronic liver disease. So this drug should be avoided as far as possible. In severe hepatic disease, it should be completely avoided. Lower doses, especially the shorter acting drugs like glipizide and gliclazide, can be preferred in child-puke class A and B and should be definitely avoided in class C. Sulfonylurea with a short half-life such as glipizide or gliclazide are preferred in these patients. Alpha-glucosidase inhibitors are like acarbose and voglibose may be particularly useful in patients with liver disease because they act directly on the GI tract to decrease carbohydrate absorption, thereby decreasing postprandial hyperglycemia. It is relatively safe and could be used without any dose modification in CLD patients, preferred in child-puke class A and B and not in class C. So this is again a very good, you can actually add on acarbose along with even insulin and low doses of metformin. Thiazolidinediones, pioglitazone and rosiglitazone. Rosiglitazone is no more available in our country. If you remember, the first drug was troglitazone, which was removed from the market because of the severe hepatic toxicity. And later on, there was a big concern regarding other thiazolidinediones and the hepatic toxicity. So pioglitazone was studied in more than 20,000 patients. This is a Japanese study. And there was no case report of hepatic failure in more than 20,000 patients. So, and even after using for more than 10 years, we have hardly case reports of pioglitazone and liver disease. So it's a very, very safe drug in patients with liver disease. It should be used in child-puke class A. In case of active or acute liver disease, it should be avoided, and it should be avoided in patients with liver enzymes more than 3 times normal. And once the enzymes comes to normal values and patient doesn't have decompensated liver disease, it can be started again. It is contraindicated in case of hepatic insufficiency and in any stage of hepatic insufficiency. Pioglitazone is known to improve NASH over there are a lot of data, and this is the only drug which has been FDA approved to be used in NASH. But important thing is the level of enzyme should not be more than 3 times when you start this particular therapy. This is very, very important. And once the enzyme levels have come down with diet and exercise, weight reduction, you can start this drug, 30 milligram. DPP-4 inhibitors are again a good class of drugs. Gliptins, Sita, Vilda, Lina, Saxa, these are all available. Today we even have evogliptin and teneligliptin. So except vildagliptin, DPP-4 can be used in child-pugh class A and with caution in class B. This is very, very important. We should not use vildagliptin. Vildagliptin has got some hepatotoxicity been reported, and definitely not in class C. So DPP-4 inhibitors can be used in child-pugh class A if at all needed, even with along with metformin and DPP-4. Even you can add a basal insulin if you need a better control of blood sugar. GLP-1 receptor agonist, we have data with exenatide, liraglutide, dulaglutide, semaglutide. They all are useful drugs in patients with NASH, weight reduction, and we have data from study. There is a significant reduction in fat content in 6 months with liraglutide, and this was after 6 months of liraglutide. So this is one good drug which can be used in patients with NASH, because this is one drug which has been documented to actually take care of NFLD. SGLT2 inhibitors like dapagliflozin, canagliflozin, and empagliflozin. We have some data with empagliflozin, and there was a significant reduction in fat content from the baseline with empagliflozin. This was a study which was published in 2018, and there are a lot of data which are coming up in NFLD and diabetes with empagliflozin. We have some data, again, that the percentage change in liver fat relative to baseline as assessed by MRI-PDFF is a significant difference in the change in liver fat between the two groups. So you can there is a 30% improvement in the liver fat with empagliflozin. And the baseline change in the enzymes is also very, very significant. So empagliflozin has shown to be very, very beneficial in patients with NASH and could be a good drug of choice early when it started early in obese type 2 diabetic with NASH. And we still need to have data for reducing the progression of the disease from NASH to cirrhosis. Even dapagliflozin, there is a data published which significantly reduced liver fat accumulation associated with a decrease in abdominal subcutaneous fat in patients with inadequately controlled type 2 diabetes. So this is again good data with dapagliflozin, another SGLT2 inhibitors, useful in management for NASH and prevention of progression of NASH to CLD. Again, we have another data with comparison of epagliflozin and pioglitazone in the management, and it very clearly says that the epagliflozin, another SGLT2 inhibitors, can be beneficial even when compared to pioglitazone in the long run as far as reduction of fat content in the liver is concerned. Insulin therapy is the mainstay in the treatment of uncontrolled diabetics. From single dose of basal insulin to multiple dose of basal insulin may be needed. Insulin is anti-inflammatory. Insulin has got in patients with uncontrolled diabetes and hypertriglyceridemia, and insulin does not have any contraindication as far as hypoproteinemia or no drug interaction as far as other drugs used in chronic liver disease is concerned. The only problem is hypoglycemia is a concern. Severe hypoglycemia is a very big concern with insulin therapy. So we need to have good SMBG or CGMs, frequent CGMs in patients with chronic liver disease and insulin therapy. Patients who have ascites, patients who have anasarcitis, very important. If they are injecting subcutaneous insulin, they should inject over arms instead of abdomen and thighs. This again should be discussed with the patients when advising insulin therapy. Insulin requirement, however, may vary. For example, in patients with decompensated liver disease, the requirement may decrease due to reduced capacity for gluconeogenesis and reduced hepatic breakdown of insulin. However, patients with impaired hepatic function may have an increased need for insulin due to insulin resistance. So this is again a very important message that insulin requirement can vary with different patients. Careful glucose monitoring and frequent dose adjustments of insulin may be necessary. So hypoglycemia is very important and is very common in decompensated cirrhotics. And if a patient starts getting frequent hypoglycemia, hepatoma, hepatocellular carcinoma should be ruled out. So to conclude, diabetes mellitus is observed in up to 30% of patients with cirrhosis, and diabetes can be either an underlying type 2 diabetes mellitus or the consequence of alterations directly related to an impaired liver function. Diabetes mellitus is associated with a poor prognosis in patients with cirrhosis, mainly because of an increased risk of cirrhosis complications. Thus, screening for diabetes mellitus should be proposed to all patients with cirrhosis. And although it is tempting to speculate that controlling diabetes may have a beneficial effect, further control studies are needed to evaluate the effects of diabetes control on the development of complications of cirrhosis. So I thank you all for your patient listening, and I thank the organizers for this particular opportunity.
Thank you, Dr. Vinay, for a very lucid presentation on diabetes and CLD. So I'll request Dr. Bhartiya and Dr. Arvinda also. Yeah, all three are there. So let me start with Dr. Arvinda. Jagdisha, you made a very good presentation on diabetes management in CKD. So let me put it in very simple way for benefits of all physicians, those who are involved in practice of diabetes. What is the standard care today with availability of MRAs, Finrenon, with ARNI and other drugs, and with ACE, ARBs, all drugs already being used, and with DEPA, CKD, and now even EMPA CKD results already published. What do you think should be a standard care today?
So mainly, sir, that is first is the lifestyle management is always the thing. That is the cornerstone. Next comes the treatment aspect. Like 10 years, 20 years back, if some patient used to come and ask, doctor, my kidney progression is halted. We used to say, no, take care of diabetes, blood pressure, cholesterol, that will stop the progression. Now we are lucky to have so many medication with so much of scientific data to say that kidney progressions be halted. So the drugs, like newer drugs are there, like especially the SGLT2 inhibitors is the drug of choice for CKD. I always feel, whether it is DAPA or EMPA, the safest to start with this molecule.
I think he's lost the signal. Arvinda, you are there?
I think the contact is lost.
Oh, he's trying to log in again. Mithun, you made a wonderful presentation again on diabetes and ED, a topic which is very sought after these days. And when you were being introduced, I was telling Girish that he's one of the most sought after endocrinologists in the eastern part of the world, because this is very less known topic and it interests everyone, in larger interest of the patient, those who have been living with long-term type 2 diabetes. So you discuss lot of psychosocial issues. While coming to therapy, what do you think should be again a standard care in diabetes ED? Of course, you very rightly said this patient needs to be investigated, because by the time you have vessels accounting for ED, by then they already have triple vessel disease or maybe an established atherosclerotic cardiovascular disease or disease like CVD also. So what should be a standard care for patient with ED when it comes to drug therapy? This signal is poor. Yeah, Mithun, yeah. Mithun, did you hear me?
I think he is also not there.
Arvinda, you were talking something. You may continue. Yeah.
Yes, sir. So, yeah. So basically, if the EGFR, if it is more than 30, that will be the safest bet to start either DAPA or EMPA or canagliflozin. That should be the drug of choice. So always you should note, when you are starting SGLT2 inhibitors, there will be an initial decline in EGFR. So we should make sure that follow-up is correct, and you should monitor the patient and keep encouraging and follow the patient regularly. Then obviously there will be a beneficial effects which you will see with the SGLT2 inhibitors. Safest best is always take home will be start SGLT2 inhibitors when EGFR is more than 30. The other drugs, definitely the Finerenone, that is the non-steroidal MRA, is one of the drugs to be considered in preventing the CKD or preventing the progression of CKD. Especially the drug has shown the beneficial in reducing the albuminuria, but only the care has to be taken in with regards to potassium, because it is known to cause hyperkalemia. So these are the two drugs. When these two drugs are not responding, then you can think of other drugs like GLP-1 and other drugs. And always kindly note, use the short-acting sulfonylurea if it is indicated, if the sugars are not well controlled. Because we all know that sulfonylurea can cause profound hypoglycemia, so that we use short-acting insulin and prevent the hypoglycemia. And cornerstone of all the treatment for diabetes with CKD would be insulin at the last stage. It means after all these drugs, if they're not showing beneficial effect, then it should be insulin. That is the take-home message from me, sir.
Very, very nicely concluded that what should be the management of type 2 diabetes with CKD as a standard care. Mithun, you are back. So we wanted your opinion on what is, you of course very rightly alluded to the psychosocial aspect of ED and all that. And you very rightly said that by the time you have ED, which happens because of vessels which are as small as 2 to 3 millimeter, by then you already have a coronary artery disease, maybe triple vessel disease, or maybe even a macrovascular complication setting in. So what should be an ideal therapy for these patients, which will be safe also, and whether it is possible for a physician to treat a patient of type 2 diabetes with ED safely with these drugs?
So it is very, that's a good question, sir. I think we can all physicians know how to neutralize vascular risk factors. So, getting them to stop smoking, getting them to reduce their alcohol, statins, getting them, if they are anemic, replacing them, because if there's no blood, nothing is going to come down. So all that can be easily replaceable by physicians, and they're very experienced in doing that. With regards to PD5, they can be safely prescribed by physicians. I don't see any problem of PD5, and there is some data that long-term PD5, there is some endothelin improvement that can happen. So PD5 can be prescribed by physicians, but the problem is not a prescription. The problem is people don't want to ask the question. I think that is a bigger barrier than because that, some kind of, I think till we break that inhibition, and perhaps, forums like these, when we are in physical format, we can do workshops, and so that people are comfortable asking about sex, especially to the opposite sex, because that is where the boil will turn out to be. When I trained, we had models and we had to ask questions, and it was very difficult. I remember the first day I was very sweaty, and then eventually things got improved. You get used to it, you are comfortable, because patients can very much get, they get the feeling, if you are not comfortable, they will not open them up. So we have to make them comfortable. That is the onus on us, but a lot of it can be done by physicians.
I think
testosterone replacement only is the only thing which I would say should be done by somebody who has an active interest. The rest, everything can be managed by physicians.
So I think when it comes to management of VD, what you rightly said, that it is the evaluation, sitting with the patient, discussing with the patient, and getting into the root of the problem before prescribing any drug, because drug may not do wonders until unless you have sort of evaluated the patient in detail and got it to the root cause, what is the problem for ED in that particular patient. Over to you, Girish. You want to ask Dr. Vinay or Dr. Jagdisha or Bharti any question?
I just
We
want
have
to.
5 more minutes here.
I don't want to ask Dr. Bharti whether he.
Time is a little bad here.
Whether he used some set of questionnaire to the patient, or it's available in his clinic, or he just asked at random. Because sometimes patients, they don't want to say anything, but they can answer you in a questionnaire form, a standard questionnaire form.
Mithun, are you there? I think his signal is very, very poor.
I think Mithun's signal is not that good, sir.
Girish, you are very right that we did one data in our hospital about 10 years ago where we tried to establish the prevalence of hypogonadotrophic hypogonadism in type 2 diabetes patient, and we there use Adams criteria to get into the problem whether it correlates with HH or no. And I think we found that it is very, very useful questionnaire. There are many sets of questionnaires which are available now, but Adams score is again one of the good questionnaire which is simple, and once you sit with the patient, you are sort of into the habit of discussing with the patient. Mithun very rightly said, we have to open up. Most of us actually, we ourselves don't open up with the patient, and we don't want to discuss because one is we don't have too many modalities to address that, and second is that many times couple is sitting there or you have a female colleague sitting with you, so you are yourself not very comfortable in evaluating the patient. So I think more important is rather than simply prescribing drugs like tadalafil or anything, much more important is to evaluate the patient and get it to the root cause. Vinay, what do you say?
So, in fact, in our part of the country, the commonest complaint for ED is kamzori hai, bahut kamzori hai. This is the word when the patient says 2 or 3 times kamzori hai, and many times the wife will say, Doctor sahab, aap inko dhyan nahi de rahe hain, ye andar se ekdam kamzor ho gaye. These are the very common presentations in the clinic. The moment they talk something like this, after a couple of seconds, I go back to their problem, and then I start directly what type of kamzori you are talking about. 50% of the patients do well after discussing with us. We tell them what are the differences, like Mithun was talking about things like premature ejaculation instead of not having a poor erection, how to differentiate it. The patient feels that even a premature ejaculation is something like a defective erection. So you need to differentiate because the therapy is different for both of them. Similarly, as you said, hypogonadism, like testosterone being one of the factors for diabetes, we talk about one of the cause for low testosterone as a cause for diabetes, obesity causing low testosterone. So we also need to evaluate for hypogonadism. So these are few clinicals, and we also need to look for drugs, especially like we are using left and right CTD, we are using beta blockers, we are even using drugs like aldactone, spironolactone. We need to be very, very careful when patients are using this class of drugs. We need to talk to them, reduce the doses if possible, or else we need to discuss with them to get it changed. Like we can change ivabradine and beta blockers to actually reduce the burden of tachycardia in patients with heart failure. So I'm sure few things are very, very helpful in taking care of erectile dysfunction in diabetes. Even our chronic liver disease is associated with hypogonadism, sir. So chronic liver disease also has the testes are atrophied, especially in alcoholic liver disease. So there again, you need to give drugs like testosterone either in injectable forms or in the local application form, and then it helps them basically.
I think that is a very useful comment. Rather than jumping on the drugs, it is much more important to evaluate ED patient and look for comorbidities and the drugs, polypharmacy, which patient may be on beta blocker, diuretics. Many of these patients may be actually symptomatic because of the drugs. So yes, we need to judiciously use these drugs in best interest of the patient. And whenever patient has come out with little complaint, those patients obviously need to be negotiated before giving a definite therapy. Girish, you may do
I have one
final
question.
comments and close. Yeah.
I just want to ask Dr. Vinay, he showed us a case, and what exactly could have been done at stage 1 to prevent him to going to stage 3 or 4, what he showed us, because the management was not exactly, he was telling this patient should be managed like this. Instead of that, he went into stage 3, 4 within 4 years.
Actually, I was talking about a case, how it follows up in clinic, how they have been diagnosed and how they follow up and lands up in the complications. My basic purpose was that. So at stage 1, when the patient has come for the first time with anemia and diagnosed to have chronic liver disease, weight management is very, very crucial, sir. And intensive lifestyle management is very, very helpful. There are small data to suggest that lifestyle management and weight reduction actually helps in slowing down the progression of fibrosis and liver cell death, because the cell death is basically causing fibrosis, and fibrosis and cell death together are actually causing progression of liver disease. So it is very important at that stage of time that obesity needs to be addressed. And there are a lot of ways where you can address obesity. One of them being the lifestyle management. Lifestyle is the casual advice. Lifestyle management doesn't help. You need to involve a good dietitian. You need to have a structured exercise program, and you need to use drugs like SGLT2 inhibitors and GLP-1 receptor agonists, which actually help them in reducing the weight. So these are few very, very important things. Actually, and you should also tell these patients to avoid drugs which are hepatotoxic.
This presentation,
like we talk about nephrotoxic drugs, we should also talk about the hepatotoxic drugs. Tell them that whenever you go for any associated disease, you need to tell your doctor that you are having a liver disease inside. So this is again a very, very important advice to be given to all the patients in the initial stages.
Thank you, Dr. Vinay. With this remarks, I thank all the speakers for a wonderful presentation.
Thank you, Vinay, Dr. Bhartiya, and Dr. Jagdisha. In any case, Dr. Jagdisha, you have to stay back for the next session, which you are going to chair for 3 doyens in the field of diabetology, Professor Das, Professor Mohan, and Professor Mishra. So I think that is going to be a very, very prestigious session. So over to you, Dr. Arvinda.
So thank you, sir. So good evening, everybody. So now we are moving on to the next session. That is an important session. A very interesting 1 hour, 1.5 hour session, I should say, because all the doyens of diabetes is speaking on a very, very interesting topics. The first talk will be none other than Professor A.K. Das. I'm sure we all know about him. There is no need to introduce, but as a formality, I should definitely introduce. He is the Professor Emeritus at Mahatma Gandhi Medical College and Research Institute. He is our patron of RSSDA. He is a co-chair of ICMR India study. He is the chair, that is Diabetes in the Young Registry. He is the former national president RSSDA and API, former dean of Indian College of Physicians, and former professor and head of endocrinology, JIPMER and PIMS Puducherry. Moreover, he is a very humble person, always encourages to all the doctors, and he is a mentor to me as well. So, and he'll be talking on an interesting topic today. After Dr. Vinay's talk on liver aspect, liver and diabetes, Professor Das will be speaking on an interesting subject, that is diabetes starting from liver. It's an interesting aspect to listen to him. Over to you, sir.
Professor Das is a legend figure, again, a fatherly figure in the field of diabetology, who has mentored all of us into the field of diabetology. Professor Das, over to you.
My dear esteemed colleagues and very dear friends, my dear Dr. Rajiv and Salini, I'm going to speak today on a very important contemporary issue. Does type 2 diabetes originate from liver? It's a type of provocative subject centered around the diabetes and liver in a vicious relationship. Dear friends, I would like to say that I have a small agenda for you. We'll introduce the topic. Think of the NAFLD and type 2 diabetes mellitus. We'll pass on to alcoholic fatty liver disease and type 2 diabetes mellitus. We'll discuss how both these produce type 2 diabetes de novo. Hepatitis C virus, how does it produce diabetes itself, and during its treatment, what happens? Most important, liver cirrhosis and the hepatogenous diabetes, which has become a big issue, testifying that diabetes originates in the cirrhotic liver. We'll discuss about the diabetes treatment algorithm in CLD, and we'll discuss the intricate relationship between the type 2 diabetes and the liver disease, and we'll go into 4 summary points. Dear friends, suffices to mention the prevalence of type 2 diabetes mellitus is higher who have liver disease such as NAFLD, alcoholic liver disease, chronic viral hepatitis, or cirrhosis. There is a pathogenic link between the liver disease progression and type 2 diabetes mellitus pathway leading from fatty liver to type 2 diabetes and back. Dear friends, this cartoon is very important, which shows that, which shows very significantly that the liver is the storehouse for glucose and prepares glycogen. And liver plays an important role in storing glucose from the blood and also manufacturing glycogen. Now, high blood glucose promotes insulin release from the pancreas, giving rise to glucose uptake, which can lower the blood glucose. It can stimulate, insulin can stimulate glycogen formation and also rise in the blood glucose. Now, it is very important to know that the liver glucose metabolism is centered around 3 things. Number 1, liver stores glucose in the form of glycogen and utilizes in the same way when body requires the glucose. This cartoon shows the various pathways from the hexamine pathway to pentose pathway, how liver utilizes the glucose. We'll pass on to the most important topic, how NAFLD produces type 2 diabetes mellitus. Dear friend, obesity can act in 3 ways to produce diabetes. So one of the ways is the liver. Liver has got increased lipid content in obesity, steatosis, Cooper cell activation, and ER stress. Similarly, skeletal muscle also has increased FFA uptake, increased macrophage activation, and ER stress. And all this produce IR in the skeletal muscle, IR in the liver, and nonetheless in the adipose tissue, there is adipocyte hypertrophy, macrophage recruitment, and ER stress, increased lipolysis. So obesity leads to increased lipid on the liver that subsequently leads to insulin resistance, and this systemic insulin resistance and inflammation gives rise to diabetes mellitus. I'll be a little fast to complete the whole topic. I must mention here that NAFLD contributes to the development of type 2 diabetes. Type 2 diabetes, as I saw in the cartoon, by increasing glucose production in the liver and exacerbating the hepatic insulin resistance through activation of hepatic protein kinase C and some liver secreted protein, I'll come in a minute, which have got diabetogenic properties like fettuin A, which I'm going to speak after me, fettuin B, retinol binding protein 4, selenoprotein, and DPP4 and HERP1. Dear friends, the increased glucose production in the NAFLD gives rise to the diabetes mellitus. And there are many meta-analyses. I've just brought 3 for you. This meta-analysis shows that the non-alcoholic fatty liver disease has a great risk of incidence type 2 diabetes development. It has the study of about 27 studies. There's a new one which also shows that that the patients with more severe NAFLD were also more likely to develop incident diabetes. This risk increases across the ultrasonographic scores of steatosis, but it appeared to be even greater among the patients who have NAFLD and those who have NAFLD fibrosis score. They didn't have diabetes before, but they developed diabetes. So NAFLD is very significantly associated with a 2-fold increased risk of incident diabetes. Dear friends, I like to add that hepatokines are released by the fatty liver, and there are many. I just address 2: fettuin A, FGF21, follistatin, HGF, and you see they have a lot of function on the pancreatic islets. they can improve beta cell proliferation, improve GSIS, they can decrease the beta cells, can produce apoptosis and decreases the GSIS, and they produce a lot of alteration in the glucose metabolism. This cartoon shows that that in conditions of nutritional excess, the diabetes is produced, and they can generate increased hepatokines, and as shown in the red boxes, and they can produce diabetes mellitus. In addition, there is a increased other hepatokines, which are shown in the blue box, that trigger compensatory mechanism of increased beta cell proliferation. So, and in contrast, there's a decrease in the release of the other hepatokines that produce increase in beta cell proliferation. To make a long story short, the hepatokines and the liver factors involves in the talk with the hepatic tissue and the pancreatic beta cells, giving rise to diabetes mellitus. Now, there is a factor called PANDER. PANDER stands for pancreatic derived factor, PANDER. Now, in the presence of nutrients, PANDER is co-secreted with insulin and acts to regulate insulin release. When IR is present, beta cells increase insulin and PANDER release. In this situation, the increase in PANDER induces beta cell apoptosis, decrease in GSIS, giving rise to type 2 diabetes mellitus. Dear friends, I will not address this, but I'll go to the text which can really tell you how pancreatic beta cell dysfunction is associated with NAFLD. Dear friends, now there's a disposition index which is employed to assess the pancreatic beta cell function. And this study which I'm describing had about 6,138 patients. Now, the NAFLD patients had much higher HOMA 2, and also the NAFLD participants had lot of increased insulin resistance, which is known by the DI index. So, some cases, the DI index were much lower in NAFLD patients, and the analysis showed that DI was inversely associated with the NAFLD prevalence. If the DI levels are low, there is increased NAFLD prevalence. And therefore, it is clear that DI or disposition index to assess pancreatic beta cell function has a great deal of association with NAFLD. I think that is the only take-home message, that the lower the DI, disposition index, the more the NAFLD, the relationship liver and diabetes mellitus. Therefore, the pancreatic beta cell function may be a new predictor for the presence of NAFLD. You address beta cell function, you can predict whether the patient is going to develop NAFLD or not. And insufficient compensatory beta cell function is associated with NAFLD. Now, coming to alcoholic fatty liver disease, heavy alcohol consumption in the people who already have fatty liver disease is a greater risk of developing type 2 diabetes. A moderate alcohol consumption without FLD also can produce diabetes. Compared to none or minimal alcohol intake can produce no FLD. Therefore, cannot produce type 2 diabetes. So therefore, heavy and moderate alcohol consumption with or without fatty liver disease can produce type 2 diabetes mellitus, incident type diabetes mellitus. Even moderate alcohol consumption can produce incident type 2 diabetes mellitus without fatty liver disease. In contradistinction, when there is no alcohol intake or minimal alcohol intake, there is, with or without FLD, there is no production of type 2 diabetes. Now, the alcohol insulin signaling is depicted here. Hepatic insulin signaling includes fat production, glycogen production, and the stopping of the gluconeogenesis. And alcohol, the insulin signaling, it produces increased fat production, more of gluconeogenesis, and less of glycogenolysis. Now, so there is a great deal of insulin resistance in the alcoholic liver disease. Now, this cartoon shows the liver steatosis is associated with increased production of insulin from the beta cells in order to compensate for the whole body insulin resistance. Now, this is associated with the greater insulin secretion, and the model parameters suggest relative beta cell dysfunction with NAFLD in apparently healthy older adults, which may be occur to reduce and produce diabetes mellitus. Coming to hep C and virus infection, now it has been shown that SCV infection is associated with an increased risk of development of type 2 diabetes mellitus. T2DM is more common among patients with chronic SCV than in patients with other liver disease or in general population. Now, if you look at the treatment paradigm, those who have sustained virological response, good response in hepatitis C virus, it has been shown that the HOMA scores come down significantly. In contradistinction, it has been also shown that when the sustained viral response is there, that when the HIPC is coming down, there's a reduction in the HOMA IR showing that diabetes does not occur. So therefore, SCB has a great bearing on the production of diabetes mellitus, and there's a good virological clearing. The type 2 diabetes may not occur. Now, it has been shown here that if you look at the increase in resistance in the hepatitis C infection, one finds that the IR is associated with the altered hepatic function testing. Now, liver cirrhosis is a great example of insulin resistance and beta cell dysfunction, and both together can give rise to hepatitis diabetes. They pass through a cycle of normal glucose tolerance, impaired glucose tolerance, and full-blown diabetes mellitus. And a state of impaired glucose regulation caused by loss of liver function as a consequence of cirrhosis is the pathway to produce type 2 diabetes. Now, the pathophysiology of hepatitis diabetes in the liver is depicted here. I'll not go into details, but if you compare the hepatogenous diabetes with ordinary garden variety type 2 diabetes mellitus, the diabetes in hepatogenous 1 is after cirrhosis onset, type 2 diabetes mellitus garden variety before cirrhosis onset. Hepatogenous has normal fasting plasma glucose HbA1c. It has increased fasting plasma glucose HbA1c, type 2 diabetes garden variety. Metabolic risk factors less frequent, more frequent. Vascular complication less frequent, more frequent. Liver complications is more frequent hepatogenous as expected, less frequent type 2 diabetes mellitus. Effect of giving orthotopic liver transplantation. Diabetes reverses totally. 26 cases of transplant has been described from India, which are reverse diabetes, but there's no modification in the transplant. In the mortality, more than non-diabetics in hepatogenous and more than non-diabetics in either way. Dear friends, I must also hasten to add that if you look at the reported prevalence of hepatogenous diabetes in patients with liver cirrhosis, you will find that it varies from 13%, large to 86.7%. So hepatogenous diabetes in cirrhosis is very common, and you see the percentages shown in this cartoon. It is quite common. Now, prevalence of abnormalities of glucose regulation amongst patients with cirrhosis has been observed if you look at the aggregated glucose ratio, you find it is altered up to 87% in hepatogenous diabetes, giving rise to the fact that it is a function of the cirrhosis to give rise to type 2 diabetes. Now, if you look at the severity of the liver cirrhosis from child A to child B and child C, you will find that as the higher prevalence is noted with more severe liver disease. Now, this is figure A, this is figure B. Figure A shows rising prevalence of IGT and diabetes mellitus as the cirrhosis worsens from A to C, and figure B shows rising prevalence of IGT and DM as the MELD scores rises. So there is good relation between them. The liver function, simply the liver enzymes like the serum alkaline phosphatase, like the asparated aminotransferase, it has been told many times, can give an indication of type 2 diabetes mellitus. Mean activity of the ALT, AST, and alphas of diabetic patients shows difference from the other population. There'll be no time to describe in detail treatment algorithm. I'm sure that there is a great deal of treatment algorithm that exists for treating diabetes in these people. I just allude to three slides which shows about the various treatment that we have, like metformin, pioglitazone, and alpha-glu inhibitor. If you find that if you give metformin, I'm just giving the pros and cons. It favors safety profile, cardioprotective, improve insulin resistance, aminotransferase is increased, liver morphology is improved. Now reduces SCC risk by 50 to 70% and reduces the risk of hepatic encephalopathy by 8-fold. Pioglitazone is a wonderful drug for the NAFLD. It improves the aminotransferase and liver histology. low risk of hypoglycemia, inhibits SSC development experimental model. Alpha glucose inhibitors also reduces the postprandial glucose and glycemic variation. Now, if you go to the other slide, it shows the effect of the sulfonylureas, meglitide, and insulin has been shown to effectively glycemic control, safe to use, and no risk of hypoglycemia. Now the characteristics of the oral hypoglycemic patients related to the cirrhosis patient, where to use, where not to use. I like to draw this to your attention to this, that these drugs, some of the drugs have clinical experience in cirrhotic patients, and the risk of lactic acidosis, etc., has been described in them. Now, there is favorable pharmacological properties in cirrhosis patients, and the clinical experience is limited with the drug DPP4, AGI, and SGLT2 inhibitors. Now, if you look at the factors that might influence selection of anti-diabetic drugs, it can be obesity, it can be sarcopenia, it can be hyperammonemia, it can be renal impairment, hypoglycemia. You have to find a drug depending on that. Now, the other thing I'd like to discuss quickly before I close, there's the effect of the SGLT2 inhibitor in the NAFLD. Today, we have a lot of studies which have shown that SGLT2 inhibitors can reduce hepatic steatosis more than expected, can produce weight loss, additional weight independent mechanism. So it's a wonderful drug for the NAFLD, is used in diabetes and takes care of the NAFLD in type 2 diabetes mellitus, and a randomized placebo controlled trial examining the effect of the various anti-diabetic drugs for the treatment of NAFLD depicted here. You will find the drugs which holds promise that we use today: pioglitazone, GLP-1 RAs, DPP4 inhibitors, and SGLT2 inhibitors. They are the 4 drugs which holds promise for use in the NAFLD, anti-diabetic drugs being used in NAFLD. Now, if you look at the intricate relationship between type 2 diabetes and liver disease, I have a very important cartoon. You know, diabetes promotes the risk of steatohepatitis, risk of cirrhosis, risk of hepatocellular cancer. And the NAFLD promotes worsening the insulin resistance, risk of the atherogenic dyslipidemia, risk of type 2 diabetes mellitus, increased difficult to manage, and the risk of cardiovascular disease. So that is the relationship between type 2 diabetes and NAFLD. Now, this cartoon shows that how the non-alcoholic fatty liver disease and type 2 diabetes are in a vicious relationship. Now, liver disease progression can give rise to diabetes mellitus, and diabetes progression can give rise to NAFLD, and the hepatitis C virus also is also partially supported by type 2 diabetes mellitus. Now, there is increased insulin resistance, increased pro-inflammatory cytokines, increased diabetogenic hepatokines, and reactive oxygen species in diabetes mellitus, which can give rise to, in the liver, fibrosis and can lead to SCC. I will not discuss in detail because lack of time. I'll go to the last 2 slides, which shows that the adipose tissue insulin resistance is a factor to produce the NAFLD or the NASH, and it produces increase in lipolysis, secretion of the pro-inflammatory cytokines, and give rise to lipotoxicity. And needless to mention, lipotoxicity and glucotoxicity can produce insulin resistance. This shows the relationship between lipoglucotoxicity, resistance, and the beta cell function. So therefore, dear friends, I will conclude by saying fatty liver and diabetes both share insulin resistance, and this is a great pathogenic determinant of the relationship between the type 2 diabetes and the liver disease, and the origination of the type 2 diabetes from the liver disease. The prevalence of type 2 diabetes is high who have liver disease. At least 4 are identified: NAFLD, also some chronic viral hepatitis, hemochromatosis, alcoholic liver disease, and cirrhosis. So these liver disease, NAFLD, chronic viral hepatitis, hemochromatosis, alcoholic liver disease, and cirrhosis, they are the ones which can promote, they can produce type 2 diabetes mellitus by the various mechanisms I have just described. There's a pathogenic link between the presence of type 2 diabetes and the severity of the liver injury. The more severe the liver injury, the greater is the hyperglycemia, and the great severe is the pathogenic link. Now, there's a great pathway leading from fatty liver to type 2 diabetes. I have presented before you the evidences. What are the pathways leading from fatty liver to type 2 diabetes? And also back from the latter to the progressive liver disease. Type 2 diabetes is a factor progressive liver disease and the vicious cycle. Dear friends, we'll listen more about this subject in times to come, but I just wanted to give a bird's eye view very quickly in about 18 minutes that how the liver diseases or liver itself can be a originator of type 2 diabetes mellitus. Thank you very much for your very patient hearing.
Thank you, sir. That was an excellent presentation by Professor A.K. Das. Very apt. We can keep the discussion at the end of the session. So we can move on to the next session. The next session is another interesting talk from a diabetes doyen once again, Padma Shri Professor Anup Mishra. So to introduce him, is the Executive Chairman, Fortis CDOC Hospital for Diabetes and Allied Sciences. He is the Director, National Diabetes, Obesity and Cholesterol Foundation. He is the President of Diabetes Foundation India. Former Professor, Medicine, All India Institute of Medical Science, New Delhi. Former faculty, UT Southwestern Medical Center, Dallas, Texas, USA. His major achievements are more than 300 published research papers, being among the top 2% scientists in diabetes from India ranked globally. This is a remarkable achievement. Editor-in-Chief for Diabetes and Metabolic Syndrome, that is Clinical Research and Reviews, Clinical Keys, and that is an Elsevier. He is the Associate Editor of Journal of Diabetes, European Journal of Clinical Nutrition, member of Academic Board of British Medical Journal, member the Lancet Commission Commission on Obesity 2023. Awards, the most important prestigious award, Padma Shri awarded by President of India in 2007, Dr. B.C. Roy Award in 2006. He is the author of book of Diabetes with Delight, both in English and Hindi. So this is very brief, I should say. If you tell about Professor Anup Mishra, it will be one session, I should say. That is one more 20-minute session, I'm sure of that.
Welcome, Professor Mishra. Just to sum it up in one line, a top-class clinician, a wonderful orator, and an awesome, prolific writer, which I always admire. If someone has to look for a blend of a personality with everything best, I think Professor Mishra is there. Thank you, sir.
Thank you, Rajiv. Thank you, Shalini. Thank you, Arvind. Thank you for inviting me for this particular lecture. Just let me have the slides. Just hold on. Can you see my slides?
Not yet, sir. Not yet. Now you can put in the PowerPoint mode, sir.
Yeah, just hold on. Can you see the slide now?
Yes, sir.
Yes, sir.
Please.
Okay, so once again, thanks, Rajiv, Shalini, for giving me this opportunity. Thanks, Arvind, for that introduction. My lecture has been made very simple because already there is a wonderful preface of this lecture by Dr. Das, and some of the slides may be overlap between his lecture and my lecture. Now, pancreas conundrum, the pancreas from which diabetes tale began, continues to be a mystery organ. And this is pancreas, and pancreatic fat is going to be focus of my lecture, around which other things will revolve. Specifically, we know so little about pancreatic fat and metabolic event cascades that it produces. And whatever we know today is spread out in this 7-part lecture. So number one is pancreatic fat and non-alcoholic fatty pancreatic disease. Now, this is the anatomical sketch of the pancreas. You can see many types of tissues here, but what we are specifically interested are two types of tissues: intracellular lipid accumulation and then the pancreatic adipocytes. So here and here, both are important and both produce a cascade of events which ultimately lead to metabolic problems. So this is important and this is important. This is the first time term non-alcoholic fatty pancreatic disease was introduced in 2007 by this is a paper by an Indian in the United States who took two types of mice, lean mice and obese mice. And you can see the pancreatic tissue of lean mice and obese mice side by side here. On the right side are obese mice and their pancreatic tissue, and you can see the fat infiltration in the pancreatic tissue. And triglyceride in this experiment represented 11% of pancreatic fat in lean mice compared to 67% of pancreatic fat in obese mice. And you can see it's the same here: intralobular fat, and total pancreatic fat here. There's a remarkable difference between the two. And at this time, the term non-alcoholic fatty pancreatic disease and non-alcoholic steatopancreatic disease was introduced. Part two, the pancreatic fat relationship between BMI and glucose. And I will again refer to earlier studies a decade back, and this is from my institution where I was faculty, UT Southwestern Medical Center at Dallas, where they experimented with in animal models and then subsequently in human beings, and found that as far as pancreas triglyceride content, which they estimated by NMR spectroscopy, increased as the BMI increased. So this is very evident from the slide on the right side. On the left side, you can see pancreas, and the voxel is right here, voxel of the NMR spectroscopy, which can accurately measure the pancreatic or hepatic fat. So this was early studies showing a relationship between the BMI and the pancreatic triglyceride content. And then subsequently, in rats, it was found that as the pancreatic triglyceride content increase, look at this, in the fat mice, it is increasing and the blood sugar is also increasing. So the previous slide showed the relationship between the BMI and pancreatic fat, and here pancreatic triglyceride content and blood glucose. So these early studies showed that it is clearly related to blood glucose, and hyperglycemia will worsen if pancreatic fat increases. Now, how does pancreatic fat accumulate as far as the aging is concerned, and what are the cutoffs of pancreatic fat, and what is the prevalence of non-alcoholic fatty pancreatic disease? Now, this is a busy slide, but I'll make it very simple for you. This slide shows the decade-wise distribution of pancreatic volume, total parenchymal volume, pancreatic fat volume, and pancreatic fat and parenchymal ratio. Now, if we leave aside the pancreatic fat parenchymal ratio and just look at the pancreatic volume and pancreatic fat, there is a difference. So pancreatic volume decreases as one goes older, and pancreatic fat volume increases. So there is a discrepancy between the two, and we shall see what happens in patients with diabetes subsequently. And of course, this is different in patients who are obese, who are overweight, and who are lean. And you can see on the right side, the pancreatic volume and the total parenchymal volume and total fat volume are higher in those people who are obese versus overweight and lean people. Now, this is the summary of anatomy in patients with diabetes. The mean pancreatic volume was found to be 33% less in type 2 diabetes than in people with normal glucose tolerance. So In patient with diabetes, the pancreatic volume is 33% less, which is similar to the aging. And if you see here, aging, the pancreatic volume has gone down. And similarly in patient with diabetes. While pancreatic triglyceride content was 23% greater, and so similar as far as aging is concerned, with aging it goes up, with diabetes it goes up. Another very interesting point is that in type 2 diabetes, pancreas has typically involuted a serrated border, and which can be seen in the next slide. You can see here, a serrated border. There are other anatomical landmarks, but on the right side, in the right panel, you see it is very beautifully outlined in patients with diabetes as compared to people who have normal glucose tolerance. So you can see serrated border in a 58-year-old female, 64-year-old male, and so on, versus the people with normal glucose tolerance. So maybe it is due to increase in the irregular contour due to the fat deposition as the patient becomes hyperglycemic. There is a fat deposition and there is irregular contour. Now, what is the prevalence of NAFLD? Remember, this subject is nascent, is a new subject. Hence, there is not much of a data, and there's hardly any data from India. And I shall produce some of the data which we have accumulated. Now, pooling data of NAFPD from 11 studies of 12,000 individuals yielded that pool prevalence was 33%. Now, this is a no-brainer, actually. Whatever is the prevalence of NAFLD, the same is almost similar is the prevalence of fatty pancreatic disease. And what is the cutoff? How much is the percentage of fat which should be normal in the pancreas? Now, pulling data on pancreatic fat percentage from 9 studies, the weight mean and weight standard deviation were 4.48% and 0.87% respectively. And normal pancreatic fat cutoff point was 6.2% on magnetic resonance imaging. Now, remember, as far as the NAFLD is concerned, in liver, the normal is 5%. And in pancreas, these people said it is 6.2%, but I'm sure we will hear from other people also on this topic. Now, part 4. Which is the main part, and relating pancreatic fat, hepatic fat, and fatune A and to insulin resistance, what Dr. Das was trying to say. Now, a little bit on the fatune A. Dr. Das mentioned a lot of hepatokines, but I'll only concentrate on one, and which is fatune A, because this is the most important of the hepatokine. Now, here you see liver, and here you see hepatocytes. If there is a high glucose levels in the blood, increase in the saturated fatty acid, then 2 pathways are activated, ERK and NFK beta. And then fatune A is increased in the blood. Look at this, fatune A is increased. And fatune A, this hepatokine impairs beta cell function. This is a major driver for impairment of beta cell function. The downstream is insulin signaling are moderated by kinase reaction initiated by insulin on insulin receptor, tyrosine kinase autophosphorylation, and also there is some effect on GLUT4. Once this happens, the myocyte insulin receptor, myocyte insulin resistance, adipocyte insulin resistance all go up, and also fatune A has propensity to activate macrophages. I'll come to that in a couple of slides. What is interesting is high fatune A level cause insulin resistance, and low fatune A cause the heart failure and vascular calcification, both detrimental effect because of high or low fatune A levels. Now, this is a very, very interesting slide, because on the top of the slide, you see a clean beta cell. So, islets. The islets are very clean. There is no fat cell. On the lower panel, you see the fat infiltrating the beta cell, which is evident here. So you see the fat infiltrating here. and this is the islet, and the fat cells are infiltrating, and there is a huge amount of inflammatory cells. So the moment there is a fatty pancreas, fat infiltration in the islet, then there is an increase in the cytotoxic cytokines and inflammation around it. So this is a summary slide from the previous discussion. Healthy liver, there's a decrease in or decreased levels of fatty and also palmitate. So resting macrophages remain rested and normal glucose insulin secretion. The moment fatty liver occurs, the fatty A levels go up and they act through two pathways, toll-like receptor 4 and an independent pathway, and which causes inflammation. So resting macrophages are activated to all which produce pro-inflammatory changes and also inflammatory cytotoxic cytokines. And you look at this. These are the activated macrophages, and which ultimately lead to impaired in the glucose-induced insulin secretion. So insulin resistance and insulin secretion, both pathways are affected by the fatty liver, hepatokine, pancreatic fat, infiltration of fat in the islets. Also, palmitate causes beta cell apoptosis, so result is devastating, and which causes insulin secretory defect, insulin resistance, and increase in the blood glucose level. So both endocrine and exocrine pancreatic functions may be affected by the pancreatic fat, and there may be a chance that these people may develop pancreatic cancer as well. So look at this. This is one study which shows CT image of 63-year-old male, relatively lean person. Pancreas showed the fat in the pancreas. And this participant had pancreatic endocrine impairment. They did a C-peptide immunoreactive level, and also pancreatic exocrine impairment. So PABA levels, PABA test was done. So 33% had endocrine dysfunction, and also some had exocrine dysfunction. So both may coexist, but also it is possible that this may be one factor leading to pancreatic cancer. So this much of discussion we knew, that there is a lipid accumulation, there is a in intralobular section, interlobular fat accumulation, increased adipokine, but in the background of possibly the KRAS activation, smoking, carcinogen, there may be precancerous regions which are further activated by this fat in the pancreas, inflammation, proliferation, and leading to pancreatic cancer, which may be one consequence of the fatty pancreas. Now, what about the pancreatic volume and fat in various ethnic groups? Now, look at the normal pancreatic volume in this particular study. They calculated between 71 to 83 cubic centimeter. But they also listed our study here, which we did some time back. We looked at volume in normal and patients and non-diabetic patients, subjects, and diabetic patients. So it is different in different ethnic groups. So this is they've given a range, but range some of the values are outside this range. Look at this: 53 only in our non-diabetic subjects, and 26% higher in diabetic. So this is opposed to what we have discussed earlier. Then diabetic volume may go down. Here in our cases, the volume was up. And look at this in Canada, in Japan, in South Korea, in UK. So the volume may be ethnically directed and depending on metabolic perturbation. Now, for example, look at here. The Koreans versus Caucasians, pancreatic fat content in Korean was 22% greater than in Caucasian, and this was related to insulin resistance. Now, part 7, and that's where the clinician should actually focus. Which modality could decrease pancreatic fat and what is its significant. So these are the summary slide in which modalities can decrease pancreatic fat. Hypocaloric diet, I'll show you in a minute. Exercise, metformin, there is a query here, GLP-1 receptor analog, there is a plus or query, SGLT2 inhibitor, the evidence continues to evolve here. And bariatric surgery, definitely. Now look at this. This is the leading study which led to the concept of reversal of diabetes. 11 obese patients with type 2 diabetes, they were given markedly hypocaloric diet, followed up for 1, 4, and 8 weeks. And look at this, fasting plasma glucose normalized within the first week. And hepatic triglyceride content decreased from 12.8 to 2.9, a 10% drop in 8 weeks. And also pancreatic triglyceride content decreased from 8.2. So not much in the decrease, but even this much of decrease, the author said, is responsible for reversal of diabetes. Now, this was replicated in direct study, and we all know about direct study. But what is important to know that while the weight decreased in most of the participants in direct study, which is given here, the fasting plasma glucose decreased in many people, but did not decrease in some people and increased in some people. So there are people who are responders, and there were people who are non-responders, and there were people who are relapsers. So what happened to hepatic triglyceride, pancreatic fat, etc. in these three group of people, which is shown in the right side? If you look at the liver fat here, responders, marked decrease in liver fat. Non-responders and relapsers, hardly any. Similarly, if you look at pancreatic fat, similar story. In fact, in relapsers, hardly any decrease in the pancreatic fat. And if you look at the palmitic acid content, similar, markedly decrease in the responders and increase in relapsers, where you remember palmitic acid can cause apoptosis of beta cell. So here is a role of both liver fat as well as pancreatic fat, and this is particularly important as far as reversal of diabetes is concerned. Now, what drug, as far as SGLT2 inhibitors are concerned, we had some discussion about the empagliflozin and liver fat and so on, but hardly anybody in the world has tried to reduce pancreatic fat using SGLT2 inhibitor. And this is our study, Journal of Clinical Endocrinology Metabolism, in April, and we took overweight patients, 20 to 50 years, uncontrolled diabetes, on stable dose of metformin and sulfonamide ureas for 8 weeks, and on ultrasound grade 2 fatty liver, we did the estimation of the hepatic and pancreatic fat measured with MRI proton density fat fraction. So look at this, these voxel, 9 voxel were taken in the liver and 3 voxels were taken in the pancreas. These are region of interest or voxel. And look at one such report, right lobe, how much is the percentage fat, left lobe, how much is the percentage fat, and how much is the fat in the pancreas. Now this protocol, you see, this protocol was over a period of time, 8 weeks to 12 weeks, led to decrease in the skin fold thickness. Now, this is subcutaneous fat decrease, and also a decrease in the fasting insulin level, PP insulin level, and C-peptide level. But more importantly, liver fat decreased markedly. And look at this, the reduction from 15 to 10%, not as much as the low-calorie fat, the diet study, which was 10%, but 5% in this study. And pancreatic fat from 7.5 to 5.9%, which is 1.5% in limb study, low-calorie diet study, it was 1.8%. So it was nearing there. And so reversal of diabetes could be possible using drugs. And we, for the first time in the world, we tried to reduce pancreatic fat using a drug. So this is the conclusion of the lecture. Several studies have demonstrated a link between pancreatic fat and impaired glucose metabolism, as well as pancreatic fat and type 2 diabetes. In general, pancreatic volume decreases with age and in diabetes. So with age it decreases and in diabetes it decreases. But what happens to Indians? In Indians, we don't know. While pancreatic fat increases with both. Ethnic differences in pancreatic volume fat have been reported. Research in India is negligible, and we are going forward with our research, and we'll be reporting a couple of studies in next 2-3 months. Fatty A is a key metabolic regulator causing effect on pancreas and multiple other tissues and responsible for insulin resistance, hyperglycemia, and with permitted beta cell apoptosis. Pancreatic fat deposition may lead to defective insulin secretion, apart from insulin resistance, and different approaches such as hypocaloric diet, exercise, bariatric surgery, and pharmacological intervention, as has been shown by us, can reduce pancreatic fat content, and decrease in the pancreatic and hepatic fat and decrease in fatty A could lead to reversal of the diabetes. So once again, Rajiv and Shalini, thank you for giving me this opportunity, and thanks for your patience.
Thank you. Please stay back for discussion toward the end. Thank you.
Thank you, sir. That was an excellent presentation, sir. Thank you so much. We can have a question at the answer session of end of next session. Next session is by another doyen of diabetes. Once again, the Padma Shri awardee, Dr. V. Mohan. I'm sure all over the India, all over the world, people know about him, but it's my customary to introduce Professor V. Mohan. Dr. V. Mohan, he is the chairman and chief of diabetology at Dr. Mohan's Diabetes Specialty Center at Chennai in South India, which is an IDF center of excellence in diabetes care. Dr. Mohan oversees a chain of 50 diabetes centers across 8 states of India and has over 560,000 registered diabetes patients in his centers. He is also president and director of Madras Diabetes Research Foundation, which is Asia's largest standalone diabetes research center. His main research interests are epidemiology of diabetes and its complications, genomic of diabetes, including monogenic diabetes and type 1 diabetes, fibrocalculus pancreatic diabetes, and precision diabetes. He has published over 1,500 research papers, the highest by a medical doctor in India. I should once again say this is only a brief introduction of Professor V. Mohan. So if we should have one session to know completely about Professor V. Mohan because of his huge achievements. Over to sir for your presentation, please.
Thank you so much, Dr. Arvinda. Let me share my slides. I hope it's visible.
PowerPoint mode, sir.
Is it visible now?
Yes, sir. Yes, sir.
Okay. So let me start with thanking Dr. Rajiv Chawla and Dr. Shalini Jaggi and the organizers, and also thank you, Arvinda, for the kind words. I know you have a star-studded international faculty as well. It's been my pleasure to participate in almost all these meetings over the last few years, and heartiest congratulations on the 9th edition of the International Symposium on Diabetes. So my topic is precision diabetes care. The time is now, and I know that about half an hour later, Dr. Ranjit Thonikrishnan is also going to talk on monogenic diabetes. There can be some overlap between these two, but I think his will be mostly a clinical talk about how to diagnose monogenic diabetes. Mine is a little bit more broad. I don't have any conflict of interest to declare. The studies are supported mainly by ICMR, but also some by DBT, DST, and also by the National Institute of Health Research, NIHR, in the UK. So I'd like to start at the beginning about what is precision diabetes and what is personalized medicine. Precision medicine, personalized medicine. In the case of diabetes, will be precision diabetes and personalized diabetes. Now, there are many definitions, but for me, this one is my own simple definition. If you try to have the other, I remember many years ago, I gave a talk on not exactly precision diabetes, that word had not yet been used, but I was talking about why you should distinguish different types of diabetes. And I know that Dr. Anup Mishra had put out at that time a beautiful, flow chart showing that not all type 2 patients should be treated the same. There are lean people and there are obese people, and so different kinds of treatment. And I was trying to put all this together. And a colleague of mine came up after the talk, and he said, why are you confusing everyone? Give everyone metformin. That doesn't work. Give sulfonylurea. That doesn't work. You give something else. DPP. That doesn't work. Give something else. That's it. Finished. Very simple. Why are you confusing the world with saying there are so many types of diabetes and all that? If nothing else works, give insulin. That's it. Then I said, okay, then my security guard can also treat. He can pick a lottery and say which one we should treat. So bringing science into it, and whatever science you have, and you saw the extensive science which Dr. Anup Mishra just presented before me. And so when you bring all that science together, then in the future, and even today, I would say, our brain itself tells us, don't even need artificial intelligence and so on, tells us that this particular patient, this particular drug seems to be good. Heart failure, SGLT2, and so on and so forth. But there's also the role of environment and genetics and all this put together based on science. You say this particular diagnosis seems to be the precision diabetes, and for that, this particular treatment seems to be good. But then what happens is that there is also a person with diabetes in the center of all this. And that person may say, all that is fine, but I don't like this. I refuse to take this. Now, what do you do? So you'll have to also take the patient's social context and preferences and all that into account, because after all, we are not treating a robot, nor are we robots treating. So we have to take the patient's needs, affordability, and many other things into consideration. And that makes it personalized. Today, we are not in a stage where everybody for every disease can get personalized medicine, but we are slowly but steadily approaching that. The ADA and EASD Precision Medicine and Diabetes Initiative was started somewhere in late 2019, and by 2020, they had a committee. I'm very happy that I have been inducted into this committee. Practically every week, we meet on various aspects. In fact, initially in the executive committee, mostly there were people only from US and from Europe. But then they, in their wisdom, they then realized that India and China are very important, because 40% of the whole world's people with diabetes come from these two countries. So they very kindly inducted me and my good friend, Dr. Linan Ji from China. So to get a broader perspective on this. And so we have come up with this international perspective and future vision. The whole idea is that precision medicine and diabetes itself is divided into type 1, type 2, monogenic diabetes, GDM. And for each of them, we have a precision diagnosis and precision treatment and precision prognosis and so on and so forth. So there are different groups working on it. We're going to come up with a series of white papers, which hopefully next year will be published as a series of papers. Well, today, in the interest of time, I'll talk a little bit about type 2 diabetes, but there I think the field is very rapidly exploding. I'm not talking about type 1 diabetes because that's still a work in progress, although considerable amount of work is being done on that. And then I'll talk about the monogenic diabetes and neonatal diabetes, what you should know, and we'll try to avoid overlap with what Dr. Ranjit will be talking soon. Now, this field of type 2 diabetes, we all knew for a long time, and we in India, led by Dr. Anup Mishra, actually came up with the thing long ago that if you have insulin resistance as a main thing, you consider a drug like a sensitizer like metformin. Whereas if you have insulin secretory defect, you can give a sulfonylurea, DPP4. These may be people who need insulin faster and so on. But the field really took off after Leaf Group and colleagues published this very nice paper in 2018, classifying type 2 diabetes into different types. But I'll straight away hasten to add that the first type that they introduced into this is nearly not type 2 diabetes. It's a variant of type 1, what we used to call as LADA, the severe autoimmune diabetes. So that you can exclude straight away in the diagnosis of type 2 diabetes. But the other four, which they describe, are very interesting and very novel. First is where insulin deficiency seems to be the main defect. We know that in type 2 diabetes, you have both insulin deficiency as well as insulin resistance. But in some, the deficiency stands out. And this seems to be more common in Asians, South Asians, Japanese, and so on. Whereas the severe insulin-resistant form, where you have severe obesity and the fat, which Dr. Anup was talking about, and so on, is more in this variety, the SIR-DD variety, although there's overlap between all the three. They had another variety called mild obesity diabetes. There's no insulin resistance, but there's obesity. We do see this, but this is not the commonest form that we see in India. And the last one is a mild age-related diabetes. So these four types were described by them. So we wanted to see whether this can be applied to Indians. And the reason for that is many people who are also speakers in this meeting, for example, have worked on this phenomenon of the Asian Indian phenotype, and which consists of lower age at onset type 2 diabetes. The BMI threshold is lower. That means you don't have to get obesity as in obesity to get diabetes. And then there's insulin resistance. Number 4 and 5 are very important to me because there's a rapid decline in beta cell function, which occurs much more rapidly in our population. Therefore, the progression from pre-diabetes to diabetes and from normal glucose tolerance to pre-diabetes and diabetes occurs much more rapidly in our population. Number 5 to me is very important because this is one of the hallmarks of the South Asian or the Indian, Asian Indian phenotype. The very low HDL levels that we have and the high triglyceride and the small dense LDL. Of course, there are many, many others, including the thin fat Indian, about which Dr. Yajnik will be talking, and many others, which actually Dr. Anup Mishra also just talked about. So given this, we said, okay, let's see whether those 4 types fit in exactly in our population. This was a collaborative study between our MDRF and the University of Dundee in Scotland. And this is what is called as the INSPIRED study. And INSPIRED stands for India-Scotland Partnership for Precision Medicine in Diabetes, funded by the NIHR in the UK. We published this 2 years ago in BMJ Open, and we described it as novel subgroups of type 2 diabetes and association microvascular outcome. Now, let me tell you how we went about it. First thing that we did was we took the exact criteria, the exact K clustering, and everything as was done in Scandinavia. Our objective was not to disprove them, but to prove them. But then we found, and it's there in the paper for those who want to read, it was all over the place. We just could not get their system falling in exactly in the Scandinavian system, falling into their 4 or 5 subtypes. When we tried to replicate in India, it's going all over the place because our phenotype is so different. Having given up after several attempts and shown what comes out, we use their clustering. We then thought, let's bring in some of our own thing. And that's why we added the HDL, the low HDL and the triglycerides. The moment we did that, everything fitted in very nicely. And where did we get this data from? We had 2 sources. In the first set, we took our own clinic patients, about 20,000 of them. The original Scandinavian group had about 8,000. We took about 20,000 people, relatively newly diagnosed within first 5 years of diagnosis, and from different states of the country. And then we use this K clustering and machine learning to see what kind of clusters come. We then replicated this in the INDIAB study. You know that the INDIAB study samples the whole country, 124,000 people, representative of India's 1.36 billion. I'm happy to say that the study is now over and the next phases of INDIAB have just started. Now, when we went to INDIAB, when we use the clinic data, because we have C-peptide and all that, we use that. We use HOMA beta, HOMA AR, C-peptide, everything. Because clinic phenotyping is much stronger than an epidemiological study. But when we tried to scale it up to the whole of the country, we simplified it. We just made it age at diagnosis, BMI, waist, HbA1c, triglyceride, and HDL. Now, this will be available in any clinic. If any of you want to do that using the simple criteria, we can do that. What did we find? We found the same in both the clinic population as well as the INDIAB population. And subsequently, we did it in another clinic population where we took samples from many of you, about 10, 14 collaborators all over the country sent their data, and we got the same results. So the results are consistent. What did we find? The first is the severe insulin deficient variety, which Leaf Group had shown, is there in our country, but it's much more severe. 26% of people have that. It occurs at a much younger age. They're much thinner, and they have much lower C-peptide and much more severe insulin deficiency. The insulin-resistant variety was very different from what they had what they described as SIRD. So we called it as IROD, which is a little different. And if you read the paper, we'll tell you the differences. But what was absolutely new and novel for the first time is this combined variety. Till we had reported this, there was no report in the world literature of a combined insulin-resistant and deficient variety. And these people had the lowest HDL cholesterol and the highest triglycerides of all the 4 groups. So this seemed to be a truly South Asian or a truly Asian Indian phenotype. And then, of course, we had the mild age-related one. Difference from Scandinavia was that their age-related was 65 plus. Our age-related was 50 plus, 15 years lower. So even the MARD or mild age-related, there were significant differences from Scandinavia. Now, you may say, what is the clinical significance of this? Why don't you just treat like my colleague told me, just give them metformin for everybody, and that doesn't work, throw in one DPP or whatever your choice or whatever your next comes to your mind, you throw that in. That's it. Diabetes treatment is so simple. Now, one of the things that came out in the Scandinavian study, and we were able to exactly replicate that, is the insulin deficient variety is more prone to retinopathy. That's what they showed, and that's what we also showed. Whereas the insulin resistant variety, they did not find to be more prone to retinopathy. And we also found the same. But remember, we had a third group, the CIRDD. Now, what did we find there? Now, the MARD is actually taken as a reference, okay? So what we found was that the CIRDD was prone to retinopathy. It was also prone to nephropathy. Now, am I surprised by that? No, because they have insulin deficiency as well as insulin resistant. So to cut a long story short, the more insulin deficient people are more prone to neuropathy and retinopathy, whereas the more insulin resistant ones are more prone to kidney disease, liver fat, and to cardiovascular disease. And CIRDD, interestingly enough, is prone to both retinopathy as well as to nephropathy. There was one other difference. If you try to treat them with whatever treatment which is given and see how long they took to get to HbA1c of 7% or below, the MARD variety, the mild age-related one, they're the mild type. They got easily controlled. The most difficult to control was the severe insulin deficient variety. And the next difficult was the red one, which is the CIRDD. Am I surprised? No, because they have insulin deficiency. And many of them have not been given insulin. They've been treated, this is a retrospective study, so we treated them the usual way. And that's why we find, you will all find in your practice, some people respond better, some people don't respond. That's because they have more insulin deficiency and you're not giving them the proper secretagogue. Okay. Now, how do you detect this in a clinic? It took us some time, but we have now developed this software called as DIANA. And DIANA stands for Diabetes Novel Subgroup Assessment. Now, what you do, this was developed in-house by us. And what you do here is that you just put in the age, BMI, waist. If you have C-peptide, and you can add that. Otherwise, you have HDL triglyceride, you can just put that. Immediately, within a second, the software will tell you which type of diabetes you're treating in that particular patient. In this particular case, it has said that this is a case of SIDD. It tells you what is the 5-year risk of developing retinopathy and nephropathy. It also suggests that perhaps you should consider a low-dose sulfonylurea, a DPP-4 inhibitor, or you may even give insulin if the HbA1c is very high. To my knowledge, it's the first time that clustering of type 2 diabetes using a simple program has been developed anywhere in the world, which also tells you what is the risk of developing complications. It also prompts you what treatment you can give. Of course, it's up to you to decide what treatment to give. I'm very happy to tell you that this clustering has now been replicated in South Asians in the UK, in Pakistanis and Bangladeshis. In this particular report, there were no Indians. They were all Pakistanis and Bangladeshis. It was published in PLOS Medicine 2-3 months ago. And what they've reported is that the possibility of combined insulin-resistant and deficient etiology has now been replicated by us. We are able to reproduce these subtypes which Dr. Anjana described. So therefore, it is not just an Indian phenomenon. It is a South Asian phenomenon. There are no Indians in this at all. And in the UK, among the South Asians, this has now been confirmed. In fact, the CIRDD, the combined one, has also been now recently replicated in China as well. And a review article has now been written on this, on all the clustering, showing that in Asians, this CIRDD seems to be a unique one. Let me now move on to the topic of monogenic diabetes, because this is where day in and day out, we use precision medicine to treat our patients. Now, maturity onset diabetes of the young, or MODY, you know, as a type of diabetes comes at young age. It looks that they may have type 1 diabetes because they are thin, but they don't develop ketosis and they seem to respond to tablets. 14 types were originally described, of which today, using the ACMG criteria and the final classification of MODY, the MODY 7, 9, and 11 have now been dropped. They are no longer considered MODY. So there are 11 types of diabetes. We have written several articles on how they should be diagnosed and reviews and so on. I won't go into that. But the question you may ask is, why bother about this MODY at all? If I show you a case, and this girl actually came back to me now after 25 years after we started her on this treatment. So she was 16 years old when she first came to us, thin, had HbA1c of 10.4, And automatically, because she's thin, severe diabetes, 16 years old, somebody diagnosed her to have type 1 diabetes, and she's started on 3 times insulin. As you can imagine, children with or parents of type 1 children go around, shopping to different endocrinologists and diabetologists saying, is there any way you can stop insulin? So this child also landed up that. And we don't normally give a promise. We'll say, let's study, and we'll tell you what it is. Now, the first thing we do is to draw a family history, not do the genetics first. We first draw the family history. That's a proban. Her mother had diabetes. Many of her aunts had, and even some of her cousins had diabetes. Everyone in red has diabetes. So with that, we then went on to study her further. We found that her C-peptide was nowhere in the type 1 range. She had much better C-peptide than any of our type 1s. Then we did the GAD antibodies and the zinc transporter, which we routinely do, and it was negative. So we said, okay, there's a good chance. And then she has such a strong family history, 3-generation transmission, which is common in Modi. So we said, let's do Modi genetic testing. This is a few years ago, 2009, we already published this. So you can see that we found the HNF1 alpha mutation, which is a Modi 3. So arginine to histidine mutation. This was done in our lab. And what we found was by that time, her sister also developed diabetes. So we quickly tested her, and she also had Modi 3. So she had, her sister had, her mother had, her aunts had, and even her cousin, who was some 14 years old, he also had Modi 3. So this is a whole family of Modi 3. Now, the beauty of Modi 3 or HNF1 alpha is that they respond to sulfonylureas. So what did we do? We took the patient off insulin completely, started her on glibenclamide, which is the commonest sulfonylurea used. We're also now doing a trial on glycoside. The HbA1c came down to 6.8, and she's still responding to glibenclamide after several years. As I said, she just came back, and 25 years later, she's still doing very well. So this is a classical example of how if we apply a mind and pick up, we might be able to find out cases which are not really type 1 diabetes and then treat them using the principles of precision diabetes. Now, if you thought that that was dramatic, even much more dramatic is this condition called as neonatal diabetes, which is onset of diabetes below 6 months of age. There are 2 types, the transient variety, which comes before 6 months, but by the first birthday, it's gone. It may come back later on during adolescence or adults, but it goes away immediately. Permanent neonatal diabetes is more common in our experience because the transient ones probably don't get referred that much. But permanent neonatal diabetes, we get constant referrals. Almost every day, I'll get a call from some part of the country that there is a child with neonatal diabetes. So this occurs before 6 months and it doesn't go away. Okay. So let me again illustrate this with a case study. This is a 3-month-old female baby who came to us 8 or 9 years ago, I think, from Calcutta. She was diagnosed to have diabetes 2 weeks after birth. That means just newborn child. She was started on insulin, but she was given 14 units of insulin, which is 3.5 kg per body, units per kg body weight, high dose. And it was not responding. 4 times a day she was injected. Blood sugars remained 300 to 400. So worried, the parents came to us. The first thing we did was, we said below 6 months of age, we have to do genetic testing because that is neonatal diabetes. That's mandatory now. American Diabetes Association and everybody recommends that. We did the genetic testing and we were happy when she had this particular mutation, the KCNJ11 mutation. And this is the glycine to valine mutation that she had. Now we were happy because the KCNJ11 mutation, as well as the ABCC8 mutation, which are the commonest mutations in permanent neonatal diabetes, respond to sulfonylurea. So what we did was we started her on glibenclamide, and this is what happened. Slowly, green is the sulfonylurea dose. Slowly, we increase the dose of the sulfonylurea. The dose of insulin was brought down, as you can see, and by 4th day, it became 0. Look at the blood sugars. When she was on insulin, sugars not under control. As the sulfonylurea dose was increased, blood sugars came to near normal blood sugars. And so this is a classic example of how doing a genetic test, which is part of precision medicine, of course, was able to completely change the prognosis for this particular child. This is Ivana when she came, when she was just 2 weeks old. Today, she's, I think, 8 or 9 years old, and she's doing extremely well. She's not had a single shot of insulin since that time that we made the diagnosis of diabetes. She's growing very well, and she's doing really well. The first report of some 30 cases of neonatal diabetes we published 10 years ago, but today we have a very large series. And if you have, as I said, the KCNJ or the ABCC8 mutations, Now, these are the HbA1c levels when insulin was given. But after changing sulfonylurea, you can see they've come down to normal and the blood sugars have come down to normal. Now, we also, when we do the genetic testing, we also pick up other things. For example, they may come like a ordinary type 1 diabetes. But when we do the genetic testing, we'll find out it's Walcott-Rollison syndrome. You may ask, what does it matter? Well, children with Walcott-Rollison syndrome don't live beyond their 18th birthday, whereas somebody with type 1 diabetes can live up to 90 years of age. The oldest I know of is 90 years of age. So it's a complete change in the prognosis once you make the diagnosis of this. DID-MOD, where hearing will go, diabetes insipidus comes, and thiamine responsive megaloblastic anemia. You just give thiamine, the anemia goes away and the diabetes goes away. It's very dramatic. You have to see these cases to believe it. Now, we have a large series now, 1,562 cases of monogenic diabetes in our case series, 315 neonatal diabetes, 76 syndromic forms. MODY 983 are the referred ones. Not all have the genetic mutation. Look at hypoglycemia, almost 200 cases of hypoglycemia diagnosed just after birth, like neonatal diabetes, much more difficult to treat. Neonatal diabetes is very easy to treat. Congenital hypoglycemia is a nightmare. Some will respond to diazoxide, some will need octreotide, some need pancreatectomy. By doing the genetic test, we can say who needs which. And today we have a kind of lookup table. Based on the genetics, we can tell you which kind of response will occur in congenital hypoglycemia. In fact, if you take them all together, MODY, neonatal, syndromic, and congenital, we are probably one of the few centers in the world which is doing all of them. We are a nodal center for monogenic diabetes testing, and we get cases from all over the country, including at least 50 or 60 medical colleges and pediatric institutes keep referring to us. We have set up a registry for this, a monogenic diabetes registry, which is constantly being updated. So I'd like to end, ladies and gentlemen, by saying that precision diabetes is slowly coming of age. It can be applied to all forms of diabetes, including type 1. But type 2 is where the field is moving very rapidly forward. There are 4 clusters in India: the SID variety, the MARD variety, the IROD variety, and the SERD variety. We are doing a randomized clinical trial right now, following the pathophysiology of these 4 types and seeing which drug responds better to which particular treatment. The recruitment is just getting over, and hopefully in a few months we'll be able to publish for the first time, based on the accurate diagnosis of type 2 diabetes, a randomized clinical trial using metformin as starting point, the control arm, and using the specific drug in the intervention arm. Study of monogenic diabetes has helped people to go off insulin, and precision diagnosis helps precision treatment. All children, if you want one message from this lecture, all children with diabetes diagnosed below 6 months of age must undergo genetic testing. You may say, well, they can't afford it. We'll do it free. Just send it to us. Nobody asks for 1 rupee. Anyone in India has any child below 6 months of age, just send it to me. 3-4 weeks time, we'll give you the result without 1 rupee being charged to you. Neonatal diabetes, the ABCCA and KCNJ11 can be transferred to sulfonylureas. Now we have hundreds of cases which are now being transferred to sulfonylureas and insulin being completely stopped. So it's nothing short of a miracle as far as the child and the family is concerned. All this is possible because of a huge team that we have. This is our genetics team, headed by Dr. Radha Venkatesan. This particular team alone has 139 publications on the genomics of diabetes, various forms of genomics, and 15 PhDs have already been completed, and a few more are now doing their PhDs. I'm very proud of this particular team who work very closely with the clinical team, and therefore from the lab to the clinic and from the clinic to the lab is something, a kind of an unique integration which we have brought about, which has helped to change the lives of children with diabetes, with monogenic diabetes. And with that, I'd like to stop, and if there are any questions, we'll take it up. Thank you very much.
Thank you, sir. That was a very excellent presentation and an excellent deliberation. I'm sure the audience would have been benefited with your talks. I request the audience, I always tell, getting the doyens on the same time is very difficult. We have got 3 doyens here, Professor A.K. Das, Professor Anup Mishra, and Professor V. Mohan. So kindly go ahead and ask all the questions you have in your mind.
I think this was professor's session and wonderful class for all of us. I think Dr. Das had to leave, so may I ask Professor Mishra? Dr. Das said that today we are talking about diabetes originates from liver. And earlier days, we were talking about diabetic hepatopathy and all that. So is the final word out, whether it is a victim or an ally in pathogenesis of type 2 diabetes?
As Mohan has presented, it's a heterogenic situation, a lot of heterogeneity. And what he has unearthed is actually, I think, it's a tip of it. There is many more things to go by. For example, muscle has been totally forgotten in the whole thing. And we have some evidence that even if there is a bit of muscle sarcopenia, then itself is an independent risk factor for diabetes. So while we focus on liver, certainly, and we say that maybe liver is the primary organ from which insulin resistance is originating, diabetes is originating, and it's further establishing a circuitous route through which a hepatokine, which goes to the pancreas, injures the pancreas, blood sugar rises, which further increases the hepatokines. And so there's a vicious circle established. This is what we are increasingly seeing in obese people. And as Mohan said, that not everybody is obese. Some people are thin and there's a different etiology involved. So the ultimately final pathway remains the islet cell beta cells. Whether insulin resistance occurs or insulin secretory defect occurred, and what is the role of muscle in all this, what is the role of ultimately the increasing liver fat and all that, I think it remains to be established. We are learning a lot as far as Indian patients are concerned. Our patients are totally different from the West. And so this is what is required. The type of research that Mohan is doing, the type of research others are doing, Dr. Ramachandran is doing, and we have contributed a bit. So I think this has actually massively escalated our understanding of the subject in last couple of years. And that's what, Rajiv, I always say that RSDI should boost, and Bridge is right here, he's at the helm, boost the young researchers' capability of doing meaningful research. And just put a hypothesis in front of you, and you'll like to find the answers to that using very simple research methodology and not much of a money. So I think, I'm sure Bridge is hearing about this, and he's in the right position to encourage our young.
Baton is already in hands of Makkad, so I'm sure he himself is a learned man, and with a lot of inspiration coming from your and Professor Mohan's sessions and teachings which have been given vertically, I am sure with RSSG we'll take it further. And last comment from Professor Mohan, you always advocated the precision medicine. Again, is it time? One of your publication led by Anjana recently, where all of us, we are part of that, that even while prescribing therapies these days, there is a role of precision medicine based on our own clusters, which you have demonstrated. So is it time that when we evolve next year for the guidelines, shall we talk for precision medicine when it comes to prescribing a particular drug?
I think we're getting there, but we need to do RCTs because hypothesis may not always be proven. When you do it, when you do the trial, you may not get the same results. But we are doing this trial in the groups, subgroups that we have described using the Diana software, and then we're doing that. As we speak, I'm reviewing a paper, I'm not supposed to say, but New England Journal has just sent me a paper for review, and it's discussing two of these subtypes. It's from abroad, so two of these subtypes where they're giving different drugs and they are seeing. So you can see the field is already moving. People are not just giving the same treatment to everyone, but they're trying to see, okay, what does this chap have? Or what does this lady have? And should we give a different approach? So that is what precision diabetes is all about. And I think it makes sense. Even today, whether you know it or not, you're practicing it. See, somebody has heart failure, will you not give SGLT2?
Very true.
That is precision medicine, no? With what we're treating. Exactly. If you have a cardiac, if you have a renal thing, oh, okay, SGLT2 may help in this case. Alpha-melanoidase may not help in that particular case. So we are already subconsciously thinking about it, but we need more and more data.
I think very fact that while doing a prescription or while seeing a patient, if we are using our prudence, we are doing precision medicine.
Exactly.
You very rightly did.
Putting it in a trial form and getting more evidence, take that precision to the next level. That's it.
Thanks
for clinicians,
Rajiv. Yes,
Rajiv, for clinicians, 2 or 3 things are important at this point of time till more evidence builds up. One is the BMI of the patient, the waist circumference of the patient, and if they can palpate liver and do one ultrasound. I think this is what is important. If patient is thin, we go into different direction. If patient is obese and has fatty liver,
you wrote that many years ago, Anup, when
Yes.
you remember that paper we wrote, where the thin people give a secretagogue and the obese people. Nobody had written that in the literature at that time. So, and this is before Leaf Group's paper and all came. So I think we're already thinking on that, but we are putting hypothesis. Now we have to do the trials to
through RCTs and
then it will get accepted.
More evidence from India.
Otherwise, just remains hypothesis. Yeah.
Thank you very much.
Rajiv, can I have a question, please?
Professor
Mohammed had a question.
Mohammed, yeah.
First, I would like to thank you very much, Rajiv, for such a wonderful session with some of the experts from India and globally. My question is to Professor Mohan. The Gulf, since I moved to the Gulf region, I realized that there is a lot of overlap in the ethnic backgrounds of even people from the Gulf who have in the past and the current years have married from Asia, from the Indian subcontinent. Perhaps it's time for our collaborations to move from just educational activities to research into the region of these precision issues and the genetic backgrounds of the Gulf population, and even to extend to even the Middle East population because of such an overlap. And I hope that this is an open invitation to establish the research from this region as well.
100%. I don't think I can agree with you more. I think more international collaboration is needed, and the Gulf is a very good example because obesity is one of the highest there. You have the highest prevalence of diabetes, while we have the highest numbers. You have the highest prevalence. So what happened there, as Anup said, despite the obesity, unless you had insulin deficiency, they wouldn't have got diabetes in the first place. Plain obesity doesn't produce diabetes. So what is going wrong there? And then the other factor that you have in the West, in the Middle East, with respect to monogenic diabetes, is that you have very high consanguinity rates. And when you have consanguinity rates, autosomal recessive conditions increase. So I've seen some reports coming that these genetic syndromes which I showed in the last slide, that is your major type. Not the KCNJ11 and the ABCC8, which in Europe is very common or in UK is very common. So there are a lot of things which we can study. And I think when we include more, kind of ethnic groups into this, our understanding will only increase further.
Thank you. Thank you very much. Thanks a lot, Professor Mohan, Professor Mishra, Dr. Mohammed. Over to Sain and Dr. Maria for conducting the next session.
Congratulations. Keep it up.
Thank you, sir.
Thank you.
Wonderful sessions.
Thank you, sir.
Thank you.
Thank you, Shalini.
Good evening, dear friends. I welcome you to this very interesting symposium, which will be on technologies in diabetes. And we'll hear from three very well-known experts and in their field who will be telling us about the impact the technologies have had on our follow-up of the diabetes and the management of diabetes, and whether or not they have any impact on the outcomes of the diabetes. For this, we have the first speaker will be Dr. B.M. Makkar. He really needs no introduction. He's well known to all of us, and is MD, FIMS, FICP, FRSSDI, FRCP Glasgow. He's director of Dr. Makkar's Diabetes and Obesity Center, New Delhi. He's president-elect RSSDI 2022 and honorary secretary RSSDI 2017-19. And he is member AACE International Committee and AACC Professor Business Committee. His course director, Advanced Certificate Course in Diabetes 2010 till date. And he has publications in several books, national and international journal. He'll be talking to us about self-monitoring of blood glucose in clinical practice, the current status. Dr. Makkar, please.
Thank you, sir. Am I audible?
Yes. Yeah, very well audible.
Thank you, sir.
Very well audible, sir.
At the outset, I would like to thank CMRE and Dr. Chawla especially for this opportunity. And I'm going to speak on one of the, very important aspects of diabetes management, which is the self-monitoring of blood glucose.
हाँ
And
नीता निकल गई
I am
है,
happy
मालूम
that
नहीं है, आप
this
ही कर लो एक पार्था और उस वाला यार रंजीत वाला।
I am happy to be,
कर लो यार, कर लो।
involved
दोनों
in the
पढ़े लिखे बंदे
technology
हैं, कोई अच्छा
session
बंदा
because
चाहिए यार उधर। ये
Dr.
करके
Chawla,
निकल
you
जाना
are
जी, कर लो यार।
Rajiv, please say, yeah.
so. Good evening, everyone. So I am going to speak, as I just mentioned, on SMBG in clinical practice, and I'm happy that session is included in the technology session because a lot of things are changing even in the self-monitoring of blood glucose in clinical practice. I don't have any disclosures for this session. Why, it is important to have a good glycemic control. That's the first thing. We know that glycemic level is the increased glucose level is the hallmark of diabetes, and controlling glucose levels is directly associated with vascular complications or vascular risk of diabetes. There is a strong evidence to prove that good glycemic control is associated with reduction in both macro and macrovascular complications, and that is why achieving good glycemic control is possibly of the utmost importance if we are looking at optimum management of diabetes. Now, when we are looking at good glycemic control, we can't control well unless we are monitoring how the glucose levels are doing. And we know glucose levels keep changing minute to minute, within few minutes, within days and over days. So we have to keep monitoring glucose level. And what are the modalities that are available for monitoring these glucose levels? The most commonly used modality is the self-monitoring of blood glucose, which provides day-to-day plasma glucose levels. The other is the glycated hemoglobin or A1C, which provides average blood glucose levels over preceding 2 to 3 months. And the fructosamine test, which is uncommonly used because the standardization issues are there. It can provide preceding 2 to 3 weeks average glucose levels. And now we have continuous glucose monitoring, which is also available as a tool for the patients to monitor their own glucose levels on a more or less continuous basis. And this measures interstitial fluid glucose levels for a varying duration of time. It can be every 3 minutes, every 5 minutes, or 15 minutes, depending on what tool we are using. So two primary techniques that we commonly use in the clinical practice are the patient-monitored blood glucose or the self-monitoring of the blood glucose by patients and the A1C. Now, guidelines have started recommending CGM as an important tool, and the recommendation is that CGM has important role to play in assessing the efficacy and safety of treatment in subgroups of patients, especially with type 1 diabetes and selected patients with type 2 diabetes who are treated with insulin. My focus in this presentation is going to be self-monitoring of blood glucose. So, what is self-monitoring of blood glucose? The self-monitoring is testing and recording blood glucose levels by patient and or the patient carer at different times of the day. SMBG, we all know, is critical for management of patients with diabetes, because if we don't know the glucose level, we don't know, there is no way we can change treatment, optimize treatment or change the dietary factors or the exercise and so on. Provides information about glucose levels in the real time, helps controlling day-to-day glycemic variability. It gives immediate feedback to provide, to take further actions depending on whether you want to change medication or exercise, or there is a change required in diet. And therefore, SMBG basically helps clinicians to take informed therapeutic decisions and help patients achieving a better glycemic control. So SMBG is a very important tool in the control of glycemia. Now, the problem is that despite knowing all this, we have very low level of usage of glucose SMBG in India. And this is data from ICMR INDAB study. And if you see that overall, about 15% people with diabetes are using SMBG in urban areas, and only about 9% of the people with diabetes are using SMBG in rural areas, which is a very dismal figure. Now, whenever we talk of SMBG or the blood glucose testing at home by patient or carer, the usual thing that they do is they keep jotting the values in a diary. And good number of times some diary is something like this. So this doesn't make any sense, because this just gives a, random figures noted at random times. And if we are not able to make out a pattern, like in this image we are seeing, number of values before lunch, after lunch, and so on, but we can't make out any pattern. So if we are not able to make out any pattern, or it is an unstructured or planned glucose testing, it has no value. Now, why clinicians don't utilize SMBG data in clinical practice in Indian setting? Possibly the multiple reasons are there. One of them is insufficient clinical information with the patient how to do the SMBG properly, and they are not having proper education and training in monitoring their own glucose at home. There is difficult to analyze data or effectively track results and react to those results by modifying the treatment. At times, people are testing only in the morning and they think their glucose in the morning is fine, but their postprandial during the day may be haywire. So it gives an overestimation of the quality of care provided. And, there are fear of adverse events. There is poor confidence in the patient or carer's own ability to manage insulin dosage or insulin level. So there are multiple reasons why, clinicians are not using SMBG in clinical practice. So on the patient side, there is lack of, SMBG performance because of the poor education and training in performing the SMBG. And this leads to, unstructured testing at the level of patient, which doesn't provide adequate information for the clinician to apply it to treatment decision making. And this leads to lack of clinicians using SMBG. So there is a vicious circle, and this leads to actually unrealized value of SMBG, the value that SMBG can actually provide in management of diabetes. And this is where the structured SMBG or structured self-glucose monitoring comes into place. So what is structured SMBG? Structured SMBG is nothing but monitoring blood glucose levels at the right frequency, at the right times, and in the right situations. Structured SMBG is a methodical approach to blood glucose monitoring and involves checking blood glucose levels at predefined times and on every day. And this enables both patient and clinicians to understand the blood glucose patterns throughout the day. And once you get the patterns, you can analyze the patterns. And if the patient is also recording the food intake or the physical activity, actually you can understand a lot about how the glucose levels are changing and why they are changing. And then you can have informed, decision making and make appropriate therapeutic adjustments based on the structured SMBG values. So SMBG is effective only when it is done in a structured manner. And patients need to be educated on the purpose and procedure of SMBG. And education should also include explaining the patients on the importance of good glycemic control. If they don't know why they're having a good glucose control, why they are chasing glucose values, it doesn't make sense to them to look at the values also. And clinicians should also be having adequate knowledge to interpret the glucose values correctly, to correlate the impact of medication, meal, exercise taken before or after the values, and understand the pattern and take appropriate actions in improving the therapeutic impact. Now, as for the keeping a diary is concerned, patients need to be told how to keep a good blood glucose diary. And now most of the new meters actually have a inbuilt system which connects with the phone or the laptop, and all the values get transferred into the diary in a very, very appropriate manner, and you can see when the test was done and how it was done. And one should emphasize on entering all the results and also make comments about the daily activity or the eating or missed doses and all that. And this can be, interpreted by the physician in detail. Now, advantages of SMBG include that this helps both clinicians and patients to achieve desired levels of glucose control while preventing hypoglycemia or significant hyperglycemia, thus plays a crucial role making the journey of achieving good glycemic control, whether it's on oral agents or insulin, safely and effectively for all the patients. It also, if you educate the patient properly, it empowers the patients in managing their own treatment. They can make adjustment in their lifestyle, their eating behavior, and also their insulin doses. Now, if we compare with A1C, 2-hour glucose levels, have been shown to be more stronger predictor of cardiovascular disease, which can be easily obtained by SMBG. And if we are looking only at the A1C values, which just give a overall average of last 3 months, actually these values may not be very accurate also in Indian setting. One, because of the lack of standardized equipment available in majority of the labs. And then there are other factors like hemoglobinopathies, the wide prevalence of anemia, blood loss, and even in pregnancy, there is a rapid turnover of RBCs, and maybe you need to do more frequent SMBG rather than relying only on A1C. And if you are doing A1C, maybe you have to do it every month because you want to, see the impact of changes in treatment on faster basis, and you want to achieve the control faster. So for a patient, structured testing means improved disease awareness, improved ability to recognize and estimate the impact of certain behaviors or impacts on events on the blood glucose levels, and their active participation on therapy adjustments. For physicians or healthcare provider, the structured testing means a more reliable data as a base for pattern analysis and therapy adjustments, and possibly help in improving better compliance and more active involvement of the patient in structured testing. So structured testing basically gives you a pattern which is amenable to analysis, helps in treatment decision making and taking action on various aspects of treatment, whether you want to change diet, exercise, whether you want to add or reduce a dose of oral agent or insulin agent or intensify insulin therapy and so on. Now, prior to STEP study, majority of the studies were performed on type 2 diabetes, and again showed that if you do a structured SMBG, then possibly you are able to achieve a better A1C reduction, varying in different studies between anything between 0.3 to 1.2%. And similar data has been shown in studies where patients were treated with oral insulin also. These were all studies on non-insulin treated patients, and there were some studies on patients who were treated with insulin. Now, STEP study was basically a 2-arm prospective cluster randomized multi-center clinical trial, which was done in multiple centers located in eastern United States, involved about 480 patients, and they were divided into active control group and the structured testing group. The active control group was provided usual care enhanced with the 3-monthly visit to the physician and utilizing point of care A1C and whatever available SMBG data was there. Structured testing group, on the other hand, was given the same care, but they were also, doing a structured SMBG, and they were using a AccuCheck 360-degree view, app, glucose analysis system where all the values were being fed. And the results showed that use of structured testing, along with use of this tool to record and interpret the values, was helpful in reducing A1C significantly, providing overall better glycemic control, was also helpful in enabling the therapy optimization and taking efficient steps, also making the use of glucose strips more efficient. Patients understood when to test and when not to test, and what testing at what times is going to be better. And also, if provided enhance the feeling of general well-being or a positive psychological impact. We published the first self-monitoring guidelines in India under the aegis of RSSDI in 2018, and again structured blood glucose testing was recommended as the way to monitor glucose. The guidelines state, or the clinical practice recommendations state, that blood glucose measurement is at predefined times, a structured SMEG should be the way to do it. It is a way of generating reliable and medically relevant blood glucose information with the purpose to support therapeutic decisions. And if we have multiple point SMBG, this may be used in as a substitute to CGM data in resource constrained settings. Recognizing the individual glycemic abnormalities based on SMBG data collected in a structured manner should be helpful in providing pattern analysis or patterns amenable to analysis. And structured SMBG and pattern analysis are tightly connected parts of therapy, helping in decision-making process. Now, another important measure that we are looking at now is the glycemic variability, and plays important role in development of long-term complications independent of the A1C levels. And we have now data to show that high day-to-day glycemic variability is associated with increased risk of severe hypoglycemia, all-cause mortality, cardiovascular disease, ischemic stroke, increased progression or enhanced progression of endothelial or renal dysfunction, and increased risk of cognitive impairment. So this highlights the need for a practical or simple tool, which may be as simple as SMBG, to assess the glycemic variability on routine basis. Now, when we are doing, SMBG, it gives us point values or real-time values, but it doesn't give any, pattern in any particular day. But once we are doing continuous glucose monitoring, it gives an overall view of the variability in within a day. And once we are doing on every day, it gives a pattern over few days. So it is something like we are doing a ECG, which gives a cross-sectional view of the heart rhythm done over a minute, or versus the Holter, which gives a 24 hours recording of the ECG. Now, this has with the use of CGM, we have started using new metrics and new parameters like time and range, time above range, and so on, which I'm not going to discuss because Dr. Bansi is going to speak on the same things in the next session. Now, what we are now looking at is whether enhancing the analysis of SMBG data and cloud-based integrated system can improve, understanding of SMBG, and can this be used, these points measured on daily basis, can they be used as, surrogate marker of glycemic variability for assessing glycemic variability? And this is a study from Italy done by Antonio Catarozzola. This study evaluated in the real life setting the association between A1C and percent of points spent in target range. Points are the glucose values that are within the target range, and these values are picked up from SMBG values in insulin treated type 1 and type 2 patients. And this study evaluated the relationship between A1C and the points in range, mean glucose, and glycemic variability. 197 patients with type 1 and 336 patients with type 2 diabetes were included in this study, and points were considered to be, or the glucose values were considered to be in range when they were between 70 to 180. And this study showed that there is a strong correlation in points measured in range with the 2 weeks and 2 months A1C values. This is a small retrospective observational study that we did at our center, and what we did was we picked up the CGM, profiles of the patients who had been tested for CGM using LibrePro, and they had simultaneously conducted they were doing the structured SMBG on the same days when they were, undergoing CGM, and they were recording that. And we included the patients who were having at least 3 values on a particular day for the study. And overall, we were able to have 93 days of data having at least 4 values, 1 fasting and 3 postprandial values. And we compared the values measured by structured SMBG with CGM profiles on daily basis, looking at the time above range, time below range, and points in range and points above range and below range. And we did for the regular, target range and also the tight control range. And there was a strong correlation found between the, time in range and time above range measured by CGM compared with the structured SMBG. Time below range, the correlation was not significant because we didn't have many data points for that. And this paper, this abstract we presented at the ATTD meeting this year only. So to conclude my presentation, structured SMBG is a methodical approach to blood glucose monitoring. It involves checking blood glucose at predefined levels each day. This enables the patients and clinicians to understand the blood glucose pattern throughout the day. Patients can also record their food intake and physical activity, and this is further helpful in understanding the glucose variations on a daily basis. Physician role is to regularly review the SMBG data at every follow-up and also discuss the SMBG readings with the patient and explain to them what is happening to the glucose values. And this helps in making appropriate therapeutic adjustments based on the structured SMBG values and helps in achieving better glycemic control for most of our patients. With that, I conclude my presentation. Hopefully, I have finished in time. Thank you. And sorry.
Dr. Maria, are you concluding?
Yeah. Thank you, Dr. Makar. Sorry, I did not switch on my mic. Thank you, Dr. Makar, for very nicely telling about the self-monitoring of blood glucose, its advantages and disadvantages, and how to use by using it as a structured monitoring. You can make it more useful and more clinically more useful to manage our patients well and improve their outcome. And with that, I think I'll pass on the mic to Dr. Sen Gupta to introduce the new speaker and carry on discussion today.
Thank you, sir. So let me thank Dr. Rajiv Chawla and Dr. Shalini and team CMRE for inviting me to do chairmanship of this very important session. And we know that technology has been immensely evolving over the last few years to help in both, in all patterns of diagnostics or treatment and prognostication. And like mentioned in the previous session also, is a huge step forward for precision medicine. So going over to the next talk, it's my proud privilege to present and introduce Dr. Banshi Sabu, Chief Diabetologist and Chairman of the Diabetes Care and Hormone Clinic at Ahmedabad. He actually needs no introduction. He's so well known everywhere. Honored with the fellowship of the American College of Endocrinology, the American College of Physicians, International College of Nutrition, and the Royal College of Physicians of Glasgow, Edinburgh, and London, and also has the MMS in diabetology, the past president of the RSSDI 2019-20, president of the AIAARO, the Indian Obesity Society, the vice president of the Diabetes in Asia Study Group, honorary secretary of Diabetes India, has launched a project, Diabetes Free India, which is acknowledged by the Honorable President Shri Pranab Mukherjee, and founder of NGO Diabetes Care India, India Sweet Registry Project. He is doing immense work in type 1 diabetics. Is on the advisory board, JAPI, Journal of Diabetology, expert of RSSDI guidelines for management of diabetes, ATTD, and CGM guidelines, has more than 50 publications in index journals and has contributed numerous chapters in various textbooks and monographs. He has been awarded as the most impactful healthcare amongst the healthcare leaders by World Health and Wellness Congress, and has been awarded the Kadam Prize, IDEA Award. The has multiple diabetes clinics along with AMC with support of the World Diabetes Federation, and has improved the standard of care of type 1 diabetes in Gujarat, which is again supported by the WDF. My pleasure to introduce Dr. Banshi Sabu. He would be speaking on time in range, and over to you, Dr. Sabu, sir.
Chairperson, for kind words of introduction. Thank you, Dr. Rajiv Chawla and Dr. Shalini Jaggi, for giving me an opportunity to talk on a topic which is time in
Bansi, just Ria. Mahima, you are there? Mahima, please help. We lost Dr. Bansi's session.
Thank you, Chairperson, for kind words of introduction. Thank you, Dr. Rajiv Chawla and Dr. Shalini Jaggi for giving me an opportunity to talk on a topic which is time in range, which is very, very close to my heart, and established metrics in diabetes management. We know that the era of diabetes control before 1922, when insulin was not there, there was hardly any way of monitoring diabetes or controlling diabetes. Then we started with insulin therapy. From 1980 to 2016, it was modern insulin. It was many more oral anti-diabetic therapy have come. Most of the people started monitoring sugar also. That was very, very important. It's a self-monitoring of blood glucose. And then it was A1C, which gives you average glucose of last 3 months. And this was established almost from 1980 to 2015. Now, if you see from 2016 onward, what we are using advanced insulin. Now we also use self-monitoring of blood glucose, but we started using continuous glucose monitoring. There is an advanced hardware of using continuous glucose monitoring along with algorithm assistance. HbA1c is still used for monitoring, but there is an emerging use of continuous glucose monitoring for our patients, and we now have a time in range. A concept have come for monitoring rather than only dependent on A1C. The future will be probably more advanced insulin will be there. We will be using more continuous glucose monitoring with refined hardware and software with more algorithm assistance. So person can, with a time in range will be an established for monitoring, and that's what the future which we are seeing. We know there are 3 pillars to manage the dysglycemia. Before UKPDS and Adiposity trial, we understood that it is the hyperglycemia which is to be controlled, and with this trial has shown us by better glycemic control, you are reducing A1C and decreasing the diabetes-related complication. But the limiting factor was hypoglycemia, and because of hypoglycemia, we could not achieve a tight glycemic control for most of our diabetic patients. Then we understood it is not only the glucose control or less hypoglycemia, it is the glycemic variability. And to know the glycemic variability, we have to have a continuous glucose monitoring. And if we have a continuous glucose monitoring, you will be able to know the glycemic variability. And through that, we could know what is time in range. That in 24 hours, how much time person is remaining in range, that is more important rather than just controlling the HbA1c, which is to be considered as one of the best way of monitoring diabetes. So what I'm going to talk, the era of A1C and its limitation. Then I'll be talking the time in range in type 2 diabetes. We know that it is almost established for all type 1 diabetes patients, but I'll be talking more for type 2 diabetes also. We also would like to understand whether this new matrix time in range is directly related with complications or not, and then we will conclude. Almost 25 years before, Adiposity established the importance of A1C. Higher the A1C, more the microvascular complication. And one should try to keep A1C as low as possible, but preferably less than 7, and you will find less and less diabetes complication in type 1 diabetic patients. That's what Adiposity had established. But we wonder about doing a A1C every 3 months. What time of day are in range blood glucose level, which are high or low? We don't know anything if we just get the A1C report after every 3 months. How you are going to adjust the dose of a medication, the timing of the medication. Suppose you have a patient with a 8 A1C and you don't know whether I have to control it is post-meal glucose level more or fasting more, because you may have a person with a fasting established well control and post-meal is high. You may have A1C of 8. Some other patients may have fasting which is slightly higher and post-meal glucose is absolutely normal? You don't know. So when the medication is to be adjusted only on A1C, it's real difficult. What's going on? With food, sleep, exercise, stress, decision, what is working, what is not working. Unless we do continuous glucose monitoring, we can't know about it. I just made it change. Today you have changed some medication, some therapy. But will it make a difference? You have to wait for another 3 months to see the A1C. And if it is not getting control, you don't know. If this 3 months is already been vested and the patient is still in hyperglycemia, or in between patient developing hypoglycemia, you don't know. The quality of life, because if someone may have a good control of A1C, but the quality of life may not improve because there is multiple hypo and hyper could be there. And what experiment should I try going forward? We don't know whether if I change this or if I change my diet pattern or my exercise pattern, will it help to control my glucose or not? Only by getting quarterly A1C will not give any such answer. You may have, as I already told you, a 3 different type of patient with a well-controlled diabetes with A1C of 7. One patient may have absolutely 100% of the time in range. If you just do the continuous glucose monitoring, the sugar remains normal. There could be other patient who is having only 70% of the time in range, 5% maybe in hypoglycemia, and 25% of the time the sugar may be high. But another patient who may have still A1C of 7, but 20% of the time person might be in hypoglycemia. 40% of the time the sugar may be high. It is only 40% of the time the person is in range and still you can have A1C of 7. So there could be many phases of a good control or many phases of an uncontrolled diabetes, and different type of patients you may see. So the credibility of HbA1c as a target for type 2 diabetes has been established with UKPDS, Accord, Advance, VADT. They demonstrated that intensive glycemic control does not reduce the incidence of macrovascular events. We don't know why it is there. It does not decrease the mortality in type 2 diabetes. Since majority of patients with type 2 diabetes with numbers snowballing quickly on a global scale, any new glycemic metric should be tested for its effectiveness to associate with type 2 diabetes complication to replace the long-standing A1C. We know that A1C was the only way, a tight glycemic control for Accord, Advance, and VADT, but majority of our diabetic patients, even after intensive glucose control, we could not decrease the macrovascular events or mortality also. So in novel metrics, that is time in range, a time in range refers to time spent in an individual target glucose level, that is between 70 to 180. And for a tighter glycemic control with a hyperglycemia in pregnancy, it should be between 70 to 140. The percentage time spent below, that's what we call time below range, or the percentage time above range, what we call is time above range. Time in range may be used an appropriate endpoint in clinical research as a measure of glycemic control in patients with diabetes. Emerging evidence suggests that time in range is inversely correlated to risk of developing microvascular and macrovascular complication in patients with diabetes. If I compare between HbA1c and time in range, A1C evaluates single value while it evaluates continuous glucose level. A1C compares every 3 months, time in range compares any time periods. A1C does not capture any hypoglycemia and hyperglycemic level occurring on the same day, while time in range capture all glucose level for given time frame and identified time within a safe range. A1C immediately effect of therapy changes not recorded, time in range immediately detects acute effect of therapy changes. HbA1c is a bad correlation with patient-reported outcome, while there is a good correlation with patient-related outcome with time in range. Time in range has low susceptibility to interference, while the HbA1c, because of various laboratory or anemia or age, there is a possibility of high susceptibility to interference. The only advantage is probably it has got a good correlation with clinical endpoints with many long-term study, because A1C is established since last almost 35-40 years, while time in range is a new metric, and probably we will have many more study which we will see in coming future. If I do a patient with a only self-monitoring of blood glucose. You may have a patient, a typical type 1 diabetic patients doing 4 times in a day or 5 times in a day. You will find out of 5, 4 reports are normal. Absolutely patient, you can say that is out of 5 reports of self-monitoring of blood glucose level, except this post-lunch sugar, which is coming 200, all 4 reports are normal. But if I do the same patient with a continuous glucose monitoring, you'll be surprised to know that patient actually getting pre-lunch hypoglycemia, post-lunch hyperglycemia, and midnight hypoglycemia. So actually we are missing, if I do only self-monitoring of blood glucose, 2 major episodes of hypoglycemia in this patient also. Now, the utility of doing a continuous glucose monitoring, again going back for DCCT trial, in 1983 when DCCT trial was done, to achieve a target A1C of 7, the mean A1C was 9 for all those patients who were the participant in this particular trial. The severe hypoglycemia rate was 62 per 100 patient year. So hypoglycemia is a limiting factor. The mean A1C still they could achieve 7.2, which is very good in a type 1 diabetic patients by giving them a multiple short-acting insulin dose as well as a long-acting like a NPH insulin twice daily, and monitoring the sugar between 4 to 5 times a day. But still the risk of hypoglycemia was very, very high, and it was severe hypoglycemia, 62 per 100 patient year. Then in 2008, after 25 years, if I put the same study, almost similar study with a JDR of CGM, these patients were on a continuous glucose monitoring. The mean A1C was not 9, it was 7.6. Already they were better control, and they could achieve 7.1, which is further good control in these type 1 patients. But the only advantage, they were having now continuous glucose monitoring. Yes, definitely newer insulin were also used for this. In a pivotal trial in 2016, after 8 years, it was an integrated CGM where pump along with continuous glucose monitoring was used. They could achieve from mean A1C of 7.7 to 6.9 with a 0% hypoglycemia. So you can understand the importance of continuous glucose monitoring in type 1, but I will be talking for type 2 also. On this, there was an international consensus on use of continuous glucose monitoring in 2017. I was luckily part of this consensus, and we had come that for all type 1 diabetic patients, if possible, they should be using continuous glucose monitoring. Then the consensus was also for the person with hyperglycemia in pregnancy, in elderly, for type 2 diabetic, who are on insulin, who are at the risk of developing hypoglycemia, those who have established cardiovascular disease where hypoglycemia could be more risk, as well as the persons with hypoglycemia unawareness, they should be using continuous glucose monitoring. Then after 2 years, with the CGM data, if somebody is using CGM, what should be the time in range? What should be the glucose control or glucose in range? So in a regular type 1 and type 2 diabetic patients, more than 70% of the time, the person should remain between 70 to 180. But it is not allowed to have hypoglycemia more than 5% of the time, sugar going below 72. But not even more than 1% of the time, if sugar goes below 54, we have to change the therapy. That's very, very important. So for type 1 and type 2 diabetes, 70 to 180, class 1 hyperglycemia is still okay for less than 25%, and less than 5% of the time, even it is okay if they go more than 250. But if they are more than that, then we have to change the therapy. Again, I was the part of this time in range concept and this consensus. In 2019, it was published, and then it is accepted by all over the world, including all major organizations like American Diabetic Association and European Association of Study of Diabetes. If somebody is elderly, high risk of hypoglycemia or more, is still more than 50% of the time, they should be between 70 to 180. And it is not allowed to go even 1% of the time going below 70. That's very, very important. In pregnancy, this becomes slightly more tighter. Instead of 70 to 180, 63 to 140. And that's very important for pregnancy, particularly in type 1 diabetes. Pregnancy, hyperglycemia in pregnancy, GDM or pre-gestational diabetes, the target range is 63 to 140, but then we want at least 90% of the time they should be in this range. 5% it is acceptable if they go more than 140, and 5% it is acceptable if their sugar goes below 63 also. So this is an international consensus for CGM data interpretation. the standardization of CGM metrics, then we should try to increase the time in range and decrease the time below range and decrease the time above range. Then how frequently? For type 2 diabetic patient, as international consensus was talking about type 1 diabetes, they should be on continuous. For type 2 also, they talked about there should be continuous glucose monitoring for some type of patients. But what about the routine type 2 diabetic patients? And this is recently, myself along with Dr. Jyoti Dev and Anup Mishra, that what should be the frequency of continuous glucose monitoring, which is recommendation from South Asia, where we had also included Pratik Chaudhary, Dr. Akhtar Hussain, who is IDF President-elect, Dr. Shashank Joshi, and our President, Dr. Arvind, and many more, Siddharth one from Indonesia and Shashank from IDF Southeast Asia, that what should be the frequency of continuous glucose monitoring. If somebody is keeping, because we are using a professional one and maybe every 3 months or every 2 months. So those who are uncontrolled and we want to achieve a good control, even it can be done for every month, or the risk of hypo is more. If they are well controlled, even it is once in 3 months, if risk of hypoglycemia is more for them. Otherwise, if they are well controlled, even once in 6 months is also fine. So that's what frequency of doing continuous glucose monitoring to know about the time in range. In type 2 diabetic patients, we had put a frequency of doing this continuous glucose monitoring, which is professional one, which we are using. The future recommendation for these is once in 6 months, once in 3 months, and once in 2 months, as dependent on how much time in range a person is keeping. Accordingly, they can do their continuous glucose monitoring more and more. Time in range should be considered in a target for even type 2 diabetes also. I had written a paper for this, that time in range should be considered a target, not for type 1 only. It should be also for type 2 diabetes. And we have written in this particular paper that using a continuous glucose monitoring and then asking the patient to keep their glucose in range and time in range, it itself is an educational and motivational tool for them. Now, in a scientific meeting, we wanted to know that whether this new metrics time in range is correlated with complications or not, because we have a lot of study with A1C, but do we have the data with time in range? There is a validation of time in range is an outcome measure for diabetes clinical trial. This is a paper which is written by in Diabetes Care in 2019, immediately after then time in range as a metric and a consensus which was published in Diabetes Care. There is a strong association of time in range with the risk of microvascular complication. When a person's time in range is better, there is a less complication, less microvascular complication. Similarly, the persons who have lesser the time in range, they have more chances of risk of retinopathy and microalbuminuria. There is also a data of glycemic variability with cardiovascular clinical outcome. A persons with a lesser glycemic, more glycemic variability and less in time in range found to have a worse cardiovascular outcome too. The similar data is also found with diabetes and kidney disease, with the persons with less in time in range and more with glycemic variability found to have more with diabetes, kidney disease. And this data was there not only for type 1 diabetes, but it was also for type 2 diabetes too. The blood glucose variability leads to rapid progression of coronary artery disease. Even a type 2 diabetic patient with a lot of glucose variability with a coronary artery disease, otherwise also very high risk for a type 2 diabetic patient, but they got rapidly progress for coronary artery disease too. Glycemic variability predicts the development of end-stage renal disease in type 2 diabetic patients too. There is an association of time in range with continuous glucose monitoring, the prevalence of diabetes retinopathy in type 2 diabetic patient. This is one of the paper, again in 2018 from Korea it was published. There is a paper for type 2 diabetic patient with a time in range with carotid intima media thickness. The persons with less in time in range, there is a more macrovascular complication and more carotid intima media thickness was found in compared to the persons who have better time in range. Even from India also, Sanjay Kalra have published one paper that outcome of time in range, the lesser by 10%, there is an increase in risk of retinopathy risk. There is a less time in range by 10%, the increase in nephropathy risk increased by 40%, and time in range less by 10%, there is a neuropathy risk which increased by 25%. So this is the initial evidence also show increase in surrogate markers of macrovascular complication like abnormal carotid intima media thickness also. So this paper from India had also established that time in range is directly proportional with the complications too. So the approach to further use of time in range across 3 stages of maturity establish importance of time in range for blood glucose management across the key stakeholder. First and foremost thing, what we are doing is across the key stakeholder, they should use or understand the importance of time in range. The advanced importance of time in range and promote ease of use of technology to enable use of time in range. Unless our patient understand, increasing the awareness about it, importance first, the doctor, healthcare professional has to understand, and then we have to promote the use of technology, which is continuous glucose monitoring. The perpetuate the use of time in range to sustain blood glucose management across all persons with diabetic population. So the person who are using continuous glucose monitoring, first we have to increase the awareness and then using this technology, and then we have to understand, then those who are using, we have to find they are better getting time in range in their day-to-day instead of going for A1C. To conclude my talk, training programs have an integral role in implementing time in range as a useful clinical measure that complement A1C currently, because we are using. So I can't say that A1C you remove and do only time in range, but at present it complement A1C in daily treatment, decision making. Studies have substantially demonstrated potential use of time in range as a patient-centric metric for glycemic control in type 2 diabetes. Despite its proven value, the clinical utilization of time in range for type 2 diabetes management has remained suboptimal. And I think these meetings and the conferences and talking more about time in range, we are going to increase the awareness about the time in range and continuous glucose monitoring, first with healthcare professional and then with the patient. Time in range has a robust association with micro and macrovascular complication and should be positioned as an endpoint and valued metric for type 2 diabetes management. A1C, we know that it's a gold standard, but glycemic variability is associated with increased risk of hypoglycemia, hyperglycemia, and reducing diabetes quality of life with increasing diabetes complication. Time in range provides a closer view of person's glycemic status. It adds in better glycemic control. Increasing time in range has been shown to have association with reducing microvascular and macrovascular complication in people with diabetes. There are international guidelines have now been updated to include consensus on CGM data interpretation, and a need exists to move beyond A1C alone and also consider CGM data for optimal diabetes management. With this, I once again thank you, Dr. Rajiv Chawla and Dr. Shalini, for giving me this opportunity.
So thank you, Dr. Banshi, for elaborating so beautifully on the concept of time in range and how it is different from a single point metric like the HbA1c, because this gives you gives the patient a much better representation over a period of time, and also its correlation with micro and macrovascular complications. So thank you very much for that lovely presentation. I would hand over to my co-chairperson for introduction of the next speaker. Sir, you are not audible.
Sorry.
Maria,
Yeah. That's sorry. We just had two very eminent speakers telling us about how to monitor the glucose and the newer developments in our technologies, the self-monitoring of blood glucose and the continuous monitoring of blood glucose, and then the time in range concept. Now we have another very eminent speaker in Dr. Jyotidev Kesavdev, who will be talking about other newer future technologies which would help us in managing our diabetic patients in a better way. And Dr. Jyotidev has really, he's a very, very popular person and is known to most of us, but still, to complete the formalities, I'll introduce him. He's MD FRCP London, Glasgow, and Edinburgh University, and the FACP FACE and Fellow FRSSDI. He's Chairman Jyotidev Diabetes Research Center, Trivandrum. He's Central Executive Committee, member RSDI, Vice President Kerala RSSDI, Managing Trustee P.K. Sadeva Trust, Editor-in-Chief International Journal of Diabetes and Technology, and conducts monthly diabetes education by 2 YouTube channels, and published many monthly internet-based free diabetes newsletter for the past 13 years. First author of Indian guidelines on vaccination, insulin pump, and glucose monitoring. Pioneer in the cost-effective treatment of diabetes and use of telemedicine technologies. JDC is an IDF recognized center for Excellence in Diabetes Care, and JDC is accredited for RSSDI certificate course in diabetology for doctors. So let us hear from Dr. Jyoti Dev. What are the future technologies we are going to have which will help us in better management of our patients and a better outcome in them? Over to Dr. Jyoti Dev.
Thank you very much, dear friends. Before I begin, let me take this opportunity to express my gratitude to my dear friends, Dr. Rajiv Chawla, Dr. Shalini Jaggi, and the entire team for giving me once again an opportunity to be part of this very, very prestigious and much awaited international scientific meeting. I am this year given the task of discussing future technologies in diabetes. Every year you have a new iPhone. Every year you have a new Apple Watch. And that itself is revealing the fact that technology is advancing much, much more rapidly at an amazing speed. And I have made sure that I will be discussing only those promising technologies which are likely to be launched very soon for the diagnosis or for the management of diabetes. These are my disclosures. I am pretty sure that many of you could have already procured this television. This is the world's first television with cognitive intelligence. In contrast to conventional artificial intelligence, this system is capable of analyzing multiple components, and the functionality is very, very similar to that of a human brain. Yes, very similar to that of a human brain. The future technologies in diabetes are dependent on artificial intelligence, machine learning, and deep learning. So let me ask my partner Siri in my iPhone the definition of artificial intelligence. Hey Siri, define artificial intelligence.
Artificial intelligence.
Is it going to be a replacement for human intelligence? The answer is no, absolutely no. But AI will have a role. AI will have a pivotal role in 5 areas in diabetes. In predicting diabetes, especially when it is integrated with electronic medical records and when the data is available for many, many years and decades. It is already there existing with continuous glucose monitoring devices and automated insulin delivery devices. In predicting hyperglycemia, maybe even 45 minutes to 1 hour ahead of an event, it can predict complications such as diabetic retinopathy. Almost all of us are having devices in our clinics and hospitals based on AI to detect retinopathy. It can even stage retinopathy. In the detection of complications, in the detection and even management of diabetic food. So the areas are ever expanding. But this is another area to customize personalized diabetes management. Big data analysis considering the plethora of factors which can influence diabetes care and to choose with the help of AI-powered decision making the right therapy from more than 3 dozen medications currently available to choose the right medication for your person. And that is the perfect example of how AI can be a way to personalized diabetes care. Moving on to continuous glucose monitoring devices. Ever since the international consensus has been published and the recommendations are existing for ambulatory glucose profile, continuous glucose monitoring, and the diabetes care is now largely based on time in range and metrics associated with it. And most of these devices are unfortunately not available in Asia. However, we are also expanding. CGM devices, the Guardian Connect. This has an AI powered, and this is powered by IBM Watson Health. The Sugar IQ, not available in all the countries. Look at this prediction. The Sugar IQ Insight. I see that you tend to go high after logging chicken tacos. So it is intelligent. It is intelligent, and already this is associated with 780G in our country. Medtronic has recently, a week ago, launched Guardian 4 sensor in India. And for Medtronic, this is the first ever factory calibrated sensor. And this is also approved by US FDA for non-adjunctive use. And you can see that this is as accurate as the glucose meter. Freestyle Libre, the new member from the Freestyle family. The sensor is 70% smaller. So this is the smallest and the thinnest CGM sensor ever. And what else is the difference? This is a real time. So the CGM has transformed from on demand to always on. And this is again an integrated CGM. So unlike the other CGMs, this can be associated or connected wirelessly with dosing algorithms in your mobile phone or with other insulin pumps. Or it can be the connected insulin pens. Dexcom G7 already US FDA approved, and it has reached the markets 60% smaller compared to G6. It is slimmer. It is the thinnest CGM in the Dexcom family. Dexcom is soon set to arrive in India in the month of January, February. The transmitter and sensor will be combined. So it is a combination of both. And the sensor wear time is also prolonged. It is up to 15 days. And this is again an integrated CGM, which can even be used by the DIY community for looping. And what else is so unique? This I happened to listen to this pad 2 weeks ago. The lag time with the G7 is as short as 3.5 minutes. 3.5 minutes. This is one of the shortest lag time. That is the difference between the interstitial and the capillary glucose level. And this will have an implication when you are connecting with automated insulin delivery devices, and the overall MAD, that is the mean absolute relative difference, which indicates the accuracy of a sensor. Lower the MAD, higher the accuracy. It is as low as 8.1% in the pediatric population when it is applied over the upper arm. So we are soon going to have one of the best and the most reliable and accurate CGMs in the world. Moving on to another innovation, and this is again a long-awaited innovation. What about having non-invasive glucose meters, biofluid-based glucose monitoring systems? Google has tried, Novartis has tried, but many of them have actually withdrawn because of disappointment. And these are some of the examples from saliva, from tears, from sweat, from ISF. But due to many interfering impurities, due to the phenomenon of hysteretic, lot of other nuisance or disturbances, no reason for accuracy. For sweat analysis, every analysis the person needs to sweat, which is probably not practically, not realistic in diabetes population. ISF measurement, skin irritation is a major issue. But still, there are reasons, and there are some of these devices in the pipeline. So I will showcase some of the non-invasive glucose monitoring devices, and this is now commercially available. So look at me. I have this with me now, and this is a non-invasive glucose meter which I have purchased online. And I won't advise you to purchase it because it is not cost effective. This is around 30,000 Indian rupees. Not worth the cost, but it is worth for the curiosity. And this is the world's first patented high-tech non-invasive blood glucose meter. And there are 3 modes for normal people, for pre-diabetes and for diabetes. And this is a demonstration in a person, and it is me as a model over there with no diabetes. There are 4 sensors, 2 in the front and 2 at the back, and you have to lightly press on the sensors with the thumb and with the index fingers. And within 15 to 30 seconds, the glucose number appears over there. It is almost matching with that of the glucose meter value, but unfortunately keeps on changing when you are repeating the same procedure. However, no pricks, no pain, no blood, no cotton. However, I am waiting for the next generation of the same device, e-touches. There is one more which has hit the market, and this is basically an innovation from India. Blue Semi has started from India. We tried contacting both since there were no published article, but there were no response. This revolutionary product is set to have launched at the CES convention at Las Vegas early this year in 2022. There is something different in EVA compared to e-touches. EVA, in addition to the glucose, it also measures a total of 6 parameters: ECG, heart rate, blood pressure, SpO2, and temperature. And this is again based on sensor data, no pain, no prick, and no interventions required. Amazing advancements in technologies, provided this is going to be reliable. We are waiting for more data. We are waiting for more publications from the innovators. Till then, best of luck. Moving on to non-invasive continuous glucose monitoring devices. And this is again the next revolution. Many researchers are partnering with physicians. The engineers are partnering with doctors for these innovative products. So I will go through some of them which are likely to hit the market. This is Scango. Another one is based on G-Wave, and FDA has granted a fast track designation last year. The sensor is inserted in a ceramic, lightweight, comfortable. You can see that it is worn as a wristband and is based on radio frequency to detect the glucose levels. Almost all of them will transmit the information to your mobile phone. We have the Graphier non-invasive CGM, Movano smartwatch, you have My Sugar Watch, D sensor, and this one is really promising, Diamond Tech. And I could see a lot of publications based on this. They have 3 different products. D-base, in the preclinical test, Diamond Tech achieved the same accuracy, almost the same accuracy as the glucose meter strips. And that is quite interesting. D-Pocket, the size of a mobile phone, you can carry it around. D-sensor, integrated sensor that can be built into a wearable device such as a watch. So many of them are getting integrated or built into an already existing smartwatch. And this is LifeLeaf from Life Plus, Apple Watch. So almost all of these are similar to a smartwatch, and they are developing a sensor. You can see the sensor over there, which could fit inside the smartwatch band to monitor the glucose levels. Another one, the Novio Sense, where the sensor is placed underneath the lower eyelid. And from there, it is wirelessly sending the glucose numbers to the smartphone. All of them are quite promising, very exciting, and very interesting. However, currently in the market, if I am to discuss about the advanced hybrid closed loop systems, because all of these are dependent on the continuous glucose monitoring devices, basically. So you have the 3 devices which are very popular: 780G, Tandem, you have the Control IQ, and then you have Omnipod 5 as automated insulin delivery devices, of which 780G has become a revolution in India. And this has been something which is probably much sought of nowadays. And this is truly a dream come true for most of the type 1 subjects and also difficult to treat type 2 subjects. What is special about 780G? Currently, 780G is meant to automate basal levels. So basal insulin keeps on changing every 5 minutes in response to the continuous glucose sensing from the Guardian Connect. And the bonus is also delivered. That is something which is very special with 780G. If the person is not delivering the right bonus before a meal, then the bonus is also delivered automatically. Every 5 minutes, if the integrated algorithm determines so. The algorithm is a proportional integral derivative algorithm. And these are the components of 780G. If you look at the real world experience from across the world, including India, India has been recently added on to this. Almost every person on an average is reaching 76% time in range. Remember, the international consensus and the American Diabetes Association and the ATTD recommends only up to 70%. And anything above 70% is well and good. And here, with this automated insulin delivery device, you are already able to reach 76% time in range. And this is a response from one of the initial patients. He's a 22-year-old boy with type 1 diabetes for many years. And according to him, this is the first time he has slept peacefully during the night in the last 16 years. And he's thanking 780G for this achievement. And you have to do manual programming. And this requires training for quite some time. You have to manually, you have to go for the glucose targets, 100, 110, and 120, and you have to probably achieve a better time in range with no time or minimum time below range. And there you have to again go for a manual setting in the active insulin time. And this is a screenshot from one of our patients where the automated boluses are also being delivered. And this is at 4 a.m. in the middle of sleep. 0.2 units is delivered automatically. And this keeps on getting repeated whenever it is required. And no wonder most of the patients in India on 780G are able to achieve a TAR between 95 and 100%. You know, these are the components of an automated insulin delivery device, and we are very near to closing the loop. We have reached stage 4 of automation, and stage 5 will be unannounced meal. Stage 6, we don't know whether it will be required or not, and that will be a multi-hormonal system. And after waiting for more than half a century, the patients themselves have started innovating. And this has resulted in, culminated in do-it-yourself artificial pancreas. And if you are enthusiastic in assisting your patients, I will request you to go through this review article. And this is an extensive review on how to create an artificial pancreas. And this review has been referred to, this review from India has been referred to by the ADA, EST, and even ACE in their clinical practice guidelines. Of course, this is going to be the future. If the technologies and the companies and the pharmaceutical device manufacturers are not going to do this, the patients are going to do this. Because with these DIY, they are capable of safely reaching, many of them are capable of safely reaching a TAR and maintaining it at almost 100% all the time. Yes, 100% all the time. And that's the reason why the American Diabetes Association has stated, even though this is not regulated, not approved, the doctors should know how to troubleshoot and assist if the patients are requesting so. The major challenge with the use of insulin pumps, whether it is a tethered insulin pumps, whether it is do-it-yourself or with the patch pumps or with automated insulin delivery devices, you need to change the infusion set once in every 3 days. The infusion set reactions are also very common. Medtronic has come out with a solution, a reservoir and infusion set for extended wear, lasting for 7 days, and they are also working on combining the infusion set with a sensor and with 4 easy steps of insertion, very easy, virtually painless, much more user-friendly compared to the commonly used Quicksand. What is next? The next in technology in automated insulin delivery will be unannounced meals, where there won't be any necessity for carb counting. There won't be any necessity for even bolusing before a main meal or before a snack. And this is the New England Journal of Medicine, which has published this clinical trial a week ago. And this is again with islet, the bionic pancreas. And this particular study was based on insulin-only system where they have compared with the conventional delivery systems, including some of the sensor augmented pumps, with iLet, where only the body weight need to be entered and the rest is completely automated. It has resulted in almost 20% improvement in the percentage time in range. And this is the way forward. Another algorithm, this is a Rocket AP algorithm, where they have compared against Control IQ for unannounced meals without any bolus. The system itself is bolusing by its own. There is an 83% time in range. Amazing, amazing. So this is my concluding remark. Diabetology 4.0. Technologies, when compared to the medications, are advancing at a rapid pace. Both the physicians and the patients, we need to cope up with the transforming technologies. And this is for our survival and for the survival of our patients. Absolutely required. Thanks. Thank you again, my dear friends, for your patient hearing and for this opportunity.
So thank you very much, Dr. Jyotide, for that fantastic peek into the future also. Sorry, I thought Dr. Maria.
No, you continue.
Yeah. So what actually, I mean, again, a part of precision medicine, and it seems so fascinating that what was like almost science fiction is now becoming a reality. And in times to come, obviously, somebody who's not updated will slowly get phased out. And these are things, including the fascinating peek into the things like bionic pancreas, are what was just a kind of a, almost a hypothetical situation is becoming a reality. So let's see how time evolves, and it's really fantastic, sir. The presentation was fantastic, and to know, to have so many things in our armamentarium in the future would be really something which we would be, how do I put it? Looking at the technology, the way it is evolving, it's really a fantastic step forward. Thank you so much for putting it across.
Thank you, all the speakers. I'm told by Dr. Chawla that Dr.
One quick question, Dr. Jyotidev, sir.
Dr. Shalini, yes.
Sir, with so much of technology, everything happening on its own, algorithms coming in, machines coming in, where does the human physician fit in? Where does the human diabetologist fit in? As it is, you see a lot of type 1s, once you put them on the pump, you teach them the sensors and everything, and they'll disappear. They don't want to come even for a review. They'll turn up once in a year or something because, they feel type 1 management is just about controlling sugars and increasing the insulin doses. And once the pumps take over and, with bionic pancreas right there, is it time for the diabetologist or the endocrinologist to actually take a step back?
Never. And
Exactly.
Dr. Shalini knows the answer very well. And the technologies are never, ever a replacement for doctors. It will never be. And artificial pancreas might control the glucose, but still you need to troubleshoot. And there'll be a lot of other complications which can happen. And in diabetes, we know it is not just control of glucose. There are multiple other factors, including emotional factors. And the doctor's role is pivotal. And having you experience patients coming back after 1 or 2 years managing on their own, they come back with a complication.
Yes.
They come back with an emergency. So, and the same has happened to radiologists. The AI powered for CT scan reading, for MRI, for retinogram. But the doctor's role is pivotal. But I believe that with the help of technologies, ultimately our work, we will feel more satisfied. Because currently, maybe if you look at an average, only 10 or 15% of the patients will have good control of diabetes. And almost all of them are developing complications. But eventually, when you're integrating with some of those best of technologies, not all the technology, you need to be very choosy in adopting the technologies. Ultimately, both physicians and the patients will be satisfied.
I think, Jyoti, you very rightly said, technology is evolving very, very fast. Until unless we keep pace with technology,
very important.
We may fade away. But
I think
your clinical prudence will stay till last. There is no match for your. So technology will come, go, evolve further, but it is finally your clinical prudence which will stay till the end.
Absolutely.
Like my professor used to say, is the man behind the machine and along with the machine.
It's
Without the proper man, nothing fits in, sir.
Absolutely, absolutely. I think as physicians, we all need to keep pace with technology, learn technology, do not depend on technology blindly. But then, yes, we need to master the technology, learn the technology, and move with the times. Thank you so much, sir, for that excellent
Thank you,
presentation.
Jyoti. Thanks a lot.
Really
With that, we can close the session.
Last session, which is a key
Thank you
lecture
so
by
much, sir, for inviting
Professor
us. Thank
Dandona.
you.
Thank you so much.
I
Thank
think
you,
all
sir.
of us, we have been looking forward to Professor Dandona's keynote lecture, and I'm sure he's a mentor to all of us. He needs no introduction on any platform, national or international, but I think still just to complete the formality, Professor Dandona is a distinguished professor of medicine and at Jacobs School of Medicine and Biomedical Sciences at University of Buffalo, what is known as popularly as Sunny Buffalo. He's a founder of Diabetes and Endocrinology Center of Western New York. He has been recognized as one of the world's leading expert in treatment of endocrine disorder, especially diabetes and obesity and vascular diseases. And he has the largest academic endocrinology center in upstate New York. He has a huge CV. I'm sure if I keep reading, it will finish his entire session. So without wasting much of time, I'll request Professor Dandona to deliver his keynote lecture. And to us, he has always mentored to me. He is the one who got me into the field of diabetology as early as 2000 when I visited him for a brief fellowship with him. Dr. Dandona, please. Sir, Dr. Dandona, please.
Hello, Rajiv. Hi.
Good evening,
Good morning.
sir. Good morning for you. Yes,
Morning,
sir.
good evening. Yes.
We cannot see you, sir. Your video is
Must
off.
be early morning at your place, so please.
So you will be moving my slides for me?
Mahima? Yeah. Mahima,
Yes, sir.
please.
महिमा अपनी महिमा दिखाइए. हाँ.
Yeah.
चलिए. So today's topic is something that I have sort of nurtured in my mind for a long time, to call insulin a vascular hormone. And although we think of it as a metabolic hormone, and that's what it is till now, in fact, our work has, and along with the other data that I'll present to you, clearly it is a vascular hormone as well. So it may sound like a challenging topic, but I hope that by the time I'm finished, I've convinced you that it is a vascular hormone as well. So next slide. Can you move the slide, or can I? Yeah. So before, no, go back, please, to the original one. Yeah, leave it there. Now, before I go on to this slide, I need to give you a little introduction. That in 1976, Page and Watkins at King's College Hospital, London, had shown that if you give insulin intravenously, even in small doses, in patients with autonomic neuropathy, you get hypotension. Now, this is a very important observation because on the one hand, of course, autonomic neuropaths have a dysregulation of their autonomic nervous system, and they cannot compensate for changes that occur. But on the other hand, you have a situation where a administration in this kind of setting of insulin caused hypotension. So that is the beginning of the story. And taking that story ahead, as I'll show you in a while, Alan Barron in Indianapolis went on to show that if insulin is given systemically, that it increases femoral blood flow. So clearly, there was evidence that insulin may be a vasodilator. But what I'm showing you on this historical picture, published in Hypertension in 1995, is the fact that it's a direct action. So this is on the left, the cephalic vein at the wrist in an ultrasound picture. And you can see its normal circumference. If you increase the blood pressure, put in a blood pressure cuff on the arm and increase the pressure, you can see in panel B that it dilates. Then if you infuse norepinephrine in the panel C, it vasoconstricts. And then when you co-infuse with insulin, the vein dilates. And this occurs within seconds, within minutes. So clearly, this was the first evidence that the vasodilatory effect of insulin is direct one on the blood vessel itself. And as you can see, the first author on this paper was a guy called Anil Grover, who was working with me as a fellow, but he then finally ended up as the chief of cardiology at PGI Chandigarh. Next slide. Now, you can see here the dose-dependent vasoconstriction in blue with norepinephrine, and then you see dose-dependent vasodilatation with co-infusion of insulin at various doses. So clearly, there's a nice dose-response effect, and you can finish this experiment in about 2 hours. Next slide. Now, the next very important observation here is that if you co-infuse methylene blue with insulin, you get rid of the vasodilatory effect. So you see the vasodilatory effect in the middle, but then it vanishes when you co-infuse methylene blue. And methylene blue is a nitric oxide synthase inhibitor, and it also absorbs nitric oxide. So clearly this vasodilatory effect is due to nitric oxide. Next slide. And here, what you're seeing here is that in type 2 diabetics who are insulin resistant metabolically, you can see that in terms of vascular pathology as well, or vascular biology as well, there is insulin resistance because they do not respond adequately to insulin in terms of vasodilatation. Next slide. And impaired glucose tolerance, again, associated with insulin resistance, you got impaired dilatation with insulin. Next slide. And here, what we are showing is that if you co-infuse sodium nitroprusside with norepinephrine, you do get a vasodilatory effect. And as you know, sodium nitroprusside is a vasodilator, and it generates nitric oxide from its own molecule. So clearly, another proof that it's NO-mediated. Next slide. And then in African Americans also, we found an impaired response. And as you know, African Americans do tend to have more insulin resistance than the white population in the United States. Next slide. Next slide, please. Yep. And now here is go back. Yeah. So here is a study showing that in the skeletal muscle, also the vasodilation is nitric oxide dependent and is insulin mediated. So if you have insulin, you get vasodilatation and increase in flow. But if you have insulin resistance or you block the NO release, you do not get vasodilatation. Next slide. And here is a very important experimental animal data. So this came from Joslin Clinic, where they caused a block in insulin responses by taking away the insulin receptor. They created an insulin receptor knockout animal. And in this animal, if you have an ApoE negativity, which is the standard way of doing producing atherosclerosis by knocking out the ApoE. So in this ApoE knockout animal, the removal of the insulin receptor from the endothelium led to more marked atherosclerosis. And as you can see in the graph at the bottom, there's a marked difference in the area involved in atherosclerosis in these mice. So clearly, insulin is not only vasodilatory, it is also anti-atherogenic. Next slide. And here are some further experiments from my own lab, which is working with endothelial cells in culture. And here you're seeing the endothelial cells characteristics. They're stained for factor VIII, they're stained for CD31, and they stain for endothelial receptors EN4. And of course, there are some negative controls, alpha-actin, which is negative. And next slide. Next slide. So in this kind of preparation, people go back. Yeah, that's it. Leave it there. Zheng and Kwon published a paper soon after our discovery of vasodilatory effect of insulin and showed that these cells will release nitric oxide if they are incubated in insulin. So clearly insulin is a nitric oxide generator. Next slide. Next slide. And here is an experiment for our own lab showing that the enzyme that makes insulin, makes nitric oxide, eNOS, endothelial nitric oxide synthase, is increased in a dose-dependent fashion when incubated with different doses of insulin. You can see the Western blot on the left, and you can see the graphic histogram on the right. Next slide. And then also here we are showing that ICAM1, which is a pro-inflammatory adhesion molecule, is inhibited by insulin in a dose-dependent fashion. Again, the protein stain on the left and the histogram on the right. Next. And again, RT-PCR, you're looking at the mRNA now, and again, there is a dose-dependent inhibition of the mRNA of ICAM1, which is a key pro-thrombotic and pro-inflammatory molecule involved in atherosclerosis. Next slide. MCP1, which is a major chemokine involved in atherosclerosis as well, and in the movement of the monocyte from the blood circulation into the endothelium. And this key chemoattractive molecule, MCP1, is also inhibited by insulin. Next slide. And then the key transcription factor that causes inflammation, NF-kappa B, nuclear factor kappa B, again in the column stains on the left, you can see a dose-dependent inhibition, and here again on the right, histogram showing you the dose-dependent inhibition. Next slide. And then this is another very important observation, that if you take the pro-inflammatory cytokine TNF-alpha, which is involved in all kinds of inflammations, including atheroma, you get an inhibition of eNOS, the enzyme that makes nitric oxide. Next slide. And here you see effect of insulin on the nitric and eNOS on the top. And then if you co-incubate TNF-alpha with it, the effect is inhibited. Next slide. Next slide. Move on to the next slide. This is a repeat. Sorry. Again, this is a repeat. Sorry, I don't know why this repeat is good. So move on to the next slide. Yes. And now what I'm showing you here, go back. Now what I'm showing you here is the basic model of inflammation. And if, say, for example, endotoxin arrives at the surface of a mononuclear cell or a monocyte, it binds to the receptor, TLR4, and then triggers a whole lot of changes. And amongst the changes are I-kappa B kinase phosphorylation and degradation, and the NF-kappa B, which is bound to I-kappa B and is held in the cytoplasm otherwise. But once this degradation of I-kappa B occurs, NF-kappa B moves into the nucleus and sets up the activation of over 200 pro-inflammatory genes. Next slide. And here you see the same sort of experiment that we tried in the human in vivo. So this is the first observation, and for this experiment and publication, we got a prize from the Endocrine Society. And you can see with the infusion of insulin in obese insulin-resistant people, as you build up the insulin concentration over 4 hours, and then you stop at 4 hours and the concentrations come down on the left. And then during this time, we maintain the glucose concentrations the same, unchanged. Next slide. And here you can see the production of reactive oxygen species, which are part of the inflammation, being inhibited within 2 hours of insulin infusion. So it's a very rapid acute effect of insulin on oxidative stress and inflammation. And as you stop the infusion at 4 hours, it bounces back again. Next slide. And here you can see the key subunit of the NADPH oxidase, which produces the superoxide radical, which is a reactive oxygen species member. And you can see the pre-47 key protein subunit being inhibited by insulin as well. Next slide. And here is NF-kappa B binding being inhibited by insulin in a dramatic fashion. Next slide. And I-kappa B alpha levels increase. So the protein that is preventing NF-kappa B to move into the nucleus is actually increased while NF-kappa B is inhibited. Next slide. So this then took us to doing some experiments on cardioprotective effects of insulin. Next slide. And here is a group of patients with ST elevation myocardial infarction, where we infused insulin at a rate of 2.5 units per hour with the right amount of glucose to maintain euglycemia. So you can see the glucose concentrations remain constant. Next slide. And during this period, insulin concentrations increased over a period of 48 hours while the patients were in the coronary care unit. Next slide. And here you can see that C-reactive protein concentrations was significantly diminished by about 44% with insulin, and PI1, which is an agent which inhibits fibrinolysis, was also suppressed. So insulin would be potentially increasing fibrinolysis. Next slide. And with this, interestingly enough, the patients who got infused with insulin got a reduced size in CKMB increase. In other words, the myocardial death was significantly diminished. Next slide. Next slide. And here, somebody in Visser et al. In Holland then repeated this experiment on patients undergoing cardiac surgery. And they again demonstrated that with infusion of insulin, you reduce the CRP levels. Next slide. And then comes a very interesting experiment. And these pictures that I'll show you, the histology is really exciting here. This is a paper from Marfella et al. From Naples in Italy, where they followed our protocol and gave insulin to myocardial infarction patients. But these patients on the initial angioplasty did not respond, so they had to have cardiac artery bypass, coronary artery bypass operations done. So let's show you the data. Next slide. And in it, you can see that with the intensive control with glucose, you had not only a fall in glucose concentrations, troponin levels had come down, and infarct segment length had diminished, wall motion scores had improved, and ejection fraction had improved, and myocardial performance index had improved. Next slide. And here what you see is actually, and this is something really amazing that these people did, they took myocardial biopsies from patients with infarcts in the infarct area. And you can see here now in the two sections to compare are those with controls on the right, where there was no significant infarct, but once you had the infarct, you see the middle panel where the infarct and lack of insulin led to inflammation, whereas an increase in INOS and nitrotyrosine, whereas insulin infusion significantly diminished these indices. So clearly insulin was effective in protecting the myocardium. Next slide. And here you're looking at, again, pro-inflammatory genes, CD3, which is an index of monocytes, CD68, which is an index of macrophages, and HLA-DR, another pro-inflammatory index. You can see that between the middle panel and the panel on the left, marked diminution with insulin infusion. Next slide. And caspase-3, which is the caspase which is responsible for actually destruction of the cells. You can see how heavily stained it is in the middle panel, and then with insulin infusion, it's markedly diminished. So clearly, insulin not only is a vascular hormone, it's a myocardial hormone as well. But myocardium, as you know, is an evolved part of the blood vessel itself. So there are diffuse actions of insulin in vasodilatation, in anti-inflammation, and of course, in terms of infarction, protection of the myocardium. Next slide. Again, same thing, further repeat. You can see further changes consistent with what I was talking about. Next slide. Next slide, please. Yep. And then there is the study from study showing that if you start infusing insulin in myocardial infarction patients in the ambulance itself, rather than waiting to get to the hospital, it's a beautiful study carried out from the Boston University Hospital in Boston, and showing the difference in controls versus insulin. So those that got infused with insulin, their cardiac arrest and death was significantly lowered, less than half. Next slide. And of course, infarct size also markedly diminished. Next slide. So basically then, what I want to conclude for you here today is the fact that insulin is a vasodilatory hormone. It is an anti-inflammatory hormone. It is an anti-atherogenic hormone. And we still need to do large studies on acute myocardial infarction to confirm these data. And there is a lot of animal data that has also collected during this time, which show that cutting out the insulin receptor, whether it is in the endothelium or in the myocardium, leads to vulnerability of the animal to atherogenesis and to myocardial infarction. So thank you very much for your time and attention. If you have any questions, please ask, because a lot of it is experimental data and you may not be very well conversant with the molecules I was talking about.
Mohammed, if you're logged in, I'll like to have your comments and some interaction.
Dr. Maria has a question. Dr. Maria has a question.
Yes, sir. Yes, sir.
Sir, please unmute yourself.
Muted.
So I just want to know that in a patient who is insulin resistant, in which the PI3K kinase pathway is selectively or resistance in this pathway, and the MAP kinase pathway is not inhibited, what would be the effect in a diabetic who's insulin resistant if you give the extra dose of insulin on these so-called vascular effects?
Because very good question. And I think I've answered it already well in my description, but I'll say it again. I told you that the very first experiment we did on the anti-inflammatory effect of insulin was in obese patients, deliberately done that way, to show that you can overcome the insulin resistance by infusing insulin at the rate of 2.5 units per hour, which gets you a concentration of around 60 to 70 microunits per ml, which is about twice or 2.5 times the normal concentration of insulin. So insulin resistance is there, but once you give enough, you will be able to surmount it. And of course, as we know, most myocardial infarction patients are insulin resistant patients because either they are obese or they've got diabetes or they are insulin resistant on their own. So it works even in the resistant group. And of course, our experiment was limited to 35 patients, whereas the Selker experiment from Boston involved hundreds of patients. And what they did, which was more clever than we did, we started infusing insulin once the patients came to the hospital. But Selker started infusing insulin in the ambulance itself so as not to lose time.
Right. Thank you, sir.
Thank you very much, sir, for a very, very lucid talk and awesome oration as always. And I'm happy that tomorrow again, same time, we are going to have you for another keynote address on hypogonadotrophic hypogonadism and diversity, a topic which is very, very close to your heart. So thanks a lot. Wonderful. I think it must be an early morning at Buffalo.
No, it is not. It's about 11:30 now, so it's not that
11:30. Okay, 9 o'clock. Okay, yeah, it's all right. But even
but tomorrow, tonight we are changing the time, so it'll be for me an hour earlier tomorrow.
Yeah, it will change tomorrow. So tomorrow again, same time, we'll have you for another keynote address in the evening. Thanks a lot, sir.
Well, thank you, Rajiv, and thank you, Shalini.
Thank you, sir.
Pleasure having you here, sir.
Happy to share with you that even at this dinner time, 9 o'clock, we have close to 900 logins still there for you to listen. So it was wonderful listening to you.
Everybody loves learning from you, sir.
Yeah, so I'm sure
thank you. So kind
tomorrow
of you.
Also we'll have more logins.
I'm
and people
sure.
will be absolutely glued
and
to
tomorrow being Sunday, I'm sure we'll have
it will be even
a
much
larger number. Today was a Saturday night.
Yeah, you see, today's talk is, of course, it's related to myocardial infarction to some extent, so therefore practical, clinical. But tomorrow's is a very practical.
Absolutely.
I'm happy to see that 2004 circulation data, which was done when I was there, Chaudhary, and you did that wonderful data. Post-MI insulin infusions. I remember that data which got published in Circulation 2004.
Okay, good. Thank you, Rajiv, and thank you, Shalini.
Thank you so much, sir.
Good night, sir. Bye-bye.
Honor having you.
Sir.
Thank you.
Always an honor to have you with us. Thank you, sir. Good night. Stay healthy.
So see you tomorrow.
Yeah.
Sure, sir. See you
we
tomorrow
still have
then.
Session going on in another hall, so we'll
So we'll wind up here.
Switching on to that and wind up this hall as for now.
All the
Before
delegates.
I end, I must say that the presentation by Dr. Kesavdas was
wonderful.
amazing.
Awesome.
He's
This is
the
a
man,
futuristic
the technology man in this country. Man known for his technology I'm in touch. He's the man, actually.
Amazing. Yeah.
So
Okay, then.
all the
See you
delegates
tomorrow.
who are still logged in, please join us tomorrow at 10:30 a.m. sharp. Both the halls will be working since 10:30 a.m. till 9 p.m. tomorrow, when we'll again finish with Dr. Danona's talk.
Dr. Hasnan, any last
Dr.
words?
Hasnan is there, yeah. I just called him. I thought he is. So, Dr. Hasnan, please
Sir, you
unmute
muted.
yourself.
You muted.
You're muted. Muted, yeah.
I just don't know how I manage to stay following for all these hours. It's down to the quality of the sessions. Thank you all very much.
Wonderful. So tomorrow morning, again, 10:30 a.m. India Standard Time, we are starting, and we'll finish with keynote address by Dr. Dandona again at same time tomorrow. Tomorrow, your session is there, but in any case, try to find out some time so that you are there in between also. Dr. Colin is there. So many good lectures tomorrow. Thank you. Thank you, Mom.
Thank you, everyone. Good night. So
wonderful
just
for your
requesting
all
everyone to be here sharp 10:45 a.m. tomorrow morning when we start. Thank you so much. Good night.